I think we are live. Shall we start?
Sure.
Okay, I think you can close this. Stop sharing. I would start. Uh, Good afternoon, everybody, and welcome to this day's feast of academic events. And some questions were raised: why a talk or a session, 1 hour session on heart failure in a predominantly diabetology meeting? And we were just going through our audits of this year. And when we audited the patients who had acute myocardial infarction, what we found that more than 80% of the patients had diabetes. And when we audited the patients with heart failure, more than 90% of the patients had diabetes. And we all know the not so new dictum or the rule that about 70 to 80% of diabetics die of heart disease. But the common thought process, a common paradigm, what people think is that diabetes is a coronary equivalent or heart attack equivalent, by the Hafner's paper way back in late 90s, 96. And even when I asked my registrars or fellows, what is the commonest cause of death in diabetics, invariably the answer will be acute MI. But we have to understand that heart failure is becoming more common and it is more lethal than acute MI. For example, somebody who comes with an MI in India, there have been registry data, and their 1 year survival or 1 year mortality would be around 5%. There have been some registries which showed that like 1 year, 5 year survival of 7.5%, but we can say around 5 to 10% is the 1 year mortality. But 1 year mortality with heart failure is about 30%, 3 times more or more. So we have to know about it because the most of our patients, especially with the diabetic background, will die of heart disease. And it may not be MI, it may be the post-MI sequelae and heart failure, which is the cause of this mortality. And we have to move away from this siloed or compartmentalized approach. And now is the time for metabolic, cardiac, renal medicine, or where all the specialities shake hands with each other and strive together for the benefit of the patient. So for that, we have chosen today for this panel meeting. The topic is the latest heart failure guidelines from the ESC, and it's very important. We have to diagnose and manage. And with that, for that, we have two of very eminent colleagues or specialists in the field. Dr. Kohli is from Delhi, is a gold medalist, and he mixes the unique features of experience, expertise, and clinical excellence. So experience, expertise, and excellence are 3 E's. And he is an internal medicine specialist, and he will give us the perspective from internal medicine point of view. And from endocrine point of view, we have Altamash Sheikh, who is a very dynamic endocrinologist from Mumbai with multiple kudos on his credit academic. So the agenda would be, I would say, few introductory sentences, and all the panelists have been kind enough to share the slides with me. So to save time, I would be there are certain questions. There are 7 burning questions, and I would ask each of them, and I would share the slides so that the time can be saved. So the topic for today is impact of ESC 2021 guideline on diagnosis and managing heart failure with reduced ejection fraction. This came in August 2021. And why is this so important? because health professionals, as I said, should move out of their silos. And we have to help our patients because the most diabetics die of cardiac related problems. Most of these problems may not be the acute MI. The survival after MI is quite good, but heart failure, the survival is still very bleak and it is worse than most cancers. So these guidelines keep on changing. There is a universal diagnosis of heart failure. The American one is coming soon, but Canadian ones are there. But European guidelines uh, is arguably the most balanced of the guidelines. And most of the Indian guidelines are very similar to European guidelines. So these guidelines focus on the diagnosis and management. And they looked at the latest available data, and all the experts are signed. There is no disparity or incongruity. And there are many new concepts. And the, the new concepts included the change of the term mid-range to mildly reduced, new simplified treatment algorithm, addition of a treatment algorithm according to phenotypes, modified classification for acute heart failure, updated treatment for most non-cardiovascular comorbidities, including diabetes. And this is mostly a diabetic meeting, so it's very important. And something about genetic testing and key quality indicators, that's also very important. So for a quality indicator for a primary care physician is broadly it's the quantity of life, quality of life, or both. The patient says that I am miserable, but my sugars are controlled. It doesn't mean a thing either for the patient as well as the doctor. And vice versa, if as a cardiologist, I say I don't have angioplasty, the stents are fine, and take the medicine, but the patient is miserable or the sugars are not well controlled, then again, the quality indicator, the quality of life indicator is important. So these are the plans. So there are we have selected about 7 key questions, and the 7 key questions include what are the key steps to diagnosis of heart failure, diagnostic algorithm and T-proBNP, challenges in diagnosing, what is the general principles, patient without diabetes, which therapies are recommended, because that is very important again, and with patient with therapy or diabetes, what are the heart failure therapies recommended, what would be your recommendation in view of ACC 2021 guideline and ACC 21 guidelines. All this will be discussed. So my first question to Dr. Kohli is, what are the key steps in the diagnosis of heart failure? So I will share the slides. Dr. Kohli, welcome, and thank you for joining in this very, very important session.
Good afternoon, Mr. Chairman, and good afternoon, dear friends. So they have aptly chosen a physician to talk about the initial diagnosis of heart failure, because it is often the physician who is approached by a patient of breathlessness. And most of the diabetics are also seen by a physician rather than an endocrinologist. So I think we should be trained in the diagnosis of heart failure, because missing a diagnosis of heart failure can prove disastrous for the patient. As our chairperson has already pointed out, the mortality is so high even with treatment. 50% of the patients of heart failure die within 5 years. And we should not forget that it is not the myocardial infarction which is the first manifestation, cardiovascular manifestation in a diabetes, but it is the heart failure. So we should be trained, and we should train ourselves to be able to diagnose. Can you go to the previous slide, please? Yes. So as with any other disease, the first step in the diagnosis of any disease are symptoms and examination or signs. But here, the problem with heart failure is most of the symptoms of heart failure are shared by other diseases, especially the pulmonary diseases. So there may not be any specific symptom in case of heart failure apart from breathlessness. And signs are also harder to detect because signs like elevated JVP and displacement of the apical impulse are specific, but they are harder to detect. So we may miss the diagnosis when we rely purely on symptoms and signs. So we have to take the help of various investigations to be able to diagnose heart failure. Next slide, please. So, so coming to the classical symptoms in a heart failure. So these are the three classical symptoms, which are breathlessness, fatigue, and swelling of the ankles because of the water retention. But they alone are not sufficient to make the diagnosis of heart failure because they can be seen in many other diseases. Next, we'll see a group of typical symptoms in heart failure patients, and we are all aware of it: breathlessness, and especially orthopnea. When the patient lies down, he feels more breathless. Then history of paroxysmal nocturnal dyspnea. So orthopnea and PND point towards a diagnosis of heart failure. Then patient gets tired easily. So there is a decreased exercise tolerance and he feels fatigued very easily. And there is swelling of the ankles. Less typically, you may get cough at night. There may be little wheezing, loss of appetite, palpitations, or syncopal attacks. Regarding the sign on examination, you may find elevated JVP. There is a hepatojugular reflex. You may hear a third heart sound, and there is laterally placed apical impulse. Apart from that, you may find both weight gain because of the water retention or even cachexia because of the tissue wasting. And you may see some murmur and peripheral edema, and chest examination may reveal crepitations and pleural effusion. And there is tachycardia and tachypnea. Apart from that, in severe cases, you may find hepatomegaly and ascites. Next, please. So, apart from these signs and symptoms, I told you we have to take the help of certain tests. And the most important simple test available in our practice is electrocardiogram or ECG. Usually, ECG will show some changes in cases of heart failure, and these changes may be changes of ischemia, changes of LVH, and changes of arrhythmia. But you may also require the help of natriuretic peptides in the diagnosis of heart failure if they are available. So a plasma concentration of BNP less than 35 picogram or anti-pro BNP less than 125 or MR pro ANP less than 40 makes a diagnosis of heart failure unlikely. So you can rule out at heart failure by measuring natriuretic peptides. Then apart from these two tests, we have to do some basic investigations, and very important, and don't forget hemoglobin. If the patient is anemic, he is more likely to go into heart failure. Then kidney function tests, urea, creatinine, and electrolytes. Then we have to also rule out any hepatic involvement and thyroid function test, because thyroid hyperthyroidism can also lead to this. Next, please. And they can also guide our future therapy. So apart from these basic tests, now we have to go on to do an echocardiography in all these patients. It is the key investigation for the assessment of the cardiac function because it measures the left ventricular ejection fraction, and then we can categorize our patients into HFrEF, HFpEF, or HFmEF. Then we need a chest X-ray from 2 points of view. First, to rule out a pulmonary cause of the breathlessness, we may rule out a pneumonia, a pleural effusion, or pulmonary artery hypertension. And in heart failure, you may find pulmonary congestion or cardiomegaly. Next. So this diagram beautifully shows the algorithm for heart failure according to ESC 2021 guidelines. And this is when a patient comes to us with symptoms and signs suggestive of heart failure, that is breathlessness, orthopnea, or paroxysmal nocturnal dyspnea, and with an abnormal ECG. What should we do first? If the facility is available, we should get natriuretic peptides. If the anti-pro NBP is more than 125 or BNP is more than 35, I think we should go on to next step, that is echocardiography. Or if this is not available or we are suspecting heart failure, straight away we can go to echocardiography. If it is abnormal, we have to categorize our patients. As I told you, if it is ejection fraction less than 40%, we'll call it HFrEF. If it is between 41 to 49, it is called, now it is the terminology has been changed. It is now HPMRF. And if it is more than 50, we call it HFpEF, that is with a preserved ejection fraction. Next, please. What if a new patient of heart failure comes to us? How will you work it out? Again, when a patient comes to us with sudden breathlessness, more on lying down, we should take a proper history, find out the risk factor in that patient, whether it is hypertensive, diabetes, or history of any ischemic heart disease. And then we will do these following tests: ECG, do a pulse oximetry, echocardiogram, chest X-ray, and other evaluation, and then go for a natriuretic peptide testing. If the BNP is less than 100 and NT-proNB less than 300, MR-proNP is less than 120, I think the chances of acute heart failure are almost ruled out. But if these figures are high, BNP is more than 100, NT-proBNP more than 300, and MR-proANP is more than 120, chances are that it is acute heart failure, and you treat that patient accordingly after doing the echocardiography. I think so. I think that sums it all. We need to have the symptoms, signs suggestive of heart failure, and this has to be supplemented by natriuretic peptide testing, ECG, chest X-ray, and of course echogram, which remains the cornerstone of diagnosis. Next, please.
Thank you very much, sir, for the wonderful exposition. And from his beautiful talk, we have to understand that medicine is an art. We have to suspect heart failure because many times if the doctors do not suspect, they will not look for it. And you would have seen from his the flow chart that these are not very expensive investigations. Even echo is not a very expensive investigation. NT-proBNP is not a very expensive investigation. And they should be part of that because each hospitalization for heart failure, people have to spend lakhs of rupees. And not only that, each hospitalization will take away not only the quality of life, many years of life from the patient. That brings us to the next question because Dr. Kohli has mentioned from the guidelines that NT-proBNP is recommended prior to echo. What is your view regarding the same? So I would put forth my views. And first of all, it's like in India, NT-proBNP is sadly not done enough. It partly is because of non-availability, but it is not a very expensive investigation. And many places, the cost is somewhere between 500, 500-ish. And it's available, but we don't ask for it. That is the most important thing. And it gives us a good clue because sometimes another important point is that patient may come with an echo some time back. It may show an ejection fraction, say 55 or 60, and he has got breathlessness. And sometimes we may not even repeat, but then NT-proBNP may give a clue, especially in mildly reduced and heart failure preserved ejection fraction. It clinches the diagnosis. So the ESC guidelines are very clear, and look at the level of class of recommendation for NT-proBNP. It's 1B. And it is even slightly higher than transthoracic echo and even 12-lead ECG because these are patients with heart failure. This is not patient with chest pain. And here NT-proBNP is very important because it can diagnose, it can prognosticate, and it can differentiate. And maybe it will give us a clue in phenotyping also. So they have recommended nitric peptides as initial diagnostic test. And it's, as I said before, it's good for prognostication. and it may guide further cardiac investigation. And as Dr. Kohli beautifully said, if it is quite low, we can even rule out uh, acute heart failure. Sometimes we have people with low ejection fraction coming with breathlessness or wheeze, especially these winter months, and they would be like treated with high dose of diuretics. But if somebody checks the NT-proBNP, it may be low, and then it will give a clue against. Even if a person was prior diagnosed to have heart failure, the acute deterioration may be due to something else. It may be due to sepsis, may be due to COPD, asthma. All those things, it will give us a clue. And most important is NT-proBNP because it is not affected by the other drugs like valsartan, sacubitril. NT, remember, like two values, 125 and 300. If it is NT-proBNP more than 125 in non-acute setting, acute setting more than 300, it gives us a clue. It is not sacrosanct. People with anemia, renal failure, other things also can have, but it will give us a clue. And echo establishes it finally. It divides. You can divide it into multiple categories, but NT-proBNP is also important. And so, as the person who is more bullish and being part of a lot of clinical trials in heart failure, and my clinical interest in heart failure, I use NT-proBNP very commonly. But Indian scenario is a little different because even the random heart failure registry and other registry data is sadly underused. And echo, like we actually NT-proBNP may be more available, but we rely more on echo. Echo is important, and echo is there even now in small and remote centers. So my advice or my take would be is use it in a balanced way. And NT-proBNP is underutilized, and echo maybe sometimes overutilized. You see a EF of 50%, then we don't think about heart failure at all. It's also wrong. So with that, I will ask the next question to the endocrine colleague, Dr. Altama Sheikh. What are the challenges in diagnosing heart failure in patients with diabetes?
Sure. Thank you for that question. Good afternoon, everyone. I agree with my previous, both the speakers and our moderator, of course. So what is more important is three things when it comes to heart failure and diabetes. The time that we catch these patients, we need to get these things early in time, early in when they present, maybe even before that in some patients. The second thing that is very important is the testing and the values of some markers, which we have seen in earlier slides, and I'll show you some more in detail. And number three would be what treatment strategies that we would be taking into. So importantly, each of these, whether it's just diabetes or the heart failure, each of these entity independently increase the risk of each other. And at times they may be just concomitant. 4 times more in women for increase of heart failure risk with diabetes, and prevalence also of heart failure 4 times more is there. Not only this, as diabetes we are seeing in younger population, even the risk of heart failure may be associated with in this population also. And as for each complication of diabetes, whether it's retinopathy, neuropathy, or a stroke, or an MI or atherosclerosis, we also have that each 1% increase in glycated hemoglobin will increase the risk of incident heart failure by around 36%, which is quite a huge number to look at. And I think we need to not just catch the people with diabetes early, but also of these abnormalities like heart failure early. And we are learning the screening test and above how we have the earlier two speakers have shown. What happens when there is a subclinical cardiac abnormality in patients with diabetes? So whether it is an age related issue, whether it's a calcium handling issue, or whether it's a fatty acid utilization, it's a mechanistic, it's a pathophysiology that we are looking towards. Is it really an autonomic dysfunction over there with a RAS activation, or is it an inflammatory dyslipidemic endothelial dysfunction which is causing coronary artery disease, and that may cause an ischemic cardiomyopathy, and the rest may cause a diabetic cardiomyopathy through fibrosis, and all the pathways finally then leading to heart failure in diabetes. Also, the presence of each of these abnormalities, as we see in this particular graph of pathophysiology, is associated with a symptomatic heart failure and mortality, and that's the death of the particular patient, which we do not want to happen suddenly. Patients without symptomatic heart failure often have subclinical abnormalities, and these changes may include, when you see on a 2D echo, it could be a LV dysfunction, it could be a LV mass increase, it could be relative wall thickness on a 2D echo, left atrial size, it could be a diastolic dysfunction, or an increase in extracellular volume or a fraction. These are those abnormalities that actually cause these mechanistic issues towards heart failure. And that's the reason I think we've been harping upon that it is the early diagnosis of heart failure in diabetes, which is very, very critical. And that was my first point that I started talking about. The next slide, we will show you that, yes, it is early diagnosis. That's very important. And immediate treatment can help the patient with delay or prevent the progression of this debilitating combo, because the high prevalence and significant morbidity and mortality of heart failure actually tells us that it's a compulsory thing. It mandates to have an early identification, maybe before time, for appropriate therapy. Moreover, most of the clinicians should not overlook diabetes patients with stable coronary heart disease. That's an important warning, underlining, or a red flag that the stable patients, if they're present with atypical symptom, they should also be picked up. That's a very, very important line. Recently, the ESC also has given chest pains as one of the short forms about how do you deal with these kind of symptom. And I think atypical, instead of atypical, they say use the word non-cardiac chest pain. And also importantly, 50% of people with left ventricular systolic dysfunction may have an antecedent to heart failure, remain undiagnosed and untreated. Similarly, we have the way we have 50% of people of diabetes remain undiagnosed for a long, long time till we have a screening test, or till we have an age-related screening based where then the data is upcoming. So early diagnosis, what are the component or challenges in diagnosis of heart failure in diabetes? Again, two important things: detection of abnormalities in the myocardium, exclude cardiomyopathy, other causes which could be contributory. These are two important clinical pearls that need to be looked into. And also, if you have lack of sign and symptom at an early stage from a clinical challenge point of view, and lack of any pathognomonic histologic challenges or changes or imaging characteristics which are associated with the diagnosis. So importantly, diagnosing diabetes heart failure in patients of diabetes require further testing. And I'm going to give two pearls again. One, a clinical careful history will detect the symptom. What would you look into? Already my previous speaker has shown, but I'll show you in one of the next slides. The dyspnea on effort, orthopnea, nocturnal cough or wheezing, easy fatigability, and nocturia should be taken into consideration, wherein 20% of those with ejection fraction of less than 40 do not report any symptom. And physical examination, no matter how skilled the examiner is, may not show signs of heart failure. That's again a very important line. No matter how skilled the examiner may be, this is because we are stressing upon this point, because it is humanly possible that even the best of the years or the stats may not be able to. That's why we may need a biochemical or an image to support the diagnosis at times, as we saw in the slides. That's why further testing, and importantly, the ESC guideline also talk about that does not have any specific recommendation, but look into the metabolic cause, look into the metabolic abnormality, which could be kind of a hyperthyroidism presenting with this, which could be a pheochromocytoma presenting with a cardiomyopathy. It could be a Conn syndrome of hypokalemia and high renin-aldosterone mechanism. It could be there, or it could be a Cushing syndrome presenting with diabetes and heart failure. So we need to have a widen spectrum. We need to think out of the box. We need to have investigations beyond the box of routine diabetes and heart failure when it comes to examples of presentation of endocrine diseases. And importantly, I think I would like to end by showing two more slides wherein our own associations of physicians of India have recommended an approach of heart failure in type 2 diabetes. Look into the history and physical examination, which is stressed upon by almost all the guidelines. investigations of serial assessment of resting ECG, urine albumin creatinine ratio, and EGFR, which all of us are doing it nearly in our clinics daily and should be considered in all the patients to help predict the risk of developing heart failure. Evaluate NT-proBNP, which should be considered to assess the probability of heart failure wherever possible, and of course confirm the diagnosis by a 2D echography, also to be done as a kind of an investigation to establish an approach to the diagnosis. And in one of my last slides, I'm going to show you now how the API has given us with a routine criteria of clinical ECG and biochemical albuminuria. If there is no assessment which suggests of heart failure may be unlikely. However, if there is more than one assessment suggestive of heart failure risk, then we should do a BNP. Here, the value they've quoted is around more than 125 picogram per ml. If it is not beyond that, again, heart failure is unlikely. But however, if it is present, then echocardiography to be done, and if that shows the signs of heart failure, then we treat accordingly in those lines. If not, if it is normal, then again heart failure is unlikely. It's quite an eased out statement and algorithm given by the API, and I think I would like to stop here and give it over to our moderator, Dr. Ruman.
Thank you very much for that wonderful talk. And it's important to identify early. And as was mentioned, like patient may deny symptoms, but when you go in depth, they'll say that, okay, I was walking 5 kilometers before, now I'm walking 2 kilometers. That also may be considered as a symptom. And most important take home from this so far is that mild symptoms do not in heart failure is not equivalent to mild disease, because class 2 or class 1 patients also die, but 10% of them may deteriorate annually, and in one third of them the first event may be sudden death. So mild symptoms is not mild disease. There is no mild cancer. There is no mild breast cancer or mild lung cancer. Similarly, cardiac failure has got higher mortality than most cancers, except for lung cancer. It has got higher mortality. So we should chase it aggressively, find it, and treat it. So that comes to the next question. What are the general principles of pharmacotherapy in heart failure with reduced ejection fraction? The answer is very simple. Like, for why do we treat as doctors? We want to improve the quality of life, quantity of life, or both. But in heart failure, is there anything more? First part is very clear, reduction in mortality. Second part is prevention of recurrent hospitalization due to worsening heart failure, and improvement in clinical status, that is functional capacity, quality of life. There is something more here, reduction in mortality, which includes sudden death, because sudden cardiac death is common in diabetics. You might have seen patients who would have come for your review. Patient was doing fine. He might have had a bypass or angioplasty, but overall everybody would have patted their shoulders and said, "You're doing well." Next week, the relative would come and say he suddenly died. Because patients with heart failure and also diabetes can die suddenly, and sudden cardiac death is more common in patients with minimal or no symptoms, and that is very important. So what are the guidelines? What does the guideline recommend? They recommend modulation of renin-angiotensin-aldosterone system and sympathetic nervous system, and ACE inhibitors or RNAs. ACE inhibitors have been there for a long time. Beta blockers have been there for more than nearly 60 now, maybe 60 years. But the heart failure aspect came only in the late 80s. MRS still there, very much there. The spironolactone is quite cheap, and they are the general foundations of pharmacotherapy. And when we talk about RNA, angiotensin receptor neprilysin inhibitor, it's a cornerstone therapy because, very simply, because on top of standard therapy, it showed a further 20% benefit. And that is humongous because we, in spite of lot of advances, our rate of improvement in the prognosis of patients with heart failure has not been very optimal. But last 5 years have been tremendously good because we have RNAs, we have SGLT2 inhibitors, and according to ESC, the triad of cornerstone therapies, RNAs, beta blockers, and MRAs, and with SGLT2 inhibitors, both DAPA and EMPA, or class 1 indication, form the foundational therapy. So the management algorithm is the RNAs or ACE inhibitors, but we know from data that the on in patients like against ACE inhibitors or enalapril, RNA scored in both mortality, morbidity, quality of life, and beta blockers, MRA, DAPA, and EMPA. If there is congestion, loop diuretics, and this is very important. Somebody is not congested. Somebody says he's not very much breathless. There's no evidence of congestion. There's no RAS. Then diuretics, especially loop diuretics, may not be of great benefit, and sometimes they will cause little harm also. But MRAs are of benefit. And EF of less than 35, QRS less than 130 milliseconds, and especially ischemic implantable cardiovascular defibrillator is very important. Another very under recommended modality in our country, in only less than 5% are recommended who really need it. That's very, very important. And if your QRS is more and if it's less than 35% CRT, that's more costlier, but very, very, very great effect. So fundamentally, foundational therapies are 4, the major 3 plus SGLT2 inhibitors, ICDs and ICD implantable cardiovascular defibrillator, and CRTs wherever appropriate. So that is the very simple, already it's been said, look at ejection fraction, look at the NT-proBNP, then EF less than 35, look at the QRS duration, less than 130, and especially majority ischemic, think of ICD also. Otherwise, the foundational therapy is on foundational therapy. So now I would pass on the baton to Dr. Kohli. He would answer the important question. In a patient with HFrEF without diabetes, because there is always that subset, which therapies without diabetes, which therapies are recommended as an internal medicine specialist? Dr. Kohli, please.
Thank you, Dr. Ibrahim. I think Dr. Altamash has already pointed out that it is the diabetes who are more prone to heart failure 2 to 4 times. Not only that, they get more heart failure, but they are more likely to die of heart failure. It's not that the non-diabetic do not get heart failure. There is still a lot of non-diabetics who go into heart failure. And as Dr. Abraham has already pointed out, what we are looking for is a drug which should have 3 aims. It should be able to prevent the mortality because of heart failure, number 1. Number 2, it should prevent readmissions in a case of heart failure. And third, it should improve the quality of the life of the patient. And we have been using these 3 group of drugs, ACE or ARBs, beta blockers, and MRAs for many years. But in spite of that, we have not been able to address to these 3 problems. We have not been able to reduce the mortality. We have not been able to improve the quality of the patient. And we have not been able to stem the repeated hospitalization in heart failure. But now you can see ACE inhibitor / RNA. So RNA is a drug which has brought about this revolution of addressing to all these 3 problems. Next, please. And after RNA comes the SGLT2 inhibitors. And we have got ample evidence from DAPA-HF trial and declared TRIMIT trial that dapagliflozin and empagliflozin, when added to these 3 drugs, further reduces the risk of CV death and worsening heart failure in these patients. And the new DAPA-HF trial has shown that this benefit is seen not only in diabetic population, but this is also seen in non-diabetic population. And another heartening feature from that trial was the benefit was seen as early as 28 days of starting the treatment. So you get the benefit and that too very early. So now the SGLT2 inhibitors are also added to the therapy for heart failure with reduced ejection fraction patients. Next, please. So apart from these four drugs, ARNI, beta blockers, MRAs, and SGLT2 inhibitors, there is scope for some other drugs also, but they are used when the situation demands. For example, as Dr. Abraham has showed, the use of loop diuretics. Yes, loop diuretics can be used in those patients of HFrEF with who show symptoms of congestion or symptoms of overload. There is a pedal edema. There are a lot of crepitations. Yes, you can use the loop diuretics. But a word of caution here is because we are using also ARNI. So adding loop diuretics may precipitate hypotension. So just take care of the blood pressure in these patients. Then what about the ARBs? ARB has a place provided the patient cannot tolerate ACE or ARNI, then use ARB in place of these two drugs. But ARNI remains the first drug of choice. Then third drug is ivabradine. Ivabradine have come because we want in a patient of heart failure, the heart rate to be below 70. If in spite of the beta blocker, the maximum tolerated dose of beta blockers, the heart rate of the patient remains over 70, I think it is worthwhile trying ivabradine in these patients. Or if the patient, the beta blockers are contraindicated, then you can also use ivabradine in place of beta blockers. Then they have mentioned it is new drug that is vericiguat, which is a pulmonary artery dilator. It is not available in India, so no point in talking about that. Next, please. Then, if the patient does not get relief, or patient is still symptomatic after giving adequate doses of RNA, ACE, or ARB, you can add isosorbide dinitrate. And lastly, what is the role of digoxin? Digoxin has been used for ages, but now I think it has fallen out of grace. It is not used, but still it has got a place. You can worth consider it in patients of symptomatic of HFrEF patients who are in sinus rhythm despite treatment with ARNI, beta blocker, and MRA. So if all these three drugs, in spite of them, the patient remains symptomatic, we can also try digoxin. And of course, when the ejection fraction is too low, you can go to the devices also. Next, please. Yes.
Thank you very much, Dr. Khalid, for that wonderful information. Now, the other side of the coin, HFrEF patients with diabetes, which therapies, what are recommended? I request Dr. Altamash to take the takeover.
Thank you, sir. Again, I think this is going to be the one slide which you will see from all the three speakers, wherein the ESC has suggested the treatment, whether it's the patient with diabetes or without diabetes. We've got actually three main molecule for the HFrEF, a triad of ACE inhibitor, ARNI, beta blocker, and MRA, mineralocorticoid receptor antagonist. That is going to remain the cornerstone. We heard very elegantly from our previous speaker about non-diabetic, but when it comes to diabetes, I think we all have suddenly been harping upon one particular drug, a class of drug which I think we are using it nearly day in and day out, with of course with certain amount of patient education that needs to be given with that, and that's the SGLT2 inhibitor class of drug. And that is where even the ESC 2021 recommends about the same thing. Now, you have seen some earlier slides wherein I think the doctor showed about the class 1 recommendation, class 2A, and around class 2B, and level of evidence was C, B, and so on. But I think now what we have, these classes of drug which are going to be class 1, and the level of evidence which is going to be around A. So we have canagliflozin as one of the molecules that is present in our armamentarium, and it is very much present in India. We've been using it since 2015. Dapagliflozin, of course, very widely available. Empagliflozin are two very much on the edge that would hit the borders and would come very soon to us. Sotagliflozin are recommended to prevent heart failure and CV death in patients with type 2 diabetes. When it comes to especially molecules like dapagliflozin and empagliflozin, they are also indicated for this particular treatment, and we have nearly little more data with these two molecules of dapa as well as empagliflozin, which has been just pouring and coming with recent releases of trials which came in NEJM also. And as we see in this particular slide, that in patients with type 2 diabetes at risk of CV events, to reduce the risk of hospitalization, major CV events, end-stage renal dysfunction, and CV death, that's the level of evidence A with a class 1 recommendation. And when it comes to patients with type 2 with HFrEF, to reduce again the HHF and CV death, the recommended ones with the EAC 2021 are DAPA, EMPA, and sotagliflozin. In this particular category, the data for CANA and DAPA and two are a little lesser. Class 1 and A evidence is much better for the DAPA, EMPA, and SOTA, as we see over here. So I think with this, I would again hand the session over to the moderator, Dr. Ruman.
Thank you very much. And this would be the final part. What would be the cardiologist opinion regarding ACC 21 consensus and ACC ESC 2021 guidelines? There is some difference between consensus statement, that is few people sit together, and also it is not a guideline. Guidelines are stronger. But having said that, guidelines are also not written in stone. We'll have to use our common sense and the art of medicine to get the maximize the benefit to our patient. So what did the ESC 2021 guidelines say? The MAD, AC bar AR, ARNI, beta blocker MRA. Then they very clearly said ARNI may be considered as first line therapy instead of AC inhibitors. ARBs are only people with or cannot tolerate AC inhibitors, ARB alone. Then SGLT2 inhibitors are recommended in addition to optimum medical therapy with AC bar ARNI, beta blocker, and an MRA. ACC 2021, again, they highlighted ARNI preferred, they highlighted about evidence-based beta blocker, and diuretic as needed when if there is congestion. And they also said beta blockers are better tolerated when the patient is dry. It's like when the patient is having rales or lungs are wet, so patient may not tolerate. But ARNI, the pioneer study has shown early initiation of ARNI is very good. So the direct to ARNI approach is recommended, and SGLT2 inhibitor can be added to the core HFrEF therapy. So the ESC guidelines said initiation of valsartan sacubitril AC inhibitor naive. That means you need not have a trial of ARBs or AC inhibitors before starting ARNI. You can straight away start ARNI. And ACC 2021 said the same thing, directly initiating ARNI rather than pre-treatment with AC or ARB. And you should titrate blood pressure, electrolytes, and renal function. So the mantra is go slow, start low, and aim high. So start low, go slow, and aim high. We just start and we do not titrate upwards also may not be good. And again, the ESC said about patients hospitalized with heart failure, they say that patients should be carefully evaluated to exclude persistent congestion before discharge and optimize oral treatment. This is because if patient has got congestion at discharge, very highly likely that they may come back for rehospitalization or come back dead. And evidence-based oral medical therapy should be administered before discharge. Is a very important concept because if we start, it has been very clearly shown that if we start during hospitalization or early if it's outpatient, early during the outpatient visits, the patient and doctor inertia will not be there, and patients will be on continued medications. And an early follow-up at 1 to 2 weeks is also important, because many times you ask them to come after 2 months, 3 months, but when you start these medicines, ask them to come at 1 to 2 weeks. And if you cannot personally do even the time of what do you call telemedicine, we can do use that. And initiation of RNA in hospitalized patient is safe. ACC 2021 consensus very clearly says that the ideal time for therapy optimization is during hospitalization. That is the golden period, and subsequently titrated upwards. So the patient there are many kinds of patients. De novo HFrEF patients, which is seen mostly by the primary care physicians and their counterparts, and hospitalized HFrEF, both internal medicine specialists, the cardiologists see, diabetologists see as references, and ambulatory chronic HFrEF patient by seeing everybody. And this is a preferred choice both by ESC and ACC. And what do these drugs do? They reduce natriuretic peptide and plasma levels, especially RNA, reduce symptoms and MHI class, reduce the need of diuretic dose, improve the quality of life and functional capacity, decrease heart failure-related hospitalization, reduce heart failure-related death, reduce sudden cardiac death, reduce mortality for all causes, reduce LV volumes, and increase LV ejection fraction. This is what RNA does. And RNA does it arguably better than the other, or as good, or arguably better than the other foundational therapy. We have very low threshold in starting ACE inhibitors, but the paradigm study has shown that for each point, RNA was superior. So we should not be denying our patients treatment. And since this is a diabetology endocrine meeting, I took a very recent paper from November 3rd, 2021, and they looked, this article said about the potential mechanism of valsartan sacubitril on glycemic control. So we are talking about heart failure, but again on glycemic control also, because there were many things. Type of mechanisms include increased lipid mobilization and mobilization from adipose tissue, increased postprandial lipid oxidation, increased adiponectin synthesis, improves insulin sensitivity, increased insulin secretion, reduction of hunger and food intake, and improved insulin sensitivity. Pathophysiology, and the effect there may be increased natriuretic peptide activity due to nitroglisin acts in the first three, and increased glucagon-like peptide 1 activity again has been effect on secretion, insulin secretion, insulin sensitivity, hunger, and food intake. This is a very famous slide from the cardiology circles. So when we look at hard endpoints, what is the hardest endpoint? Or what are the only two absolutes in life? They are death, taxes, and maybe change. Many of us are very resistant to change, but death and taxes are absolute. So let's talk about mortality. Let's remove everything else from the equation, because everyone wants to live longer. And you can see here relative reduction of 2-year mortality. Look at the effect. And RNA is on top of ACE or ARB, or replacing ACE or ARB, or on patients, or compared to patients on ACE or ARB. And when you give all four together, the absolute risk reduction is about 26%. And number needed to treat is 3.9 or 4. There is no group of therapies in the world in heart cardiology or in other specialties will give this much benefit in mortality in a disease where, as Dr. Kohli said, 5-year mortality is 50% or more than most cancer. And this was shown in the random heart failure registry that only 1 out of 6 patients received guideline-directed therapy, and they were associated with higher mortality and lesser survival. And when do we start them? Now the concept, the cardiologists, we talk about door to balloon. Some people talk about door to needle. But now we have to talk about door to guideline directed medical therapy. Unless we start quickly, we don't start at all. Best place is to start in the hospital. And finally, we have got 4 more minutes. And I think there's a very, very famous paper from Lancet by Muthu Madhagunathan and group. And they looked at patients who were initiated on ARNI plus beta blocker plus MRI plus SGLT2 versus standard AC or ARB versus beta blockers. And this was very famous. But certain authors, some people tried to reverse engineer it and thought, what is the harm in not giving it? What is the benefit in giving it? And what is the harm in not giving it? Benefit: reduce cardiovascular death and heart failure hospitalization by 62%, reduce cardiovascular death by 50%, reduce all-cause mortality by 47%, extend your patient's median survival by 6.3 years. Now let's look here. If you do not give these 4, and we just give AC or ARB plus beta blockers, what is actually happening? We increase compared to foundational therapy. We increase cardiovascular death and heart failure hospitalization by 163%, increase cardiovascular death risk by 100%, increase all-cause mortality by 89%, shorten your patient's median survival by 6.3 years. Ladies and gentlemen, we all taken an oath first, like to save the lives of the patient. And by doing less, we may be doing harm. And we have taken oath, first do no harm. So we should do the foundation therapy so that patient will live longer. So this is my last slide. The time is essential. So right choice in guideline directed therapy is important. ARNI is important and is good for diabetic patients also. Here, I will stop sharing the slide and I would request Dr. Kohli, we have 2 more minutes left. 1 minute, give his summary. After that, 1 minute for Dr. Altamaj to give your final summary. Dr. Kohli, please.
Yes, thank you, Dr. Ibrahim. I think these 2 drugs, ARNI and SGLT2 inhibitors, have changed. They are the wonder drugs of this decade, I think. They have changed the way we treat diabetes and heart failure. Second thing I want to say is that I have been treating my patients of heart failure with ARNI for a long time now. I think more than 200 patients I have got right now. One caution to my physician colleagues, and that is, no matter what lower dose of ARNI patients can tolerate, they still gives you benefit. So don't bother if you don't reach the target dose of 200 milligram twice a day. Even if you reach 100 milligram twice a day, it will do some benefit to the patient. And secondly, my message to my colleagues is that don't stop the drug ARNI, because once the ejection fraction increases, I have seen increasing from 25 to 40%, the patients and even the physician tend to stop the ARNI. Once you stop the ARNI, I think it will come back again down. So you have to give this ARNI benefit to all your patients of heart failure, I think, life. I think that is my message. Thank you.
Dr. Altamaj.
Sure. So I think I would like to say that this is one aspect of diabetes and heart failure where we should start slow, stay low, avoiding patients who do no shows, because these drugs need to be monitored, especially when they're giving a combination of ARNI and SGLT2. Look into creatinine and hyperkalemia. Going over there, most importantly, do not skip it. We need to look for heart failure, atypical symptoms and signs. Time is essential, and over to you. Thank you.
Thank you very much. We are absolutely on time. Thank you for Dr. Kohli as well as Dr. Altamaj. I'll sign off with one sentence from one trial, PROVE-HF, where patients treated with ARNI over a period of 12 months, 62% of the patients improved the EF improved to more than 35%. That is the cutoff for ICD. So as Dr. Kohli said, it saves lives, EF improves, and if you do not give them, we may not be doing justice to the patient. Thank you very much for patient hearing.
Thank you very much. Thank you. अंदर दो।
Hello everyone.
Hi.
Dr. Arvind.
Yes, sir.
I'm Dr. Ashok Jain. Good afternoon.
Yes. Nice meeting you, sir.
Nice to see you.
You can start, sir.
Hello. May I start?
Yeah, I think looks like.
Dr. Palaniappan is here. Dr. Rajneesh is here.
Hello, namaskar, sir. Namaskar.
Namaskar.
Namaste ji.
Namaskar. So,
Sir, if you permit, Dr. J.K. Sharma is not there, I can start now.
Dr.
If J.K. Sharma is
Rajneesh
not there.
Saxena, yes. Your topic is on?
Sir, diabetic foot examination.
Oh, okay. Then I'm going to start the session. So, good afternoon, everyone present in this session of fast fix, 10 minutes each. I'm Dr. Ashok Jain from Dhar, chairing the session. My co-chair is Dr. Arvind Raya. And namaskar.
Namaste.
My sincere thanks to organizers for giving me the opportunity to chair the session. In this session, we have various eminent speakers with us who will be talking on several aspects of diabetes, and every speaker has been provided with 10 minutes time. Before going to the first speaker, I would like to ask my co-chair, Dr. Arvind Iyer, if he want to add some more. Dr. Arvind, please. And please also introduce Dr. Rajneesh.
Good afternoon, friends. It's a great privilege to be a part of the RSSDI team. My sincere thanks to the team and Dr. Bansi Sabu especially. The first talk is on diabetic foot, and I request Dr. Rajneesh Saxena to go ahead with his talk, sir. Rajneesh Saxena is a PG in diabetology, and he is running the Saxena Diabetes and Foot Care Center in Ajmer, Rajasthan. Over to you, sir, for your talk. It is 10 minutes and 10 slides. Please keep to your time so that the entire session finishes off in time. Thank you very much.
Sir, this is Dr. Palaniappan. Next is mine or Hemant Sharma, others are there.
Hemant Antani is there, sir.
So after 20 minutes only, 30 minutes I will be joining, no?
Yeah.
Dr. Palaniappan, okay, from the district.
Thank you very much, Chairperson, sir. I am audible to you.
Yes, very much.
Okay.
Thank you very much, Chairperson, for your nice word. Now, first of all, I am very much thankful to Dr. Bansi Sabu, sir, and Dr. Sanjay Agarwal, sir, and all the organizing team members of RSDI for giving me this opportunity to be here with a important topic, that is diabetic foot examination. So in next 10 minutes, I will discuss diabetic foot examination and how should we approach. Because you all know at present there are more than 80 million citizens are suffering from diabetes mellitus. So it clearly indicates that 160 million feet are at risk of developing diabetic foot problem, and 7.4 to 15.3% diabetic foot prevalence in our country, and about more than 2 lakhs amputations annually in India reported. Shockingly, only 15% our amputee achieve mobility after amputation, and among diabetes mellitus patients, 15% experience a foot ulcer in their lifetime, and 15 to 20% of patients with such foot ulcer go on to need an amputation. And dedicated diabetic foot care result in 40 to 70% reduction in amputation and results in cost saving. reduction in morbidity and mortality. So proper diabetic foot care and diabetic foot examination is very important. Next question is, why do diabetic patients get foot problem? Mainly neuropathy, vasculopathy, all motor, sensory and autonomic neuropathy responsible for development of diabetic foot problem. And trauma, because in our country, barefoot walking tradition is very common, and poor or ill-fitted footwear are wear by the patient, so it will again damage the epithelium of the foot. Falls, accident, object inside the shoes, and second, very important is the alteration in the biomechanics of the foot. That is limited joint mobility, bony prominences, foot deformity, osteoarthropathy, and calluses. These all are, along with previous history of amputation and ulcers, are responsible for alteration in the plantar foot pressure and lead to development of diabetic foot problem. Last, very important is the socio-economic status of our country. Now I will discuss the identification and assessment of high-risk diabetic foot part. Basically, examination of foot is very important, because goal of examination of foot is to identify the normal fit, which fit is normal or abnormal, and which fit is at risk of developing diabetic foot problem. And secondly, presence of significant neuropathy, vasculopathy, and lastly, presence of foot lesion. This should be very important to identify at the time of foot examination. The history taking is very important, because patient is complaining tingling, numbness, burning in feet because of presence of neuropathy, and insensate feet is very common in diabetic foot. So history taking is very important. Secondly, history of previous foot ulcers or amputation, use of tobacco, claudicating pain in the leg are due to presence of peripheral vascular disease and difficulty in walking. And lastly, very important is the associated vision loss along with or chronic kidney disease. At the time of history taking, not only tobacco but other nicotine products should be considered. Secondly, clinical examination, because generally if patient is not complaining any problem, then we are not going to examine, but it is wrong in case of diabetic foot. Always examine all the patient of diabetes, whether they have any complaint, any problem or not. There are two types of factors for this, intrinsic and extrinsic. Intrinsic are related to foot, that is bony prominences, deformities, callus, and altered tissue pressure, and extrinsic are the related to footwear and outer part, that is whether heel of the foot is normal or not, outer sole is proper or not, appropriate footwear or insole is there, or object inside the shoe. So this should be inquired at the time of examination. Second is the inspection of the foot. Inspection of foot not only from the plantar aspect but also from the dorsum, sole of the foot, back of the heel, and interdigital area is very important. And full assessment regarding the color, deformity, swelling, presence of callus, foot ulcers, interdigital mycosis, fissures, and dermopathy is very important at the time of we have to inspect the foot. Then look for nail deformity, or tropical nails are there or not, prominent blood vessels are there or not. These all are indicative of the presence of neuropathy and mainly autonomic neuropathy. The foot deformities like claw toes, hammer toe, and bunions. Claw toes and hammer toes are generally present in foot with motor neuropathy. So this should be inspected at the time of examination. Then palpation of foot is also very important. Always go for dorsalis pedis and posterior tibial pulsation. Dorsalis pedis is examined at outer part of the extensor hallucis longus tendon, and posterior tibial below and behind the medial malleoli. So peripheral pulsation of these two blood vessels is very important. Then bony prominences palpation is also very important. Edema is there or not. Sometimes cellulitis is also there. And temperature difference. With the help of dorsum of our hand, we can examine whether temperature is normal or not. If temperature is high, then cellulitis may be there or other lesion can be there. Then limited joint mobility is also very important to assess. Mainly hallux rigidus is very common due to limited joint mobility, and we have to ask the patient to dorsiflex the hallux while foot is in weight bearing state, and the patient can move up to 14 degree, up to 15 degree. If after inspection, comprehensive foot examination for neuropathy and vasculopathy is very important. The skin sensation and skin integrity should be examined with the help of tuning fork, mainly 120 tuning fork, tendon hammer, and Sims-Winston monofilament. With the help of this Sims-Winston monofilament, we apply 10 gram pressure at different part of the plantar aspect in this picture. At the plantar aspect of the great toe, then first, third, and fifth metatarsal as incept and heel area and dorsum. If patient fail to feel the monofilament along with symptom of tingling, numbness, burning sensation, then quantitative neuropathy assessment is advised. Quantitative sensitivity testing is done with the help of biothusiometer, as a vibration perception test, and neurothusiometer. If vibration perception is more than 25, then severe neuropathy, more than 20 moderate, and more than 15 then mild mild neuropathy is there. Then temperature assessment is done by the sensitometer and infrared thermometer. If temperature is more than 4 degrees centigrade, then patient can develop Charcot arthropathy in future within 3 to 4 years after. Then paper grip test is very important for knowing the intrinsic muscle strength in diabetic foot patients. Next important investigation is the ABI for assessing the presence of ischemia. With the help of ankle and brachial systolic pressure, we can identify if it is its ratio is between 0.9 to 1.3, then patient is normal. If more than 1.3, then arterial calcification is there or poorly compressible vessels are there. If it is less than 0.9, then suggestive of peripheral vascular disease, and if listed less than 0.5, then critical limb ischemia is there. So chances of non-healing of ulcer is there. Now I will discuss very important picture. In this, how to do a 3-minute diabetic foot examination. This is given by the Amputation Prevention Center of America. According to this graph, in first minute, we will go for the history taking, whether patient is suffering from diabetes or not, any previous leg or foot ulcer or lower limb amputation or surgery there, prior angioplasty, stent or leg bypass surgery history is there or not, then smoking or nicotine use, then patient presentation, that is patient is complaining of burning, tingling, leg pain, any changes in the color or skin lesion, loss of lower extremity sensation, or patient has the regular podiatry care or not. In second minute, we will go for vascular examination and neurological examination with ABI and with capillary filling timing. If it is less than 0.3 second, then vasculopathy is there. And neurological assessment with monofilament and electrical tuning fork is done. And musculoskeletal examination is also very important. In second minute, we can go for assessing the presence of range of motion, whether there are normal motion or of hallux or not, or Charcot arthropathy there, any sign of Charcot arthropathy there or not. In third minute, we will decide if we can manage patient or we can refer according to the condition of patient. If vasculopathy is there, then we will send for vascular assessment or vascular surgeon. And neuropathy is there, then we will send patient for neurological assessment or higher center. Next very important thing is, according to ADA task force, 5 simple clinical tests are sufficient to assess the significant neuropathy presence. First is the 10 gram monofilament, second pinprick sensation, 120 tuning fork, ankle reflex, and last is biopsy. With these 5, we can assess whether significant neuropathy is there or not. And second important thing is risk categorization. If no sensory neuropathy, then once a year. If sensory neuropathy, once every 6 months examination is advised. If sensory neuropathy and signs of peripheral vascular disease and foot deformity is there, then once every 3 months. If previous history of ulcer or amputation is there, then once every 1 to 3 months according to condition of patient is advised. These are the guidelines of ADM. Now I conclude with this slide that with the take-home message that every person with diabetes should undergo examination of fit at least once in a year. Those who are at risk fit should undergo comprehensive examination of fit more frequently, and it is the patient education and lifelong surveillance of high risk fit we shall be able to prevent foot problem and eventually limb amputation in person with diabetes. Thank you very much for patient sharing. Now I conclude with this beautiful picture of Gandhi March. The one who walks his good fortune also marches ahead. But no one is wearing footwear in this picture. So always educate all the patient, all the diabetic for proper footwear and foot care and prevent amputation. Thank you very much. Now I invite you all to attend the Epicon 2022 Jaipur in the month of March. Thank you very much. Padaro Mare Desh.
Thank you. Thanks, Dr. Rajneesh.
Thank you very
Very
much.
informative talk on food examination. Basically, the diet, drug, and exercise are three main pillars in diabetes management. And if the food is diseased, then one pillar is gone. And so the food examination is very essential in diabetes management, to which you have covered it very nicely. Can we take some question or one question from my side? What is the role of biospectrometer and the Doppler machines and manual examination of the food? Do you think it is?
No, actually, sir, according to ADA Task Force guideline, biopsyometer is only advised if there is patient fail to feel the monofilament and symptoms of tingling, numbness, burning sensation, or other previous history of amputation or is there, then we will go for biopsyometer. Otherwise, with the help of tuning fork, we can assess significant neuropathy is there or not. And line or management is same. And these simple 5 tests are sufficient to diagnose in rural or semi-urban area where biopsyometer and nerve conduction velocity and other investigations are not available.
Okay, thank you. Then the Dr. Arvind, please. Please call the next speaker.
Yeah. Good afternoon. I think Dr. Palaniappan is available. I don't see him. Then Dr. Sachin Gupta from Bhopal is there. Sachin.
He was there, but now.
No, Sachin Bhai is there, I think. Sachin is there. So the next
you were
talk
telling
will be,
that Dr. Hemant Antani was there.
okay. If he's there, then Palaniappan is there. So the next talk is by Dr. Palaniappan. He'll talk about diabetes risk scores and clinical implications. He is a consultant and Best CEO Award by the Times of India.
Sir, this is not Palaniappan. This is V. Palaniappan.
Okay, okay.
I am a National API Vice President from Tamil Nadu.
Okay, sir. Please continue with your talk because this slide is wrongly posted. Okay. And Dr. Palaniappan, please welcome for your talk, that is diabetic risk scores and clinical implications. Please go ahead, sir.
Yeah. Am I visible, sir? Slides are visible.
Yes, perfect.
Yes, sir. Yeah, thank you so much, Dr. Bansi, for giving me this opportunity. This is Dr. Palaniappan. I am an API Vice President, National API Vice President, Tamil Nadu API Secretary. Today, my topic is diabetes risk score, clinical implications. So diabetic, by means of diabetic risk score, what we can apply, what we can get it. What do you mean by diabetes risk scores? The diabetic risk score is a simple, fast, inexpensive, non-invasive and reliable tool to identify individuals at high risk of developing pre-diabetes or type 2 diabetes mellitus. The main objective of this diabetes risk score estimation is very, very important. We have to pick up in the early phase. Then nowadays we are thinking in terms of early detection of type 2 diabetes mellitus or pre-diabetes mellitus. Nowadays, the postprandial hyperglycemia postprandial hyperglycemia, usually fasting and postprandial diabetes, pre-diabetes. So pre-diabetes, that is 1 hour PPG. Now recently we are detecting half an hour PPG is also very important to detect early and treat aggressively to prevent the development of type 2 diabetes mellitus. Like that, here the prevention of transformation of normal glycemic to IGT or pre-diabetes and pre-diabetes to type 2 diabetes mellitus, it can be prevented if it has been addressed properly. And here we are going to use diabetic risk score. We are going to use various parameters, that is BMI. One of the thing is BMI. This study has been done in Finland. Their BMI is different, Indian BMI is different. So for our Indian population, overweight is also very, very important, and class 1 obesity is also very important. Finland population study, they are giving more score for the class 2 obesity. But here we have to give overweight and class 1 obesity also, we have to give it very important.
Hello, Rx. Hello, RxEvents.
Actually, Indian 95 more than 80 more score the districts. And we have tables. Hello.
I think sir
Hello?
have network issues.
Audible, sir?
Yeah, network issue, probably.
No. Am I audible, sir?
Yes,
Hello?
Now, yes. Now,
Okay.
yes, there is some network problem, I think.
Rajesh, please come. So waist circumference is very important, and usage of vegetables and usage of fruits, and that's also very important. Here, diabetic risk score, it has been calculated by using the beta coefficient. If it is 0.01 to 0.2, score 1. And like that, 0.21 to 0.8, score 2, like that. Lowest score is 0. If the patient is doing physical activity more than 4 hours per week, 0 score. If the patient is using adequate vegetables and fruits and berries, 0 score, lowest score. So here is a slide. It explains everything. Here we did, there are 2 studies, 1987 and 1992. There are 2 studies. Here, 10-year study is concise model. Here, the number used is 4,995. And full model, 4,435. The new, that is whom developed diabetes after this diabetic risk score, 194 patients developed diabetes, new diabetes in this study, 1985 model. And full model here, they developed only 182 patients whom developed diabetes. This is 5-year study, this is 10-year study. Here, various parameters are used. Usually the diabetic risk score varies from 0 to 20. We are giving the score, the last column, we are giving the score. If the age is 45 to 54, 2. 55 to 64, 3 scores. BMI more than 33 and 25 to 31. And waist circumference more than, that is 102 and 88, it's 4. And waist circumference 94 to 102, 80 to 83. And use of blood pressure, that is medication, that is indirectly indicates they are already known hypertensive. If it is that, the score is 2. History of high blood glucose, that is known diabetic, means the risk score is 5. And physical activity less than 4 hours, you have to give 2 score. Daily consumption of vegetable is not there, 1 score, it has to be given. So here, the first model, no, there is physical inactivity, others it's not considered. The second model, 1992 study, 5-year study, they are considered. So here we are using the sensitivity and specificity for the diabetic risk score. DRS means diabetic risk score, drug-treated diabetes. How many patients you are getting diabetes, that has to be treated by drug. The sensitivity means diabetic, that is diabetes risk score, positive drug-treated diabetes in future, if they are developing, sensitivity is high. Specificity, that is, if it is negative, diabetes risk score is negative, then they will not develop drug-treated diabetes. So here is the curve. that is 1987 curve and 1992 curve. 1987 curve studied for 10 years and 1992 for 5 years. Final results announced in 1997. This cohort study, one that is x-axis, y-axis, false positive rate one side and sensitivity other side. They are meeting each other at 9 o'clock. 9. Score value 9 is selected as a cut point for increased risk of drug-treated diabetes. So here the sensitivity is 0.7578 and specificity is 0.77 for 1987 cohort. And sensitivity is 0.81 and specificity is 0.76 for 1992. And positive predictive value is higher for the 1987 cohort because it's a 10 years follow. Positive predictive value is lesser, that is 0.05 for 1992 because the study duration is 5 years. Overall incidence is lower for 1992. And here there are two cohorts also studied, 1997 and 1992 cohort. Here 1987 cohort, male and female, what are the incidence of developing future diabetes, the percentage. According to the diabetic risk score, if it is 0 to 3, it's lesser, only 0.3% men and 0.6%. 4 to 8, that is 2.4% and 1.3. And 9 to 12 means that is 10.5 and 6.6% male and female. But 1992 cohort, if it is 2.6 and 2.2 for 9 to 12 diabetic risk score. If it is 13 to 20, the percentage of diabetes incidence in the previous cohort is 32.57% and here 28 male and female. But it is lesser with cohort 1992 cohort because they are using physical activity and vegetable and fruits also consider. And p-value is significant. So undiagnosed diabetes development with this diabetic risk score, the percentage is 5.6% in previous study and recent 1992 cohort 10%. 10% undiagnosed, it has been come. And positive predictive value for cross-sectional setting is increased. 7% previous study, 1982 and 87 and 1992 cohorts, it's 12%. So we can detect very early by means of diabetic risk score. And here family history of diabetes is not included, but at the same time, for the patient what we are interviewing and diabetic risk score we are assessing, here family history is not included. Nowadays, family history of diabetes is very, very important. That too, first degree and second degree relative. First degree relative, if it is positive, you have to, even the diabetic risk score is 3, it has to be addressed properly. Early intervention like physical activity and consumption of vegetables and fruits and berries, it has to be advised properly very early. And second degree relative, if it is positive means 5 score. If it is 5 itself, you have to address properly and you have to aggressively manage. And previous gestational diabetes is not included in this study. So gestational diabetes also equally we have to give importance. History of gestational diabetes means the diabetes mellitus. Here 1/3 of people will develop diabetes type 2 diabetes mellitus and 1/3 will be IGT, 1/3 will be normoglycemic, but regularly you have to undergo OGDT, and within 3 to 5 years they will develop type 2 diabetes mellitus. If they are treated with adequate lifestyle therapy, they will not get it. So here Indian population diabetic dyslipidemia also it has to be addressed. It is nothing but previously the diabetic risk score, it's nothing but almost similar to metabolic syndrome X. So metabolic syndrome X, that is BMI, age group, and that is HDL level, and HDL levels. All the things are physical inactivity. Everything is included in the almost like metabolic syndrome X. So undiagnosed diabetes mellitus and pre-diabetes mellitus, 30 to 60% of the individuals with diabetes in the community are undiagnosed. With the diabetic risk score, if you are estimating these people, whether there are chances for getting diabetes in future, many patients are asking, if you plot this diabetic risk score, if it is more than 9, chances of getting future pre-diabetes and diabetes are very high. So aggressive management with physical activity and consumption of vegetables and fruits and berries, it has to be appropriately applied yearly to prevent future pre-diabetes and diabetes, because it should be addressed properly. Otherwise, it will end up in diabetes mellitus. So diabetes mellitus, which will lead to macrovascular complication as well as microvascular complication. Nowadays, newly detected type 2 diabetes mellitus, if you control adequately, you can prevent microvascular complication. If you, in the early phase, if you control adequately for the first 7 to 8 years, you can prevent macrovascular complication also. So that's why in the community wise, diabetic risk score is estimation is very, very important. If it is higher, more than 9 for all populations, you have to address properly to prevent future diabetes, incidence of type 2 diabetes mellitus or pre-diabetes. If it is first degree sibling, 3 it's very important. Second degree relative, 5 itself is very important. You have to target this population and appropriately, and hit hard and hit fast rule has to be applied properly to prevent future development of pre-diabetes and type 2 diabetes mellitus. So all these individual, if you address, detect early, it is a simple tool without doing that is invasive glucose estimation, because here all the study they did the glucose estimation previously 1985 they did the result is 2 days. Here immediately they did 1992 study for 5 years. So incidence of future diabetes is very high. So nowadays, if you plot properly, diabetic risk score assessed properly for all community setup, more than 20 years itself, if you do that screening with this diabetic risk score, you can detect the early newly detected diabetes mellitus or pre-diabetes mellitus, and aggressive management to prevent all these complications, all these type 2 diabetes mellitus, pre-diabetes. So community will grow like anything. Lot of morbidity and mortality will be prevented. Microvascular complication also can be prevented. So diabetic risk score is very important. Here 9 number is very important for all population. 5 for second degree relatives and 3 for first degree relative family history of diabetes. So all this you have to keep it in mind. And diabetic risk score is very, very important for the entire community India to assess everything. Here BMI, overweight, class 1 obesity also, it should be given proper validation and treat aggressively to prevent morbidity, mortality of future diabetes mellitus and pre-diabetes. Thank you so much for the patiently listening.
Thank you very much, Dr. Palaniappan sir.
Yes, sir.
You wonderful talk, and predicting diabetes.
Yes, sir.
In a particular person.
Yes, sir.
Thank you very much.
Thank you,
predicting
sir.
diabetes in a particular person
Yes,
by
sir.
assessing his risk factors is a first step in prevention of diabetes, and you have explained it very well. So thank you very much. And next speaker is Dr. Arvindji.
Yeah, I think Dr. Sachin Gupta sir is there, sir. Dr. Sachin
Yes,
Gupta, can you?
Yeah.
Oh,
Yeah, I'm going
Hemant.
to hear.
Dr. Hemant Antani.
Hemant Antani. Dr. Hemant Antani is a close friend of mine. We studied together. Oh,
Okay. Then priority to your friend.
yeah. Hemant is a close friend of mine and is a colleague for me. And he will be talking on body composition analysis, how important for clinician it is. Over to Hemant. Hemant is not there, it seems. Then Dr. Sachin can start his talk.
Yeah.
Dr. Sachin Gupta from Bhopal.
Yes.
Oh, Hemant is here. Okay.
Hello. First
Yes,
of all,
yes.
I thank RSSDI and Dr. Bansi Shabu for giving me this opportunity to vent my, express my views on a very important clinical topic, the body composition analysis, and how it is important in our clinical practice. Now, when we say body composition analysis, it basically takes care of all these three things. One thing is the total body water, which is intracellular and extracellular water. We also measure lean body mass, dry lean mass, body fat mass, and weight. So basically, if you look at the entire, crux of body composition, it is body fat versus lean mass, which is taken into consideration. Now, very briefly, we'll just see what are the methods by which the body composition analysis is done. We have got anthropometric measurements, skin fold test, hydrostatic weighing, computed tomography, air displacement plethysmography, dual energy X, DEXA, as very commonly known and very much familiar to all of us, and bioelectric impedance analysis called BIA. So what exactly we do in anthropometric is been doing in our clinical practice day in and out. We do the weight and height and waist circumference and hip circumference. And by measuring all these four, we basically come up to two very important measurements, which are waist to hip ratio and body mass index. Now, if you're looking at the waist circumference, all of us know that now there are certain set standards by which we can make out that patient is whether having vulnerable to the risk. So if the man waist inches is less than 37 and women is less than 31.5, they will fall into low risk. And if for man, if it is more than 40 inches and women more than 35 inches, would fall into high risk, and in between are the intermediate risk. And if you, this is even more sensitive parameter is a waist to hip ratio. Now, if the patient who is in low risk, we find that the ratio is less than 0.8 in women and less than 0.95 in men, and the body shape is called as a pear. Now, if you look at the moderate, it is between 0.81 to 85 in women, 0.96 to 1 in men, and we call it as an avocado kind of body shape. And the high, where the women is more than 0.85 and men more than 1, which is a apple shaped, this is a high risk category. And this is the time where we really to intervene and ask the patient to follow the lifestyle modification. Now, we have been doing this and we'll still continue to do this for a while, although we know that there are certain disadvantages that we will see later. And the body mass index, it's actually measured by weight in kg by divided by height in meter square. And the BMI, all of us know if it is less than 18.5, it is underweight, 18.5 to 25 is normal, then 25 to 30 is overweight, and then class 1 obesity, then 2, and more than 40 is class 3 obesity. 40 to 50 is almost morbidity, and more than 50 is called as super obesity. So these are the grades by which we have graded the patient as per the BMI values. But there are limitations of BMI, and all of us know now. You can see the two picture here. You can very clearly see the person on the left side is so fit, and the person on the right side, needless to say. Both of them have got the same BMI, and because BMI does not distinguish between body fat and muscle mass. In fact, there are many super athletes who have got high BMI and very low fat levels. So this is one thing which has to be kept in mind, and that is how the body composition analysis has come into play. So the more accurate, comprehensive, and realistic measurement is body fat percentage, and that is what we have to aim at. Now, the skin fold thickness is a very common thing which is applied by the skin calipers. The skin fold thickness measurement provides an estimated size of subcutaneous fat deposit, which is basically the fat under the skin. And by estimating the thickness of this area, an estimation of the total body fat can be made. And these are certain, calculators which are available by which we can actually come up to the total body fat. The limitations are that it's not very accurate, and there are incorrect results if the skin thickness is more than 5 centimeters. So it has a lot of limitations, and that's why there are better methods which are available called hydrostatic weighing. Now, weighing under water actually calculates the total body fat by density of the body, and it is based on a basically Archimedes principle. Underwater weighing is regarded as the gold standard for body composition measurement, as it is one of the only body composition technologies that have been compared directly to the cadaver analysis. And that's why this is actually is pretty important. Now, this is also very important by which we can actually come up mainly all of us know the subcutaneous fat and the visceral fat. The amount of visceral fat definitely has a very higher risk and as compared to the subcutaneous fat. And this computed tomography will scan and provide the accurate, high quality information on the body composition and the including the muscle mass, visceral fat, and subcutaneous fat. So this also is very important test by which we can come up to how much is the visceral fat. Then this method, which is called as the air displacement plethysmography, this method measures the volume of a human body by measuring the volume of air according to the changes in pressure in a chamber that you can see on the left side. First, weight and the volume of the persons are used to calculate body density and the percent body fat and the fat-free ratio. Time required for measurement is relatively short, because you can just finish this test in 3 to 5 minutes, and the examinee can continue breathing in the chamber as opposed to the underwater weighing. So that is where this actually is more convenient. And this method is also known as a gold standard, because it allows the body composition analysis and produces accurate measurements using the volume, just like underwater weighing. And that's why this is a very important method. Now, DEXA, all of us know the dual energy X-ray absorptiometry. The DEXA actually is the imaging method that measures the body weight in terms of BMC, lean and fat, based on the decrement of X-ray on the image obtained by exposing to two different X-rays. And this method takes about 5 to 30 minutes. And it has got a very high accuracy, and it can measure the body composition of bones and density, body fat, and muscle mass for different parts. And the advancements to the technology affords DEXA the ability to differentiate lean and fat, allowing this technology to advance from a two-compartment model to a three-compartment model. And BIA, which is the bioelectric impedance analysis, is a method of measuring impedance by applying alternating electric currents to a user to measuring their volume of water through impedance values. And this is a non-invasive method, as you can see, where it involves the placement of electrodes on a person's feet, hands, and both. A low level of electric current is actually sent through the body, and the flow of current is affected by the amount of water in the body. BIA devices measure how this signal is impeded through the different types of tissue. The muscle has got a high conductivity, but fat actually will slow down the signal, and that's how actually you come up to the estimation of fat. So BI determines the resistance to flow of the current as it passes through the body, and it provides the estimate of body water, from which the body fat is calculated using selected equations. So this also is a pretty fairly accurate method by which we can come up to the body composition analysis. Now, the most important question is that why it is important to know the body composition. Now, most diet and fitness goals focus on weight loss or gain, overlooking that two people of the same sex and body weight may look completely different. That's what we saw a couple of slides back from each other, because they have got a different body composition. Body composition describes the amount of fat, bone, water, and muscle in the body. Measuring the body composition will guide the persons to understand their body's unique makeup and help them to identify areas to work on to improve the overall health and wellness. And I think that's the most important clinical application of the body composition analysis. And the measurement of body composition allows the documenting the efficiency of nutrition support, very important point, tailoring the choice of disease-specific and nutritional therapies, and evaluating their efficacy and putative toxicity. It helps to assess the percentage body fat to guide the patient to focus on fat loss and not just the weight loss. Very important point on the fat loss and not just the weight loss. And I think this is an important paradigm shift which we have to keep in mind if we want to make our patients, risk-free. So I'll very quickly go through 2-3 slides before I complete. And what are the parameters that we basically measure? The most important thing is the percentage body fat, which is more accurate than BMI, as we saw. And these are the levels which should be borne in mind by all the clinicians, that the percentage of body fat is 10 to 20% for males and 18 to 28% for females. So this should be the guidelines when you're actually taking care of your patient. And then another important thing is a skeletal muscle mass. Now, skeletal muscle mass is crucial for mobility, posture, and strong immunity for long-term health. And I think this is also very important. The body water is either intracellular or extracellular, and they are valuable in their own right. But the monitoring extracellular water in particular can provide deep insights. If you notice an increase in extracellular water, but not intracellular water, this could be due to acute inflammation from overtraining. And I think now that we find so many young days with undue exercises, this is something which is very important. So desirable extracellular water and total body water ratio should be less than 0.339. Now, lean body mass is very important because lean body mass is the sum of ACW and dry lean mass. The lean body mass is the weight of everything in the body except fat, and for this reason, it is also called as a fat-free mass. Lean body mass includes muscle, water, bones, and organs. Usually, increases in the LBM reflects an increase in muscle mass and is considered an improvement in the body composition. That's why you can actually monitor your patients. However, people who do not maintain normal body water ratios may have increased LBM due to swelling caused by the strenuous exercise and activity. This is also a very important clinical point. Now, these are the methods by which actually you can find that you can get a complete analysis, and you can see on the right side, there's a very extensive report by which we can actually come to so many conclusions at whatever points we discussed. And this is now available, which has become very easy for us so that the patients are also helped to a great extent. To summarize what I actually discussed, the body composition describes the amount of fat, bone, water, and muscle in the body. It is very vital to know all components of body to guide patients with specific. BMI is not a very reliable indicator of health. The percentage body fat is most important marker to predict health, and the focus must be on the fat loss and not just the weight loss. That's a very most important message that I want to give. And the skeletal muscle mass is crucial determinant of immunity. The various accurate methods, as I already discussed, are now available to estimate the body composition. So thank you very much for your patient listening. And thank you once again, Dr. Bansi Sabu. It is my bad luck that I cannot be there the live, but thank you very much for giving me this opportunity to record my presentation. Thank you very much.
Thank you, Dr. Ahmed. It was a wonderful discourse. Now over to Dr. Ashok Jain sir for the next speaker, sir. Sir, you are muted. आप muted हो sir. Unmute करिए mic.
Okay. Thank very nice talk by Dr. Hemant. And now I call on to Dr. Sachin Gupta, who is a renowned diabetologist in the city of Bhopal. He will be talking on insulin resistance, thin fat Indians. And Dr. Sachin Gupta, sir.
Yes.
He is MD Medicine, consultant diabetologist, Krishna Diabetes Clinic and Education Research Center, Bhopal. Trained in diabetes from Royal Prince Alfred Hospital, Sydney, Australia. In 2001, regularly organizing diabetes awareness program in urban and rural area. Received 2 national awards. Diabetes Awareness Initiative Awards by Diabetes India in 2015, and Geo Dil Se Award by my fame Dainik Bhaskar Group in 2015. Participated in educational seminar Diabetes in 2008 from research to clinical practice at Joslin Diabetes Center, Boston, USA. Since Feb 2014, running free charitable Sai Diabetes Clinic every Thursday evening and providing free blood sugar test, HbA1c at regular interval, free medicines to all low socioeconomic patients. Great, sir. Regularly consulting about 100 plus patients every Thursday. Nice, very nice. And overall, he is my senior remains senior at Bhopal Medical College during my course. Sir, please.
Thank you.
Very nice to hear you as today. Please go on. Insulin resistant thin fat Indians.
Number 1 billion. Yes. So good evening, dear all. Thanks, nice words, Dr. Ashok Jain. Glad to meet you. And at the outset, I'm thankful to Dr. Banshi Sabu for providing me this opportunity to meet my dear friends, doctors, recognized, renowned conference, RSSDI, and thanks to both chairpersons. So my topic is insulin resistance and thin fat Indians. We know that we just know that diabetes is two type 1, type 2, basically. But now recently Dr. Mohan and Dr. Yagnik's work and so many other works, we know that diabetes is not just two types. We have at least, Dr. Mohan said that it is almost 25 types of diabetes. So now we have severe insulin resistant diabetes, severe insulin deficient diabetes, and now we know that we Indians, we are thin fat Indians. We have a lot of insulin resistance, and this is responsible for this epidemic of type 2 diabetes. We know that every fifth, 1 in 5 diabetic patient in the world is Indian. So it's a grim situation. We all physicians, we have to think about it. And the problem is that if we diagnose correctly, then we can treat correctly, because these thin fat Indians, they are so insulin resistant that they will need insulins very early, and they have more kidney problems. So let us discuss about I've been given 10 minutes and I'll discuss within 10 minutes. So very important topic. So Asian Indian phenotype, this is thin fat Indians. So any body mass index and age, Asian Indians have, maybe your BMI is healthy, as we have just heard Dr. Hemant's talk. Maybe your BMI is 22, 23. Even then you can have problem, because there is higher body weight, visceral fat and waist circumference is on the higher side, lower skeletal muscle mass, you are lean and thin, thinner hips, short legs, profoundly higher rates of insulin resistance. Like there was one more term like spider. Oh, that central obesity. So this is unique clinical and biochemical characteristics that are commonly found among Asian Indians, in particular South Asians in general are collectively referred to. Okay, so I think you must have seen, all must have seen this slide so many times. Dr. Yudkin and Dr. Yaznik, and this is YY paradox. This slide, this study was around 1970. Dr. Yagnik, he was working in Oxford University, London, and that time he submitted himself for one test, and to his surprise, both the BMI, you can see that BMI of both Dr. Yudkin and Dr. Yagnik is same, 22.3. But if you just see the body fat, Dr. Yudkin, even if you just see his fatter, his height is 15 centimeter longer than Dr. Yagnik. Weight is also high, but even that the body fat mass is just 99.1% compared to Dr. Yagnik, that is 21.2%. So this body fat is more. And the surprise that the insulin levels were double the Dr. Yudkin's in Dr. Yagnik. This was the main point. So this was insulin resistance. And from there, we thought that why our lean and thin people, they are getting diabetes. Okay. So this is very important slide. So Indians are referred to as thin fat because they have lesser amount of mean muscle mass and tend to add weight to their bellies. Okay. The thin fat phenotype occurs when fat is added to an already thin frame. This may occur with rural-urban migration when positive energy balance occurs in a migrating population who were predominantly thin and physically active to begin with. We have seen, we have learned that there were a lot of amputations in the and patients from Dharavi, Mumbai, and the that migrants were laborers at Bihar. They shifted to Mumbai. There was abundant meals. They did not do any physical work, and they developed diabetes and foot amputation. They need, and there were a lot of problems. And why this? And if you just recall that thrifty gene phenotype and genotype, then you would remember that we faced a lot of starvation, and the lot of famine was there in generations. And because of that, the genes they develop like that, everything in when they get more food, they just accumulate in abdomen. But that continued, and after 1970, and after that, more after that, when we stopped working, not going for walk, our lifestyle changed, and we used to eat more, because and what we eat bad food, that is all this fast food and other thing that contains a lot of fat, trans fats and other things, and that all accumulate, and this central obesity, it becomes active and it leads to a lot of metabolic diseases, diabetes and other things. So thin fat Indian is very important thing. We know that we get diabetes at lower age, at onset of type 2 diabetes compared to Western people. Lower threshold for BMI for type 2 diabetes. There is increased serum insulin level that we all know. There is increased insulin resistance. The important thing is that there is rapid decline in beta cell function. So this group of patients, they need insulin more earlier. Okay, characteristics dyslipidemia, and this is typical of Indians. There is decreased HDL cholesterol, increased triglycerides, increased importance LDL. There is decreased levels of adipose.
Drop you off at
There is
sunrise.
increased inflammatory markers,
He'll drop you off.
HSCRP, low muscle mass, increased abdominal obesity and visceral fat. And now we are getting a lot of these fatty livers, low birth weight, low B12, OSD, and gut, a lot of problems for this Asian Indian phenotype. Okay, so if you just see this data, and in this excess age, and if you just see the prevalence of diabetes, it's very high in Indians compared to Chinese, Japanese, Maltese, and Europeans. Very, very high, quite significant. Okay, and if you just see the diabetes in Asian Indians, this is, if you just see BMI wise, even with low BMI, I think you can appreciate this. This is with even 22, 23, we have high diabetes is very high in India, and this is typically thin fat Indians. Okay, when you compare it with Europeans, the insulin levels are very high, maybe in control subjects or maybe in type 2 diabetic patients. When you just see the data on newborn matched for their birth weight, this is hyperinsulinemia, and this is, if you just see this data on newborns, anthropometry subscapular triceps, this is quite p-value is very significant. When you compare Indians, this is Dr. Yagnik's study, and they studied that this is from Pune, and this is from Europe. Okay, and you can see this difference, that even this our Indian babies, they have insulin resistance from when they are newborn. So it starts very early. So there is visceral, and this is one of the studies from Dr. Anjana, visceral and central abdominal fat and anthropometry in relation to diabetes in Asian Indians. And visceral and central abdominal fat showed a strong association with type 2 diabetes. That I think we all have this experience. Both measures correlated well with each other. And the waist circumference and the sagittal abdominal diameter in diabetic and non-diabetic urban Asians. So this is very important study, and it also proves thin fat Indians. So I think this is one should, when we see patient, one should be look what patient we are seeing. Is it simple type 2 diabetes or this is something different? Just devote some time and I think we can differentiate. So this is affluenza, abundance. So, and the three main risk factors when you compared yesterday with today, there is increased calories, glycemic load. We eat a lot of things, and food has become very accessible. Even the poor people, they are getting a lot of fast foods at very cheaper rate in India. Physical activity, just don't talk about physical activity. Do not have time for physical activity. If you just ask anybody, no, sir, we are such a busy person. We are earning a lot of, even you talk about CEOs and other, even poor people, we see that when we run that our charitable clinic, poor people, they are coming with all problems with diabetes and other things. Urbanization is definitely responsible for this affluenza. And I need not to elaborate. We all know about this thing. Okay. So I think this was the last slide. Thanks a big thank for patient hearing. Over to chairpersons.
So thank you very much, Dr. Sachin sir, for
Thanks.
very wonderful talk on thin fat Indians. And you have nicely described the crux is that although we Indians are very thin as far as our BMI is concerned, but the fat percentage of our body is high, and which makes us insulin resistant, and so the diabetes is more and more in our India. And just a simple question: is it related to our habit of strong food conservation for emergency purpose? Like as we are also concerned about the money which we are storing all the time.
Yeah. This is our genes. This is in our genes. Generations there was famine in India. So
ये हमारे जीन में है स्टोर करना.
yeah, हाँ, genes में. This is the thrifty, that is thrifty gene hypothesis. And whatever we eat, we store in this central part. That is to get in starvation time, so that we can get that fat, our meals, fat from that stored food. But now we have abundance of meals, and still we are eating more.
We have that habit of
And
storage.
not utilizing that food, not utilizing by exercising. Previously, people, they used to go. There was no option to walk. I have ridden my cycle. I used to go by cycle. My son, he needs a scooter. So now we have cars. So this is something the change has made. The luxury, we are paying tax for our luxury. Okay.
Means no expenditure and only conservation.
ऐसा इकट्ठा करते जा रहे हैं.
So thank you very much. And so the next talk, Dr. Arvind, do you want to say something?
Yeah, the next speaker is Dr. Sonali Patange from Mumbai. She is going to speak on estimating CV risk in diabetes, use of scoring system. Over to Dr. Sonali Patange.
Thank you, sir. I'll be sharing my screen. At the outset, I would like to thank RSSDI and Dr. Bansi Sabu, sir, for this opportunity. I think it's very pertinent because this hall is named after my mentor and guru, Dr. V.S. Ajgaonkar. So thank you very much. My topic today is estimating CV risk and DM, use of scoring systems. Diabetes mellitus has become the most prevalent chronic disorder in the past few decades. With the experimental rise in cases across the world, it has become one of the leading causes of death worldwide. So real concern lies in both the vast prevalence as well as the major complications associated with DM, especially CVD, and CVD being the leading cause of morbidity and mortality in type 2 diabetes.
Your slides are not visible, ma'am.
Oh, 1 minute, sir. Sorry. Is this okay, sir?
Yeah.
Very sorry about that. So introduction is that we all know that CVD is the leading cause of morbidity and mortality. The CAPTURE study was the first global study to uncover prevalence of CVD in type 2 diabetic patients. showing us that the prevalence of ASCVD within the type 2 diabetic population is very high. 9 out of 10 people with type 2 diabetes and established CVD have an atherosclerotic CVD. Life expectancy goes on reducing with no diabetes having a normal life expectancy. You look at diabetic patients already reducing by 6 years, and with diabetes, MI and stroke less than 12 years. So what is a CVD risk calculator? It is used to generate a patient score for the absolute risk of specific CV outcomes based on the weighting of independent risk factors. Some of the common diabetes specific CVD risk calculators are UKPDS and Advanced. UKPDS risk score is actually a diabetes specific risk calculator that estimates the 10-year risk of future coronary artery disease and stroke. Advanced risk score assesses the risk of developing cardiac complications associated with diabetes over 4 years. There are other validated CV risk calculators as well, such as ASCVD risk estimator, QRisk3, but they are not really specific to diabetes. Let us have a look at the UKPDS risk calculator. This is the risk engine. It takes into account age, duration, sex, presence of atrial fibrillation, ethnicity, smoking, and also HbA1c, systolic blood pressure, total cholesterol, and HDL cholesterol. Thus, it gives us a 10-year risk of CHD, a fatal stroke, and a fatal CHD also. So let us remember that UKPDS actually had the massive amount of type 2 diabetic patients. 5,300 patients followed up for a period of 10.7 years. So they have the longest 53,000 patient years behind them. This is the advanced scoring. Here we are looking at the age at diagnosis. There are points given. So depending upon the age of the patient, duration of diabetes, so that also has a point system. Gender, that has a point system. Atrial fibrillation, retinopathy, treated hypertension, pulse pressure, HbA1c, albuminuria, presence of normo, micro and macroalbuminuria, non-HDL cholesterol. And from that, because of these points, you are getting a 4-year risk assessment. So total points 5 or less is less than 0.5, and it goes on to above 83 for the next 4 years. 2013, there was an ASCVD risk estimator which came out, which helps the healthcare workers and patients estimated 10-year and lifetime risk for ASCVD, which uses the pooled cohort equations and lifetime risk predictions tools. But however, since this is derived from the Framingham score, which actually had only 5% of the total 5,000 patients enrolled who were diabetic, so I think UKPDS and Advanced works way more than the other calculators. So ASCVD risk calculator pooled cohort equations take into account age, sex, race, total cholesterol, HDL, systolic blood pressure, treatment, diabetes, and smoking. So accepted range of values are right here, and these are the optimal values where we want our patients to be. So when we are talking about the risk discussion, the potential for ASCVD risk reduction benefit, actually, if the decision is unclear, we have to consider an LDL if it is more than 160, family history of premature ASCVD, a lifetime ASCVD risk, abnormal CAC score or ABI, HSCRP more than 2, potential adverse effects, drug-to-drug interactions, management of other risk factors, healthy lifestyle, and also patient preferences. So we are looking at the aspirin therapy in appropriate patients, blood pressure control, cholesterol management, and smoking cessation. So this has to be discussed based on the calculators, so then we can ask our patients to have a healthier lifestyle. So these are the risk enhancing factors. The ASCVD is the family history of premature ASCVD, males less than 55, females less than 65 years of age, primary hypercholesterolemia, LDL cholesterol of 160 to 189, and non-HDL of 190 to 219. Metabolic syndrome, like we have already seen in the previous talks also, the increased waist circumference is a risk, elevated triglycerides, elevated blood pressure, elevated glucose, low HDL, chronic kidney disease, EGFR between 15 to 59, with or without albuminuria, not treated with dialysis or kidney transplantation, chronic inflammatory conditions such as psoriasis, rheumatoid arthritis, or HIV/AIDS, history of premature menopause or history of preeclampsia, high risk ethnicity, South Asian ethnicity, definitely, Persistently elevated lipid markers like primary hypertriglyceridemia, if measured high HSCRP, elevated LPA, elevated ApoB, and an ankle brachial index of less than 0.9. So to summarize, the prevalence of ASCVD we know in the type 2 diabetic population is very high. Indians are at high risk. Common diabetes specific CVD risk calculators are UKPDS and advanced. ASCVD risk estimator is one of the validated CVS risk factors, but is not really specific to diabetes. Risk assessment tools can be used as a guide for decision making in the primary prevention of CVD. CV disease in diabetes actually follows a gradient which can be captured with identification of these risk factors. Thank you so much for your kind attention. At the end, I would all like you to welcome you all to CID 2.0, 24 to 25th December in ND Film Studios, Mumbai. Thank you so much.
Thank you, Dr. Sonali. It was a wonderful talk on the ASCVD risk factor scoring. It's very essential for diagnosing and managing diabetes, and also detect the risk factors and treat them accordingly so that the mortality and morbidity can be reduced. Over to Dr. Ashok Jain for the next speaker.
The next speaker is Dr. Shefali Dr. Karkhanis. If she is there, then she will be talking on gaps in diabetes care, challenges and solutions. Dr. Shefali, please.
Thank you very much, sir. I'll like to share the screen, please. The thing is, I really thank Dr. Banshi Sabu, Dr. Sanjay Agarwal, sir, Dr. Vasant, sir, for giving me the honor to be a part of this esteemed conference. Are my slides visible, sir?
Okay.
Yeah. So today I'm going to talk about gaps in diabetes care. What are the challenges that we face, and if possible, provide some solutions. We know that India is home to the second largest number of adults living with diabetes. And as Dr. Gupta has so beautifully explained, we are the typical thin fat Indians with high insulin resistance and greater insulin secretory effect. And we have an earlier onset of diabetes as well. The sad part is 4 and 5 people with diabetes are uncontrolled, with only 22% of the people having an HbA1c of less than 7. The DiabCare India 2011 study has shown that the HbA1c, if we calculate all over India, is almost 2% higher than the ADA recommended target. So this means that we are not really treating optimally. The mean age was, of course, younger than that in Europeans. And unfortunately, the patient sought treatment only when the complications had started to set in. So it was a delayed visit to the physician as well. Comorbid conditions and other chronic conditions like hypertension, dyslipidemia, obesity, depression were also very common. The TIDE study also revealed a similar kind of a picture where about 76% of the patients had a poor glycemic control. Now, all of this it shows that we need to implement strategies to improve the glycemic control of India. So what are the challenges that we face? One is patient-centric, second is community fallouts, third is physician-centric, and fourth is the infrastructure and government-related. Let me deal a little about all the 4 points. The patient-centric issues and community fallouts go hand in hand. The first and foremost, as we all know, is the lifestyle. Second is the the health unawareness. So people are not really aware of what the chronic conditions can be and what problems they can cause and complications they can cause in future for them. There is a lack of access to medical care, diagnosis and testing, especially in rural Indias. Financial affordability is always a challenge. In fact, patients who have money also do not want to spend upon their healthcare, especially in chronic diseases where there are no immediate symptoms. We do not get time off from work for visiting the doctor, which unfortunately, given the population of India, a visit to the doctor can range from anywhere between half an hour to even 4 hours. And that means there is loss of pay, and patients do not want to really sacrifice their leaves for visiting the doctor. There is a social stigma associated with diabetes. So people do not want to reveal that they are diabetic, and then they end up eating um, tea with sugar or the mithais or whatever is offered to them. There are a lot of misconceptions which are held along with diabetes. And unfortunately, the social media just adds fuel to the fire. There is a suboptimal distribution of human resources and infrastructure. And this again is causes a downfall of the health system of India. If you talk about lifestyle, the START study clearly has indicated that all across India, take any state, about 60 to 70% of the energy intake for Indians is through carbohydrates. And this translates into a higher postprandial peaks. Glycemic excursions are more common, and this reduces the control of diabetes as well. With the improvement in our economic conditions, there is reduction in the physical activity because every household, even in rural India, has a two-wheeler. And then who will walk when you can ride is a motto of today's world. The amenities are aplomb. The stress level starts very young. This might be mental stress, physical stress, emotional stress, and of course, financial stress as well. Whether the patient is poor or whether the patient is affluent, both the categories are malnourished. The malnutrition is in poor people is because there is inadequate supply of food, and in affluent countries there is too much of fast food. So both of them will suffer from diabetes. Alternative therapies are again available in our market in plenty. Everybody has their own version, and unfortunately, they feel that alternative therapies are a substitute for allopathic medicines. They are not used as adjunctives, which it should be used as. If you talk about adherence, again, the cost of the medication is one of the most important cause for patients to stop medications or reduce the dose on their own. Complex regimens of medication, especially in elderly senior citizens who are living alone, it is difficult for them to understand and maintain the complexity. The perception of the patient and their family of the side effects of the medicine is another factor why they are in a hurry to stop the medications. Family support is now lacking with the formation of nuclear families. Peer pressure is tremendous. I'm sure all of us and every one of our patients must have heard कि आज खा ले इतना सा कुछ नहीं होता है. So that is where you're tempted, and usually people give in to temptations. Festivities occur every month, unfortunately, in our country, and every festival is associated with at least 3 sweets which you have to taste. Skipped meals are very common. Either it is because of work pressures, patients because of meetings, or because of fasting purposes, etc., etc. But irregular food timings are definitely a problem, especially in urban India. Stress and emotional problems we've already discussed. Let's talk about physicians. We do have a little bit of a clinician's inertia. So we do not really optimally treat the patients. We tend to still go in a stepwise approach. And this probably leads to sort of hyperglycemic memory, which will translate into complications. The cost of the medicines have to be taken into account, because if it is too expensive, the patients are not going to follow through with the prescriptions. Most of us have a very busy practice. There is a lack of time where the patient counseling, patient empowerment cannot be attained. The primary physicians sometimes do not refer the patients at time to endocrinologists or podiatrists or other specialties as required. There is something new happening every day in the field of medicine, especially in the field of diabetes, and we need to update and keep updating our knowledge every time. So again, we do not, because we are not updated, we cannot integrate our evidence into practice. We have beautiful tools of information and technology available at our disposal, and unfortunately, I don't think we are utilizing it to the full extent. So what can we do? We know that this is a progressive disorder with a need for therapy which influences every stage of the natural history of the disease. Polypharmacy, FDCs, etc. have made it easier and more patient compliant, but we need to simplify guidelines. This is a beautiful paper which was published in 2018 which shows that most of the guidelines which we follow are based on evidence from high income countries. Now, applicability of these guidelines into a middle or a low income countries is a critical challenge because they are inadequate in terms of applicability, clarity, dissemination plan, and do not take into consideration the socio-economic and ethical legal contextualization. In fact, the low and the middle income country guidelines are targeting mainly the healthcare providers. And I think it's a time to change this and make it more content development has to be such that they have to be accessible for people who are in the middle and low income countries. They have to not only incorporate healthcare providers, but also the community at large. And this probably will help us to form a good rapport between the patient, the family, and the healthcare professionals. We as physicians have already started bridging the gap, and we can do a lot more. A patient-centric approach for diabetes care is a must, including the sensitivity to the needs and the lifestyle of the patient, socio-cultural activities of the patient, including fasting, including food habits, including religious sentiments. We need a comprehensive team-based approach where a multidisciplinary approach where the whole team of doctors act as one for the patient's benefit. We need to attend ECMEs. COVID has shown that ECMEs are beautiful tools to impart knowledge. And just as we have a hybrid CME right now, this is a good way to disseminate medical information and latest technologies. Newer technologies are a must. CGMS has helped us to maintain glycemic excursions in patients and control their sugars a lot better. Teleconsultations, including video and phone consults in order to adjust the dose, have helped us to reach out to more patients, saving time, energy, money, and do not crowd they don't crowd our OPDs, they don't crowd our waiting areas, but we can give the same amount of care. Telehealth apps offer online diabetic educations, medicines, food time alarms, diet advices, online pharmacies. So all of this makes the life of a diabetic patient much simpler. And I think every physician should incorporate this for their patients. Audiovisual aids in the form of smart graphics, animations, audio clips, they can be kept on playing in the waiting room where the patients can actually listen and be bombarded again and again. Dissemination of the same via WhatsApp and other social media can help impart correct information instead of patients gathering information from the relatives and neighbors. Involving the local government to help good community practices is also very nice. And patient education tools are also important, including the lab test. We have to talk to the patients about diet, exercise, mental health, evaluation of their parameters, including renal parameters, feet, retina, as well as the cardiovascular events. I ask my patients to bring their medicines with them at every visit. It makes it easier to adjust the doses, to understand how they are taking and what medicines they are taking at what time at home. We can also ask them to write down their questions and doubts at home and bring the paper along so that it saves time and energy when we are giving and the patient goes home satisfied that all the doubts were explained for. Most important, refrain from taking advice and experimenting on yourself on basis of social media and Google is what must be stressed upon. To summarize, there is a huge burden of diabetes in India. We need to be aggressive in preventing and treating diabetes and its complications. We need a patient-centric approach. The patient must be made aware about diabetes, its medications, its complications, and the whole package. As such, financial and logistic issues do remain a problem in our country, but improved public healthcare infrastructure, along with well-designed community health insurance schemes and access to medications will help us to build a good India. Involvement of primary healthcare workers and community citizens with a political will can improve the health status of India, and probably we'll be a 76% in a euglycemic state instead of poor glycemic state. Contextualized strategies for prevention, identification, treatment, management, and financing of diabetes care within and with the population is the need of the hour. Thank you very much. And I also invite you to CID 2.0 on December 24th and 25th. Thank you very much.
Thank you, Dr. Shefali. Very fantastic talk, and very truly said that the patients, and most of our patients has either no money or no time, but in spite of having money and time, they don't want to spend it on medical costs.
True, sir.
And we physicians are also very busy and don't have time to educate the patient, truly speaking. And
True, sir.
one thing I want to add, that support of paramedical staff must be taken more and more, and some educated person in the villages must be trained
True, sir.
For the care of diabetic patient, like measuring blood glucose with glucometers and advising them for insulin, or how to put them on insulin and insulin injection. This must be,
Yes,
this
sir.
practice must be covered in villages. And the next thing, the use of media and apps, social app, on which Dr. Mohan Shuna will speak more. I think that part must be taken help to care of diabetic patients.
Yes, sir.
Okay, thank you very much.
Thank you very much, sir. In
Can I
fact,
make
sir,
a comment?
Asha, sorry, yes.
Dr. Shefali?
Yes, sir.
Yeah. Do you feel that we need more diabetes dedicated centers to treat diabetic patients?
Sir, it is very difficult for our population to have only diabetic dedicated centers. Unfortunately, urban India, yes, definitely. I have a dedicated diabetic center, so I'm not saying anything against it. But it is difficult in the rural population to have a dedicated diabetic center. But if we can impart even one diabetic educator to every center, that I think will work a long way. In fact, there was a study where the ASHA workers were trained to measure the BP and give diet advices on hypertension. And they saw that in that community, the hypertensive patients came down a lot. So if we can have something like this for diabetes, I think it will go a long way.
Yes. Thank you.
Thank you, Dr. Shefali.
Thank you so much, sir.
So the next speaker is Dr. Mohan Shenoy from Thiruvananthapuram. He is going to talk on the social media and apps and pros and cons about it. Over to Dr. Mohan Shenoy, please. He's a consultant endocrinologist and a regular speaker and resource person at major scientific summits and webinars. He has many laurels to his credit. Over to Dr. Mohan Shenoy. He'll be talking on social media and apps, pros and cons.
Dr. Mohan Shina, is he not?
Yeah, he's there. Over to Dr. Mohan.
I'm sorry, I was just getting into the system. I'll just change the background. 1 second. Yeah. Sorry for the delay. I was uploading my system.
No, we have enough time.
Yeah, sorry. So let me open my screen.
I think we have much time.
Yeah, because I was informed 4:45, so just I was getting my things sorted because it's raining here. So just okay, let me share the screen. I hope the screen is visible.
Yeah, it is.
So let me just start. So thank you, Dr. Banshi Sabu sir, and thank you, dear organizers, for giving me this opportunity. So this is a wonderful venture in which we'll discuss some new topics regarding social media and apps. And I will take you through the pros and cons. These are 10 slides and we will cover in 10 minutes time. So what is social media? Social media is a type of a new generation media in which we are portraying online content through our different networking solutions. These are the networking solutions we all know. There are many systems we already are familiar with. There are many giants. We all know so many giants in the names of our things like Facebook, WhatsApp, Instagram. These are all taken by one company, then Twitter, Google. There are many different types of social media engagements which we go through. And not a single day in our life is complete without social media. So amount of engagement time we spend on the internet is immensely high, and it's enriched by the content in which we are going through these media. So we know that these are here to stay. From the last several years, we are seeing that the use of social media is gathering momentum, and the number of social media apps are also very much here. So they are here to stay with us. So what can we do to educate and inform our public regarding this, and what can we as a doctor community do regarding social media is going to be the focus of my next 8 minutes. So we know that advent of social media means that whatever content we put, that is opinion, our photos, our scientific content, or our videos, all these are seen by the entire gamut of online media. So all the content are actually transparent, and there is a loss of privacy. And also we know that whenever you do some campaign or opinion poll or even time of elections, all these things we can do by healthy media marketing. So this is why this I have shown you the fourth monkey. We are all seen that in our own media. So the previous three monkeys we know no harm, like not seeing bad, not telling bad. So now there's a fourth monkey that is sum of all three. That is he or she sees nobody or hears nobody and speaks to nobody. That means entirely glued to the phone or the social media. So the humor aside, remember that all this information, which is actually governed by an IT Act of 2000, recently amended to include all the government sharing mechanisms by 2021 or 2020 recent amendments, which is why we know that all the social media content are actually getting legally important and binding with us. Let us see what are the social media strategies we should understand. So we know that the utility of social media is too much, and the modern, even digital medium is making it through the strategical way in which there is a planning of gross power, and not only the medical content, all the non-medical content, the hospital administration, the publishing, all these things are definitely having to be planned and done properly. Then is the listening and engagement. When we do some listening, always we take into consideration the pulse of the person who is viewing this content. And of course, how to engage our audience is the prime interest of such a mediums which we know. Ultimately, before you go to advertising and spending money on it, we have to see how far whatever we have done is analyzed properly, and then go for the final publishing or doing the reporting. So these are, my friends, the 5 pillars of social media and social media apps. So let us see the main focus. What are the pros of this thing? So whenever we say it is good, we should understand that the availability, accessibility, and ease of communication, and the rapidity in which these go into the multimedia network. So these are the awareness system. We know diabetes awareness, hormone disease awareness, any disease which is non-communicable is properly communicated, or now in the COVID context, all the multimedia messaging regarding the virus infection, all these things are available, which is why we all should be worried as well, because the content has to be accurate. I have not put another A, but accuracy of the content is the very important thing to be ascertained. So now we are knowing that now sitting in this room in the virtual distance, we are seeing there are barriers are breached. So which is why digital technology is very important in the information technology era. Of course, the last 2 years have been so beautiful because they have been relieved the boredom of all the community. So scientific community and the other communities alike are all very good, happy with whenever we return home with a lot of good videos which are getting shared. But remember that these are all important, that there is some commercial element, there is a business element also, which has been utilized by this marketing system. So there are some things called email marketing, pay per click regarding even internet. One click can give you the company money. Then search engine optimization, search engine advertising, content writing, because whenever we write a blog or blog, this all content gets screened and seen by all the person across the world. Then cross media marketing, which means that the content gets marketed across different social media. The one message in one media gets transmitted multiple times into the different media. Then ultimately, marketing has to be made sure the pulse of the community. The C stands for the creativity. So creativity, a person who is not previously intelligent also, the creativity can be very great and encourage the person's creativity and help them to connect with other persons. And we have seen the digital marketing of RSSDI done by Dr. Banshi Sabu, Dr. Rakesh Parikh, so many people last several months we have seen regarding defeat diabetes. That is regarding the pros of the diabetes care also being marketed. Then we know the telemedicine, digital diabetes marketing, all important discussion. So when a person comes to us as a client to see us as a patient also, remember that they already might have gone through the social media and information technology available in the visual and the print media. So discovering new friends and new persons, new ideas and new concepts. So these are all the reasons why we are definitely discussing the pros of this thing. Economy, because the E stands for economically getting into, because some people know that it is free of cost, but we know everything is not free. So we know the business marketing like LinkedIn has got a premium content in which we know that getting a job in the proper area of interest requires money as well. Education, the last 2 years, the education class system, we know that social media, all these have got recorded videos being shown for our children and the next generation. Ultimately, E stands for efficiency. So improving the efficiency is done by providing the content in the social media. So what are the criticism? Because I will not call them as a cons, because telling bad about social media is not a good thing. But still, what are the criticisms that the social media goes through? Firstly, I have shaken this picture from the movie released in 2010 by name The Social Network, in which the famous personality has been shown in this picture. I will not name the person, but we all know that this caption itself shows you we don't get to 500 million friends without making a few enemies. So that is a very important thing. So the person in the question had definitely discovered the medium social network, but that itself had been having a very much dubious distinction as such. So which is why addiction, the next generation, we know that habituation, dependence, screen time, over expectations, because the reality is different from what we see in social media. And cyber trolling, because very much persons who are known to doing these abuses, because a person who gives opinion on the internet are definitely not immune to criticism. So getting the content marketed sometimes gives you a bad name as such. So cyberbullying is bad, which is why the market has also come with new concepts of Cyberbully Prevention Act by Women and Child Department. Then inertia, because the person sits idle for many years, sitting is the new smoking. And screen time, whenever we see so many screens, more than 1.5 times or more than 2 hours per day, it causes a lot of harm inside the system. Ultimately, all boring, sometimes it goes into fatigue. The exhaustion, the fatigue goes into the work-life balance also get disturbed, and burnt out personalities can also occur. So keep yourself engaged always. And there is something called fear of missing out, or FOMO, which means that the person is always anxious, keeps on checking what happened, how many likes have come, how many people have seen my photo. That becomes a self-image booster. So fear of missing out is very important. It is seen in more often in the Instagram personalities. Ultimately, I have shown you the privacy and affecting the work-life balance. So this is the reasons why we should understand that not all which glitters is gold, which is why we should understand how to sensibly utilize the social media. And reality to be checked before posting any content. Remember that there may be fake news which can be circulated. So we know that news spreads faster when it is fake. So remember that whenever you make something public, there can be some criticism of fake news also. Then something called marketing can lead to so many criticisms, so many likes. We know awareness programs, panel discussions, so many things done online through apps can definitely needs to be authentic and totally accurate as well. So now we have to be responsible. The last 2 minutes, I will tell you how we can be responsible. We all read books when we were young. Definitely, I still am young. I hope all of you are young as such. So books are definitely portable magic. So we all read more books. Even books are seen in the digital medium, but still, whenever you read more, we learn more and become leaders in the future. There are more things in the books than what anybody can imagine. So many authors have so many things. So reading responsibly and utilizing the knowledge accurately is what we should remember in any media, not only social media. So what are the key takeaway points from my side? So these social media and social media apps are here to stay. We should all remember that there is a hope, because in future, identifying the target audience is always important. No hyping is important, because whenever we hype more, there is potential to fall down flat. Then we know we are collaborating for research. RSSDI, the R stands for research. So research collaboration is here by social media, which is what creatively utilized. We all know so many things have been done, therapeutics like digital therapeutics, because losing weight can be done hygienically by improving the sleep also. So how to count the sleep time, count the steps, and improve your efficiency is done by digital therapeutics. Then telemedicine potential. We know all of us are used to telemedicine, and our privacy also sometimes need to be protected in telemedicine also. And last several months and several, we know that there is some personality, eminent personality, who was saying bad about insulin also. So we have been happy that ESI, RSSDI, type 1 diabetes community also have united together in type 1 diabetes advocacy in helping our patients and potential community regarding benefits of type 1 advocacy. And all, we have to congratulate the president, vice president, the office bearers, the general secretary, all of us also, because successfully getting this campaign of defeat diabetes was possible only through social media. Ultimately, moderation is the key. So achieving the right exposure. So identifying the right person, the right personality, and the right exposure is important. So I still believe that when you do proper marketing, even the word of mouth marketing still remains the best one when you do it correctly. So thank you, everyone. This is my last message. I hope I have stuck to my time. Practicing mindfulness is very important, because what we learn becomes what we are. We are part of it. So learning books, reading more, publishing more articles, and learning through collaboration makes us stand taller than the rest, and helping each other is very important in this. So thank you. I bring you regards from Sri Gokula Medical College, a rural medical center, which I am working very proud to be associated with this center. Thank you everyone for this, and thank you RSSDI for this opportunity.
Dr. Mohan Shanoy, that was an excellent discourse of social media apps and pros and cons. It's very, very nicely depicted by you. Congratulations on that.
Thank you.
Any other questions? And over to Chair Dr. Ashok Bhai. I think Dr. J.K. Sharma is not here, so probably this will be the last speaker. Any other questions in the shelf, I think we can check out, and otherwise we'll close the session. Thank you very much, all the speakers. And once again, thank you, RSSDI, for giving us this opportunity to be on this stage and enjoy the sessions. Thank you very much.
Thank you very much.
Thank you. Thank you, sir.
Thank you.
Thank you.
Sir, mic is muted.
Sorry, you are always helping me several times. Thank you very much. So thanks every speaker who have talked very nicely, and thank you my co-chair Dr. Arvind Nair. And if there are no more questions, there are in the chat box, so we can close the session in time. Thank you very much, and we will meet again. Okay.
Okay. Thank you, Dr. Ashok.
Thank you, sir.
Hybrid session.
Thank you.
Hybrid session tomorrow, I think.
Okay. Thank you.
Thank you very
Right,
much,
sir.
everyone.
Okay.
Good evening, Dr. Makkar.
Good evening, sir. How are you?
How are you, sir? I am fine. I am good. I think there is 10 minutes left before we start the session.
Yeah. So I was in the other hall only, actually listening to something else. So
Okay.
just got the call.
Yeah.
But we have to start at 4.
At 5 o'clock.
5, yeah.
Sir, you want to start the session? Hello. Hello. Sanjay sir, you start the session.
So Dr. Deepak has joined us, or he's yet
Yes,
to
sir.
join? Okay.
Yes, sir. I'm here, sir.
So can we start the session now?
Yes, sir. Yes.
Okay. Good evening, everybody. At the outset, I would like to thank the organizers for inviting us for this very, very important session on the management and monitoring of the diabetes. We have a very senior and learned speaker lined up for today's session. The first speaker for our session is Dr. Bij Makkar, who will be talking on the FDC of vildagliptin, remogliflozin, and metformin. Can you run the slide of Dr. Makkar's introduction, please?
Dr. Sanjeev, should we start a little early? Because, at time happens that people want to listen to particular presentation and they join on time, but they will miss something.
Okay. So you want us to start right now, yes, sir?
No, I think we should wait. Ideally, we can, we have time does not mean that people who have to join, people who are looking for this session, they will join at 5.
I think I also think that we should start at 5 o'clock sharp.
Yeah, sharp 5 we will start.
Yes, definitely sharp 5. Okay, because somebody may join at 5 o'clock because the session is planned for 5 o'clock.
Yeah.
So we'll start at 5 itself. Okay.
Yes.
Okay.
Good afternoon, Arvind.
Good afternoon, boss. How are you?
I was waiting for you to join. Then only I thought we should start. They were about to start. I told them not to start till Arvind is shown.
I know. I was just hearing all the discussions that happened.
So how's everything?
Going on. How is the COVID threat? I think that's slowly disappearing.
Delhi is very comfortable right now. Delhi is very comfortable. Very low numbers.
I think it's the same with Bangalore also. At least the people have started coming back. The hospitals are running to the normal. How is it going on at RSSDA? How was the response?
I have no idea. I didn't check the numbers, but I think the sessions are going fine. I was in the other session just now. I was listening to Anjana's presentation. Then, before that, I was in this hall only listening to Chef Ali. So sessions are going fine.
Yeah, I think moving from session to session is always a problem, even for listeners when there are 6 halls.
Yeah.
I think that's the only issue. They're waiting for 5 o'clock so that the session starts at 5.
I suggested that we should wait. People at times who want to join a particular session, they will come only at time.
Correct.
Good evening, Dr. Arvind sir. How are you?
How are you? I'm doing fine. Thank you.
I'm good.
So everybody is speaking from home, or is everybody landed in Ahmedabad and sitting in Ahmedabad and speaking?
No, I am
at home. in my chamber.
Are you coming to Ahmedabad, Arvind?
No, see, because Bhavna's child is still very small. It's just 1 month old, and I have a child, a mother, and the grandmother to take care of. So
Yes.
I will not move out till December, because at least the baby will be grown.
Yeah.
You can kind
How's Shobha doing?
Shobha is doing good, and
very nice. And she must be very happy now with the grandchild.
she's extremely happy, because there was a time when she thought that she would not see beyond 6 months. That was about 6 years back, but now
she must have that time lost hope of seeing Bhavana's wedding also.
Absolutely.
What to talk of
Absolutely.
grandchild.
So I do believe in miracles, and now she is extremely happy. She's spending all the time with the child and literally teaching Bhavna how to take care of the child the way they were all taken care of. Even though the daughter doesn't listen, the mother pushes us and says, "No, this is what you do."
Great.
That's the thing. So when are you planning to become a grandfather?
My daughter has to get married first.
Yeah, so you have to start the process.
I am in the process. I am waiting for her not to be, positive.
Okay.
We are, actually after her for last 3 years now. In fact, we are seriously considering, but there were a couple of proposals. It took some time, didn't work out.
Now we missed Rajiv's daughter's wedding in Delhi. I think.
We all were at it.
If your daughter happens in Delhi, then I think all of us got to converge on Delhi.
Yes, you must. But hopefully sooner than later it will be there.
And I'm sure we'll also catch up sometime soon on the physical meetings, because it's been bugging. It's literally 2 years.
Yes, almost 2 years. Almost 2 years.
People are meeting in the people are there going to local meetings now. In our place, we have started local CMEs with few gatherings, 10, 12 people.
The local CMEs are fine, but the meetings, national or state-wise meetings, still.
Yeah, that hall becomes a good crowded hall, and a lot of people are there. So traveling from different places.
Sanjeev, the cost of air travel has skyrocketed. I mean, it's a phenomenal, one-way fare to Delhi or Delhi to Chennai or Bombay. I mean, it's 3 times what it used to be 2 years back.
So I think it is now coming down, because more and more flights are becoming operational. So even, Delhi, US return flight, New York used to be about 60,000. Now it is almost 1 lakh.
I know it's.
So, but now they are coming down.
Today, Times of India carries articles about how the prices are skyrocketing.
Yeah, but these airlines suffered huge losses also. They have to make up some money.
But all of us suffered losses.
Yeah, but these had expenses while they were just parked in the airports. Anyways, so I think Dr. Gulati, now we can start.
Yeah, I think we are good to start now. Okay.
Yeah, 1 minute away.
Yeah. So good evening, everybody. I am Dr. Sanjeev Gulati. First of all, I would like to thank the organizers for inviting me for this very, very important session. We have very senior speakers for this session. First topic will be taken by Dr. Bij Makkar, who will be talking on FDC of vildagliptin, metformin, and remogliflozin. I think this FDC has not yet come to the market, at least in my town. So we'll be listening to him about the new FDC of remogliflozin, metformin, and vildagliptin. Dr. Makkar is a very senior diabetologist. He is a director, Makkar's Diabetes and Obesity Center, Delhi. He's been honorary secretary of RSSDI from 2017 to 2019. Ex-chairman RSSDI Delhi chapter and member executive board Diabetes India, honorary secretary Indian Obesity Network, is a member of AACE International Committee 2014, 2016, 17, and AACE Professional Business Committee, AACE DSN International Workforce, UN USFC San Francisco, Cleveland Clinic, John Hopkins, and Oxford Diabetes Center, Mayo Clinic. He has been his course director for Cleveland Clinic Advanced Certificate Course in Diabetes 2010 till the date. He has numerous publications in the books, national and international journals. Over to you, Dr. Makkar, sir.
Thank you, sir, for a very kind introduction. Good afternoon, everyone on the other side of screen. And at the outset, I would like to thank RSSDI for this great opportunity. As member of RSSDI and member of executive, it is always pleasure to see this national conference becoming bigger and bigger and better every year. So without much ado, I'll share my slide set. Can you see my slide now?
Yes.
And I'm going to speak on the novel approach for holistic type 2 diabetes management, the pharmacotherapy with fixed dose combination of metformin, SGLT2 inhibitors, and DPP4 inhibitors. This is my disclosure slide, and this is a Glenmark supported presentation. Now, this slide basically shows that we have a huge problem of diabetes across the globe, and India is not spared. In India, on the last count, we had more than 77 million diabetic patients. Now, important thing is that patients with diabetes in India have unique problems. Most of the patients have poor A1C control, and we need to put them on medications to achieve better glycemic control. Asian Indians, we have faster decline in beta cell function, and therefore we need faster or more progressive intensification of therapy to have a durable glycemic control. Another important thing is the access to healthcare, because diabetes care is mostly taken care by out-of-pocket expenses, and the patients do not visit most of the time clinicians on time, and most of the patients are taken care by primary care physicians. So there is a delay in intensification of therapy, leading to poor glycemic control. There is poor adherence, again, because of the cost of therapy and repeat cost of visits. And, economy is an important factor, and ease of administration of medication is also important consideration, as most of the patients do not want to take any injectable therapies. Now, number of studies have shown that average A1C in Indian diabetes population is in the range of 8.5 to 9%, which is far higher than the target of less than 7%. This was the TIDE study, which was a real world evidence looking at the glycemic control in type 2 diabetes patients in India, and showed that more than 3/4 of the patients are having a A1C above the 7% goal, and more than 1/3 of these patients already have microvascular complications. We know from our understanding of pathophysiology of type 2 diabetes, which is the major chunk of diabetes and accounts for more than 97% of diabetes in Indian setting, that there is a progressive decline of beta cell function which happens during the course of diabetes. There is insulin resistance which increases in the beginning and stays constant, but the beta cell function goes on declining throughout the course of disease. And this necessitates progressive intensification of therapy in due course of disease to achieve glycemic control, which gets worsened with the progressive decline of beta cell function. And there is repeated increase in the medication which is required to control glucose, and ultimately most large number of patients will require insulin also. Now, because of the gaps in intensification, large number of patients stay in poor glycemic control for pretty long durations of time, and therefore they are predisposed to develop a higher percentage of complications. Now, if we look at the adherence to therapy is also quite low, and various studies have shown that in anywhere between 1/3 to 1/5 to 1/2 of the patients only adhere to the therapy that is prescribed to them, and more than 50% patients are non-adherent to the prescribed therapy. Another important thing is that most of the patients who have type 2 diabetes are on multiple drugs. So if you look at the data from this particular study, the patients with type 2 diabetes are taking, most of them are taking anything between 3 to 8 medications on daily basis, and between 2 to 4 of these medications are anti-diabetic agents. Now, studies have shown that if you combine two agents into one pill and thereby reduce one pill burden, this was a study which looked at the separate administration of vildagliptin and metformin versus a fixed dose combination of metformin vildagliptin, showed that just converting two medications to one improved the adherence by 26%. Which is very important. And better compliance to therapy is also important for having the better therapeutic benefit in terms of reducing the A1C. With each 10% increase in adherence, there is decrease in A1C by 0.1%, and with every 10% decrease in the adherence, the A1C goes up by 0.14%. Now, till about 2008, we conventionally understood that type 2 diabetes is caused by two core defects, the insulin resistance and beta cell dysfunction, leading to hyperglycemia. It was only 2008 when Ralph DiFronzo, in his Banting oration, gave the concept that hyperglycemia is caused by more than just these two defects, and there are actually 8 pathways which are contributing to development of hyperglycemia. And because there are multiple pathways contributing to hyperglycemia, multiple agents are required to address the various arms of this ominous octet to control hyperglycemia. Now, if we are using combination therapy, it provides benefits in terms of targeting multiple pathways, leading to early achievement of the targets, improved glycemic control, reduced risk of complications, and maybe a delay in the disease progression or delay in the beta cell functional decline. And if we have fixed dose combinations, possibly we will have better compliance also. So now we have multiple drugs available because we have multiple pathways to address. And if we can put them in one single pill, then possibly we will be able to achieve a better adherence to therapy and better targets in terms of achievement of goals. And this was clearly shown by DiFronzo's group that if we start, this study basically compared the stepwise intensification of therapy as was recommended at that particular time by the clinical practice recommendation versus the pathophysiological based approach using a 3-drug combination of metformin, pioglitazone, and a GLP-1 receptor agonist, and followed up these patients for 2 years and showed that triple drug combination achieved a better A1C reduction, which was sustained over 2 years period. And this is the 6-year follow-up data, again showing that if you start with multiple drugs to begin with, and you have a sustained control over a longer duration of period as compared to the progressive intensification of therapy that was recommended by the clinical practice recommendation. Now, when we are looking at the choice of drugs that are available, there are certain key considerations that we have to look at before we select a drug for the treatment. First and foremost is the efficacy in terms of A1C lowering, and of course then the risk of hypoglycemia, because that's a big deterrent in increasing the dose of any treatment modality that we use. Then we have to consider the effect on body weight, safety and tolerability. The cost of therapy is very important in terms of having long-term compliance and adherence. And of course, then we have to look in terms of CV benefits now with newer agents showing CV benefit or CV neutrality, and also the renal benefits. Now, if we look at the triple drug combination that is in consideration that in this presentation, if we look at the combination of metformin, DPP-4, and SGLT2 inhibitor, this combination provides moderate to, in fact, very high efficacy in terms of A1C lowering. There is no increase in the risk of hypoglycemia. There is, some weight reduction, which is a beneficial effect. The adverse event profile is very much tolerable. The cost of therapy with the newer agents like SGLT2 inhibitor, particularly remogliflozin, which I am talking in this presentation, becomes moderate to low. The metformin has been shown to have some CV benefit, DPP-4 are CV neutral, and now SGLT2 inhibitors, if you look at, though Remo does not have CV outcome data, but possibly there is a class effect, and we have some proven, CV and renal benefits from the various SGLT2 inhibitor studies. So this appears to be a very good triple drug combination with all the plus points. Now, when we are considering a fixed dose combination, we have to keep certain things in mind. And this was an expert opinion published very recently in 2020, which, expert panel opined that fixed dose combination, whether they are double or triple, they should help in improving the patient adherence to therapy, reduce the cost, should play a crucial role in achieving glycemic targets effectively. However, you have to keep in mind that this combination that you are picking up has the rationality of combining these drugs, and the tolerability should be good. In addition, the drugs which are being used in combination should have different mechanism of action so that they provide synergy of effect. The pharmacokinetics should not be very different so that can be combined in one pill. The combination should not have additional increase in toxicity, and combination should also be complying with the clinical practice recommendation. Now, earlier available combinations are metformin, sulfonylurea, glitazone, and metformin, sulfonylurea, and AGIs. But if you look at the current guidelines, they possibly are not the best combinations according to guidelines. But if you look at the combination of metformin, SGLT2 inhibitors, and DPP4 inhibitors, they provide a synergy in terms of mechanism of action. The pharmacokinetics is such that they can be given as one or two pills, and their recommendations are very much in sync with the clinical practice recommendation. If you look at 2020 AAC clinical practice recommendations, it clearly recommends that SGLT2 inhibitors and DPP4 inhibitors, along with metformin, should be higher up in the hierarchy of choices when we are making choice for treatment. Now, first triple drug fixed dose combination to be approved in US by US FDA was DAPA, Saxa, and metformin, and 2020 Empalina and metformin has also been approved as a triple drug combination. Now, if you look at the advantages of this combination, and in terms of looking at various pathways that are addressed, the combination of DPP4 inhibitors, SGLT2 inhibitors, and metformin possibly addresses almost all the components of ominous acted, provides a significant and durable reduction in glycemic parameters. It also have cardio-renal benefits, and possibly there is some beta cell preservation as shown in the experimental studies. There is no increase in toxicity of any agent because of the presence of other agent. There is some weight reduction. There is no low risk of hypoglycemia. There is low propensity for drug-to-drug interaction, and possibly it's a very good cost-effective combination if we compare with metformin, SGLT2, and GLP-1 receptor agonist. Now, if you look at the combination of Remo, metformin, and vildagliptin, which has been approved very recently in September 2020 by DCGI, this has been studied in Forever study, which was a phase 3 study comparing the efficacy of a triple drug regime with metformin, Remo, and vildagliptin versus Empalina and metformin. So this was a randomized trial based double-blind, double-dummy, parallel group conducted across 23 sites in India, and compared Remo-Vilda FDC plus metformin to Empalina FDC plus metformin for efficacy and safety in Indian type 2 diabetes patients. This was a basically 16-week long study. Almost 400 patients with type 2 diabetes who were on stable metformin treatment with metformin of 1500 milligrams for at least more than 8 weeks and had A1C in the range of 8 to 11%, were randomized to Remo-Vilda add-on to metformin as a fixed dose combination, or Empalina fixed dose combination added to metformin, and followed up for 16 weeks. And the A1C was measured at 6, 12, and 16 weeks. And the patients were further followed up for 2 weeks after the study period. And if you look at the total withdrawals were only in the range of 10%, and the population that was analyzed in modified intention to treat analysis was almost 95% of the population. If you look at the uh, patient profile, both the groups were very well matched. Age in the range of 51 years, body weight in the range of 68 to 70 kg, EGFR around 95%, baseline A1C in the range of 9.3% in both the groups. Now, if you look at the A1C reduction, there was absolutely similar A1C reduction, whether it was 6 weeks, 12 weeks, or 16 weeks in the Removilda plus metformin group compared to Empalina plus metformin group, with showing clear non-inferiority between the two groups. And this is, if you look at the decline in A1C on 3 different time points, it was very similar in the 2 arms of the study. There was similar A1 fasting glucose reduction in the 2 arms. There was similar reduction in the postprandial glucose levels in both the arms. And if you look at the weight reduction, again, that was similar in both the arms. If you look at blood pressure reduction, both the groups had even blood pressure reduction of 2/1 millimeters of mercury, and adverse events were also not different in two groups, whether it was treatment emergent adverse events or drug related or adverse events of interest. And if you look at this, there was, the most common adverse event that we want to look at is the hypoglycemia, was totally very low and not different in two groups. The incidence of urinary infections was low, and incidence of genital infections was also very low. And that is expected if we look at data from the SGLT2 inhibitor and DPP4 inhibitor combination studies. So this study showed that triple drug therapy with metformin, Remo, and Vilda was associated with early and consistent glycemic reduction, reduction in the body weight and blood pressure, no additional safety risk or adverse events, and all the findings were comparable with the triple drug combination of metformin, EMPA, and LINA, with demonstrated non-inferiority in the glycemic reduction. So to sum up my presentation, early, adequate, and durable glycemic control with better compliance are prevalent unmet needs of the Indian type 2 diabetes patients. A rational fixed dose combination therapy offers potential solutions for addressing the unmet needs. A triple fixed dose combination of metformin, SGLT2 inhibitor, and DPP4 inhibitor provides a favorable efficacy and safety with added extra glycemic benefits. And if you look at the FDC of Remo, metformin, and Vilta, it provides effective, safe, and economical option for managing type 2 diabetes. Thank you. With this, I come to end of my presentation. Over to the chair.
Thank you so much, sir. It was really a crisp and informative session about fixed dose combination, which is again a need of today in management of type 2 diabetes. Thank you so much, sir. So we'll take a few questions right now, or we'll move on to next speaker. What do you suggest, sir? Makar, sir.
You can take just now. No problem.
Yeah, we have a couple of minutes left before the next speaker. We can take it right now also. Sir,
yes, sir.
Is this available in the market, or have you used this?
It has just become available. In Delhi, it has become available now.
Okay.
Yeah, in Gujarat and in my district in where I'm practicing in Junagadh, it's also available right now, and I have started using it as well. So my question is that, sir, so it should be a OD dose, or conventionally it should be a BD dose?
Vildagliptin conventionally is a BD dose. Remogliflozin conventionally is a BD dose. Metformin 2 grams you cannot give in single dose. So you can actually, it makes a lot of sense giving it twice daily.
Right, sir.
In the trial, they have used FDC of Remu and Vilda along with on the top of metformin.
See, neither triple drug FDC of Empalina metformin is available in India, nor this was available. So when the trial was conducted, they saw the comparison between 3 drugs, metformin combined with the FDC of 2 drugs.
Vilda and Remogliflozin and Empa and Linagliptin.
So if you see cost-wise, if we are giving BID dose, again, I think it is around 16.5 or 17 something. So it will go up to almost 35, 34 rupees.
But if you have Empalina combination with metformin,
that's true, sir. But if we give in like single dose, separate remogliflozin or vildagliptin, which is again a cheaper generic brand. So I think it can be a bit cheaper as well.
No, I think still it will cost more or less same or maybe higher.
Same.
I think
always
higher, I don't know the exact cost, but I am pretty sure that whenever they make fixed dose combination, there is always a cost advantage.
Okay, sir.
So we move on.
Well. So if you permit, sir, we can start next speaker lecture.
Thank you.
Thank you so much, sir. Sanjeev, sir, please introduce Arvind,
we
sir.
move on to we move on to very important talk today, that nowadays we are always talking of the cardiovascular implications of various oral hypoglycemic drugs but Dr. S.R. Arvind is going to tell about the glucocentric approach in the era of cardiorenal outcome studies, lesson from the advanced study. Could you please run the introduction slide for Dr. Arvind, sir? So Dr. S.R. Arvind is a very senior diabetologist, director and chief diabetologist, Diacon Hospital, Bangalore, India. The course director, PG Studies of Health University, RGUHS and RSSDI, President RSSDI 1516, President Diabetes India. He has over 100 papers and has conducted over 100 phase 2 and 3 clinical trials. Dr. Arvind, sir, please, over to you.
Thank you. Thank you so very much, Sanjeev. Makkar, I think that was a great talk, and I really enjoyed, because I'm one of the investigators who have actually done this.
Thank you so much.
So thank you so very much for a great talk. I think we need, the drugs which is available as an FTC. Can somebody allow me to, share my screen, because it is blocked from the organizers? Or I think they will have to take out my introductory slide and allow me to share my slides. Anybody in the organizer side? I think take out my introductory slide and allow me to share my slide, please. No, it says I cannot share my screen. Somebody has to take out the.
No, it is showing you are viewing Brijesh RX event screen. So Brijesh has to unshare that screen, whoever is there on the side.
Let me call them, sir.
Yeah, I think they're starting.
I think we should make a call. Yeah.
No, it's already there.
It is
now you can share.
He has stopped sharing his screen.
Yeah, stopped sharing the screen. I hope you can see my screen now. Give me a call, please. Thank you very much. I think after Dr. Makkar's talk, this talk again is all about advance, and we're going to be talking about the glucocentric approach in an era where people have been talking about the cardiorenal outcome studies. And this advanced study was actually done by Serdia, and it's a contracted lecture for me. And then I would like to thank RSSDI, Banshy and his group, Dr. Makkar, and all the others who have been a part of RSSDI and Serdia for having asked me to actually talk about the lessons that we have learned from advanced trial. In fact, from 2008 onwards, we have been learning a lot of things about what exactly the glycoside XR has actually done. Now, the first question that comes to our mind at the present day is, does glucocentric approach provide benefits in a cardiorenal outcome trials? Let's look at what exactly Advant has told us over the years. In fact, way back in 1997 itself, UKPDS clearly told us that if you go for a tight glycemic control, you can reduce the risk of microvascular complications. And what we saw in the UKPDS was a clear evidence of a 16% risk reduction in MI. But people were not happy with the 16% risk reduction with an MI. So this glucocentric approach then was criticized as it showed lesser than expected benefits concerning a cardiovascular outcome, because people were expecting much more. And at that time, our understanding of the actual role of glucose control was not very clearly known. And then we were not very clear about the multi-pronged treatment that diabetes really requires in order to reduce the cardiorenal benefits. But let's see what happened after that. So Advance was actually designed to look at both microvascular and macrovascular complications. And it was designed to see if a HbA1c can be pushed to 6.5 or less, will there be a benefit? And this was regardless of the initial blood glucose concentration. So the target of HbA1c was much lower than what we saw in UKPDS trials. Now, this is the patient population in the advanced trial. Important to remember, there's a huge number of patients. There were 11,140 patients. Mean age was 55. They were diagnosed after the age of 30 with a mean duration of diabetes of 8 years and a HbA1c of 7.5. And you look at the other parameters, the history of major macrovascular complications, the risk factors were present in 1/3 of the patients. Microvascular complications were present in 1/10 of the patient. And other major risk factors, especially vascular disease and microalbuminuria, was present in 28% of the patient right at the beginning of the trial itself. Now, this is just a comparison of the patient population that we saw in Advance versus Accord and VADT, because whenever we talk of Advance, invariably Accord and VADT also comes into the picture. There was a definite difference as far as the HbA1c was concerned in the Accord trial. It was 8.3. Remember, Advance was 7.5. And the mean duration of diabetes was about 10 years. In Advance, the mean duration of diabetes was about 8 years. So just to recapture, I have moved the slide back. So there was a definite difference there. Now coming to VADT, HbA1c was 9.4 and the mean duration of diabetes was 12 years. Now these are very, very important points to remember, that if you start late, the legacy effect, the bad legacy effect would have already settled. It's like you have taken your car to a very bad road and your car is damaged. You can't bring it back onto good roads and try to see whether the car will actually automatically become normal. This is the lesson that we learned actually after the Accord trial. But let's come back to our glucocentric approach. These were the differences between Advanced, Accord, and the VADT. Now, what we saw in Advance was something tremendous, and we all know that glycoside extended release was used, and the target HbA1c was 6.5, irrespective of the patient's baseline characteristics. That is what was done in Advance. And we did see the reduction of HbA1c to 6.5 in the patients who took part in this trial. And this was the intensive arm of the Advance trial. And this reduction of HbA1c was seen across different BMIs, across different age groups, and across different durations of diabetes. So it did not matter what the BMI was, it did not matter what the age was, did not matter what the duration of diabetes was. The group or the arm which was targeted to get an HbA1c of 6.5, the intensive arm were able to get to that level of 6.5. Now, what happened after that? So there was a 10% reduction in combined, that is both micro and macrovascular complication. So we were able to see this over 5 years itself. Both micro and macrovascular reduction happened in the intensive control arm compared to the standard arm. Now you go back and visit ACCORD and VADT. You will realize in ACCORD, when they targeted an HbA1c of 6, there was an increased mortality. In VADT, there were no significant effects at all. Of course, the drugs used were completely different. And ACCORD study had to be stopped because it increased the mortality. Now, if you go back and look at these 3 trials, there were low rates of hypoglycemia in the intensive treatment arm of the advanced trial. And in ACCORD, the hypoglycemia was about 16%, VADT was about 21.2%, and in advance, it was 2.7%. Now, there's a very, very clear message here. Okay, the clear message is, even if you go for intensive control, the intensive arm that received glycoside XR experienced very few hypoglycemia in advance. Was this the reason for the huge difference that we saw? Well, we don't know. That was the speculation that we had then. Probably the biggest advantage that the patients in the advanced trial saw was very, very low rate of hypoglycemia, which is equivalent to what we see in some of the DPP-4 trials today. So the publication very clearly mentioned that a strategy of intensive glucose control involving glycoside XR-based regime that lowered the HbA1c to 6.5 yielded a 10% relative risk reduction in the combined outcomes of major macro and microvascular complications. Now look at the weight gain. Huge difference between ACCORD, VADT, and advance. And in advance, the weight gain, in spite of intensive control, targeting HbA1c to 6.5, the weight gain was only 0.1. Because there is a myth that if you go for intensive control and try to bring HbA1c down below 7, there is a good chance that you may actually put on weight. And now advance is clearly telling us that it did not happen in the advance trial. So there were a number of papers after this looking into the weight changes and the predictors. Many people said that, okay, we have to look at why advance did not show the reduction, why advance did not show the weight gain. In fact, one can read these papers at a later time, but what came out is the patient characteristic associated with weight change were actually the age, ethnicity, smoking, and HbA1c. And the main treatment strategies predicting weight gain were the use of insulin and thiazolidines. So advance did not use thiazolidines. We know about that. So the weight gain was not seen in the advanced trial. Now, what surprised everybody in the advanced trial was the reduction in the risk of EASD to an extent of 65%. And if you look at the numbers needed to treat to prevent one EASD, is surprisingly low for macroalbuminuria at 41. Albuminuria, whether micro or macro, is 152. Overall is about 410. So the renal benefits that we saw in advance has not been shown with any other sulfonyl urea. And this has never been shown by a DPP-4 so far. This was a trial which went in with a glucocentric approach, which showed a combined 10% reduction. And they looked at the renal benefits. It was a clear 65% with no weight gain and no hypoglycemia. And this data is there. And people have looked into this data from all corners, trying to see what exactly is this drug actually doing. And regression to normal from albuminuria, especially from macro to normal, was seen in 20%. So I asked the same question. Now, if you have to use a sulfonylurea, here is a sulfonylurea which has shown fantastic reduction in HbA1c and reduction in both micro, macro, and most importantly, the renal benefits that we have seen with this sulfonylurea is not seen with other sulfonylurea so far, and definitely not seen with any DPP4s. So the criticism or the myth that is sulfonylurea causes weight gain and hypo has been clearly busted with the data that we have in advanced trial. And that is what the publications have also clearly told us, that the data suggests that intensive glucose control may be an important strategy to curb the growing number of individuals receiving dialysis as a result of diabetic nephropathy around the world. And 20% reduction that we saw in advance is something highly praiseworthy. Today is a time when SGLT2s have shown us very clearly the cardiorenal benefits. DPP4s have not shown that kind of a benefits. And will the guidelines over a period of change, because only fear we had with sulfonylureas was the weight gain and hypoglycemia. That has clearly been now bursted with the data that we have from advance. And look at the renal legacy. After the trial ended, the patients were followed up for a period of 10 years to see what happens in the group which had intensive control earlier. In fact, the renal legacy continued and there was a reduction of 46% in EASD after 10 years. I'm sorry, ESRD after 10 years. And these benefits were greater in patients with preserved kidney function. There was, of course, a change in patients who did not have CKD and they were in CKD 1 and 2. But those who did not have CKD and who had preserved renal function showed a much better thing. That means trial ends, 10 years later, people's HbA1c has changed. Some of the medications would have changed, but still the renal legacy continued in the patients who participated in the advanced trial. So the publications that followed this clearly gave a message that the risk-benefit profile of intensive glucose control in patients with type 2 diabetes and impaired kidney function appears similar to that observed in those with preserved kidney functions. And of course, all this happened without any evidence or an increased risk of cardiovascular events or death. That's an important thing. Now look at the cardiac events also. Before that, we'll go across some of the points about the eGFR levels in the intensive treatment advance. Now, during the follow-up, the mean HbA1c level in the intensive glucose control was significantly lower than the standard glucose control in eGFR arms. But irrespective of the HbA1c, irrespective of eGFR, the HbA1c showed a good change. Now, when it comes to the cardiovascular benefits across eGFR levels, irrespective of the eGFR, there was benefit in the intensive arm. Irrespective of the eGFR, there was a reduction in major macro and microvascular complications. Irrespective of eGFR, there was benefit as far as the CV safety was concerned. Now, they also looked at ASCVD risk of the patients. It was divided as risk equal to or less than 20%, maybe 20 to 40%, and a risk with 40% and above. And across ASCVD risk, of course, the risk score engines were used to calculate this ASCVD risk in these patients, but across the ASCVD risk, there were macrovascular benefits and there were microvascular benefits in the advanced trial. So the final say was that therapeutic strategy and a regimen of intensive glucose control with glycoside extended release is equally beneficial for improving CV outcomes, irrespective of the existing ASCVD risk in patients with type 2 diabetes. So it started off as a trial. to see about macrovascular complications when you intensively treat somebody to get a HbA1c of 6.5, and it started in 2008. It did show a combined microvascular complications, both micro and macrovascular benefits to an extent of 10%. 2012, it was very clear that it is weight neutral. There was no weight gain. In 2013, we were able to find out a fantastic reduction in the renal parameters. And we saw the renal legacy benefits in 2016. And over to 2020, we are looking at the benefits across the cardiorenal continuum. So glucocentric approach still has a role. Now, in summary, these are some of the points that we have discussed on that. So glucocentric approach is still a very important approach to prevent macrovascular complications. Never take it out of your mind. And advanced with used glycoside XR clearly achieved a target HbA1c of 6.5 with very minimal hypoglycemia and weight gain, and vascular benefits seen in advance irrespective of ASCVD or renal status of the patient. So these are the important take-home messages. And today, of course, is an era of SGLT2 and GLP-1 for CV risk reduction. But a few points that we should remember is, it is not the glucocentric approach that these drugs are using. The mechanisms are still not clear and established. And the benefits that we see from SGLT2 and GLP is unrelated to glucose lowering, as it occurs very early. That's what we have seen in the trials. And the CV benefits occur too early to effect of the weight reduction. So the future is probably going to rethink about this advance and probably think, why don't we actually add a glycoside extended release to metformin and an SGLT2 drugs? Now, how do we compare a sulfonylurea like glycoside XR and a DPP4 today? Just take a second and look at these points which I have put down. Glycoside XR regime has shown vascular benefits. DPP4 has done nothing so far. Weight neutral, no hypo, reduces sugar to some extent. The sulfonylurea like glycoside XR has better glycemic efficacy compared to DPP4. And myths about weight gain has already been busted. Yes, a slight increase in hypoglycemia is seen in patients taking sulfonylurea. It's not a side effect, it's the result of a better efficacy. Or I can say a very poor education on part of a physician who has not taught the patient what to do in case of hypoglycemia. Or it can be an error on part of the patient. So hypo, I don't think should be a side effect, because when you give insulin, you know you're going to get hypo. So when you're using sulfonylurea, it is the patient education that's important. At this point of time, sulfonylureas have overwhelming evidence to move up the ladder as a second add-on to metformin or a third add-on to met plus an SGLT2 combination. I really don't see a DPP4 dominating. The only advantage of a DPP4 here is, of course, no hypoglycemia, no weight gain. Apart from that, I don't think DPP4 can score over sulfonylureas anyway. Considering that the worldwide growing number of patients with diabetes, especially in India with 73 millions, as caregivers, I think we must follow a dialectical thinking and choose a synthesis approach where glycemic control is as important as control of cardiovascular risk factors and should remain the target to be achieved. We know macrovascular complication is a multi-pronged treatment. You need to use much more than just glucocentric. You need ASARB, you need statins, probably a drug like SGLT2 or a GLP-1. It is a multi-pronged treatment. So today for diabetes, what we have to practice is both the glucocentric and cardiocentric approaches are necessary for a disease as resilient as diabetes mellitus. Thank you very much for your patient hearing. With that, I will stop sharing the screen. Thank you so very much.
So I think Dr. Deepak is not here. So thank you very much for, okay, over to you, Dr. Deepak, please. You have muted your mic, sir.
Sorry. Thank you, Arvind sir. It is always a pleasure to hear. And yes, it was a very nice informative lecture. And you have the main summary part, what the last slide you have added. That was again very good, informative for all of us, how we can see this advanced study in our day-to-day clinical practice. Thank you so much, sir.
Yeah, I think it was beautifully explained by Arvind sir. I am almost convinced now that if not the second, the third drug in my chamber should always be a sulfonylurea. It's our duty to always the good glycemic control should always be the first goal of ours in a diabetes patient. Then comes the cardiovascular complication, and when we are now, I am almost convinced that these drugs are still very useful. Thank you, sir, for very beautifully explaining the details of advanced trials. Thank you. Thanks a lot. So if there are no questions.
Any questions in our chat box as well, sir?
Yeah. So should we move on to the next talk by Dr. Devgaonkar, sir?
Sir.
Yes, I am there, sir. Should I start my sharing screen?
Yeah. The next talk will be by Dr. Devgaonkar from Nashik, and he will be talking on the GLP-1 as an anti-obesity drug. Dr. Devgaonkar is a very senior physician and diabetologist, organizing secretary for RSSDI National 2020, honorary secretary for state chapter RSSDI Maharashtra, past president Maharashtra Association of Physicians, organizing secretary for MAPCON RSSDI and US Emergency Medicine, joint secretary Indian College of Physicians, Dean Place, former member board of studies postgraduate medicine and allied subject Maharashtra University of Health Sciences 2020 to 2017. Over to you, Dr. Narayan Devgaonkar.
Thank you, sir. Should I start sharing screen?
Yeah, please.
Just a minute. At the outset, I would like to thank organizers for giving me this opportunity. Basically, the talk which has been given to me is GLP-1 receptor agonist as an anti-obesity drug. We know that this drug is mainly used in treating the patients for diabetes. But here, we can use this drug as an anti-obesity drug. And recently, it has been US FDA has approved this drug as an anti-obesity drug in 2021. We know that obesity worldwide has increased almost 3 times since 1975. In 2016, more than 1.9 million adults and 18 years old were obese, and the incidence has been increased. Of these, over 650 million were obese. 39% of adults aged 18 years and over are overweight in 2016, and most of them are obese. Almost 13% are obese. Over 340 million children and adolescents aged are 5 to 9, in between 5 to 19 years old are overweight. So this is the incidence of obesity, and the drugs available to treatment of obesity is
Devgaon sir, sorry, I'll just Dr. Arvind Iyer, please mute your mic, please. From RX event yes, thank you so much, sir. Go on.
Yes, sir. As we know that the limited drugs are available in treating the patients of diabetes, treating the patients of obesity. Several drugs were come in the market, and because of their side effects, they have to go back. But initially, the drug which was approved was phentermine in 1959, and liraglutide has been approved recently in 2014 as a number 3 milligram as an anti-obesity drug. Several drugs that were initially approved were subsequently has gone out of market because of its side effects. As we know that the drug which was used was initially fenfluramine, dexfenfluramine, sibutramine, lorcaserin, and recently the GLP-1 analogs. The glucagon-like peptide, we know that GLP-1 is the endogenous incretin hormone, and this hormone, we know that this is the secretion of this hormone is dependent on the glucose-dependent secretion. So the chances of getting hypoglycemia is comparatively very less, because the higher the sugar, the secretion will be more. And it is secreted by the small intestinal L cells in the distal ileum and proximal colon after ingestion of glucose and other carbohydrates. Having a low concentration during fasting, if the blood sugar levels are less, the GLP-1 levels are also less. That means it is dependent on the glucose levels. GLP-1 receptor belong to the G protein coupled receptor family. It is mainly expressed in the pancreas and central nervous system, and also found in the heart, kidneys, blood vessels, and peripheral neurons. What is GLP-1? GLP-1 binds to its receptor, particularly pancreatic beta cells, increase insulin production in a glucose-dependent manner due to enhanced intracellular levels of cyclic AMP. It promotes survival and proliferation of pancreatic beta cells. GLP-1 inhibits glucagon secretion by pancreatic alpha cells, thereby reducing hepatic glucose production. Other biological effects of endogenous GLP-1 include slowing gastric emptying, increasing postprandial satiety, and ultimately it reduces the food consumption because of reducing the appetite. GLP-1 influences the neurons of the paraventricular and arcuate nucleus, attenuating the orexigenic signals, and it also reduces the appetite. Main biological effects of GLP-1 are not only on pancreas, but it also has effects on liver, central nervous system, gastrointestinal system, cardiovascular system, and renal system as well. In pancreas, we know that it increases the insulin secretion, thereby reducing the blood sugar levels. It decreases the glucagon secretion, thereby reducing the blood sugar, and it stimulates the pancreatic beta cell proliferation and their survival. It reduces the liver, reduces the glucogenesis through liver, increases glycogen storage, reduces lipogenesis. In central nervous system, it reduces the appetite, thereby reducing the weight. In gut, it has slows down the gastric emptying, and it slows gastric motility as well as it reduces the appetite in these patients, thereby helping the reducing the weight. In cardiovascular system, it reduces the systolic blood pressure. So it has got a pleiotropic effects, where it has got effects on almost all the systems. And these are all positive effects which are helping in reducing the weight also. GLP is a 30 amino acid peptide hormone. Its short half-life is very low. It is 1.5 minutes following intravenous dosing, and it's 1.5 hours following subcutaneous dosing in humans. Rapid degradation of the endogenic GLP-1 is by DPP4 enzymes, and these properties have posed challenges to the pharmaceutical use of this drug. The GLP-1 receptor agonist, given the beneficial effects of GLP-1 on glucose metabolism, its weight, there was an immense interest in developing a pharmacological compound which mimic the action of GLP-1. The first GLP-1 receptor approved for type 2 management was synthetic exenatide 4. Eventually, it was named as exenatide, and it was developed using the venom of the Gila monster lizard. Based on their pharmacological kinetics, GLP-1 receptors are classified as short-acting and long-acting agents. Short-acting are characterized by periods during which patients are exposed to the drug concentration that lasts for only few hours. Under these are exenatide and lixisenatide. The long-acting, which produces a long-lasting circulating drug concentration with minor side effect, minor duration. It is a liraglutide, which is once weekly exenatide, dulaglutide, and albiglutide, and now it is a semaglutide. So liraglutide and semaglutide, there are studies which has been already published, and it has been approved by US FDA as a weight-reducing drugs. Liraglutide in weight management, body weight management. Liraglutide can activate GLP-1 receptors found in hypothalamic region, thereby reducing the feeding, such as hypothalamic, paraventricular, and arcuate nucleus. In the arcuate nucleus, liraglutide stimulates the appetite-inhibiting pro-opiomelanocortin hormones. It inhibits the orexigenic neuropeptide gamma, and it result with reducing the food intake and increase satiety. Liraglutide has proven its weight loss benefits in several clinical trials. These trials mainly lead to trials where body weight loss in a dose-dependent manner was noticed in the liraglutide 2.8 kilograms compared to the glimepiride group that had associated weight gain. On the contrary, the lead 5 trial, where it is the liraglutide produced significant weight loss, where it was compared with the placebo treatment, and versus insulin glargine also, the weight reduction was almost 3.43 in liraglutide group as compared to glargine, where we know that insulin glargine is known to cause weight gain rather than reducing the weight. Lead 6 trial, liraglutide 1.8 milligram per day and exenatide 10 micrograms twice daily produced significant weight loss. It is almost 3.24 kg as compared to the placebo. This is a scale trial, where scale clinical trial conducted in almost 126 sites in 9 countries, investigated the safety and efficacy of liraglutide as weight reducing drug and excess weight individuals with type 2 diabetes mellitus in association with 500 kilogram per day deficit and increased physical activity. So increased physical activity and exercise, we know that this is known to help and they have compared with liraglutide. After 56 weeks in subjects with type 2 diabetes, 3 milligram of liraglutide with most weight loss was almost compared to the liraglutide 1.8 milligram per day, and 6.4 kg versus 5 kg weight loss was seen. This ETD for liraglutide 3 versus placebo, it was -4, and for ETD for liraglutide 1.8 versus placebo was -2.71%. For both liraglutide, it is less than 0.001. Weight loss of 5 to 10% of body weight is associated with improved and improved outcome of comorbidities in type 2 diabetes. Weight loss of at least 5% occurred in 54.3% patient with liraglutide 3 milligram. Liraglutide as compared to liraglutide 1.8 milligram, it was 21.4% with compared with placebo. Reduction of at least 10% in weight loss was noted in 25.2% of cases with liraglutide 3 milligram, 15.9% of patients with liraglutide 1.8 milligram, and 6.7% with placebo. So if you compare with the placebo, the reduction of weight loss was quite significant. ETD between liraglutide 3 milligram versus placebo, it was less than 0.001. For liraglutide 1.8 milligram, placebo it was 0.006. It was quite significant. Scale obesity double-blind trial. Scale obesity and pre-diabetes double-blind trial investigated the patients with liraglutide 3 milligram per day. This was 56 weeks trial, 3,731 individuals with type 2 diabetes. The BMI of these patients was more than 30 or 27 kilograms per minute, when dyslipidemia or hypertension was also associated. At 56 weeks, liraglutide treated subjects achieved a weight loss of almost 8.4%, 8.4, with a loss of 2.8 plus or minus 6.5 kg. 63.2% of subjects in the liraglutide group had a weight loss of at least 5%. And 27.1% subjects in the placebo group was weight loss was almost less than 5%. Weight loss of at least 10% was encountered in 33.1% patients in liraglutide group versus placebo group. Liraglutide also shows very promising perspective in the management of obesity in individuals with under 18 years of age. In 2020, a randomized double-blind trial which investigated liraglutide 3 milligram as a weight reduction option in obese adolescent patients. Liraglutide was found to be superior to placebo plus lifestyle modification, where the BMI standard deviation score at week was 56. The US in 2014, US FDA approved this drug for weight loss, indicated as an adjunct to reduce calorie diet, increase physical activity, and weight management in adult patients with an initial BMI of more than 30 kilograms per square meter or greater, that is obese patients, or 27 kg per square meter or greater in the presence of at least one or other comorbid conditions like hypertension, type 2 diabetes, or dyslipidemia. Pediatric patients with age of 12 years and older with body weight above 60 kg and initial BMI corresponding was 30. The limitations of use should not be co-administered with other liraglutide containing products or other GLP-1 receptor agonists. Safety and effectiveness in pediatric patient type 2 diabetes have not been studied. Safety and efficacy in combination with other products indicated have not been published. Dosage and administration, we know that liraglutide we are using in patients of diabetes, type 2 diabetes. Those patients who are obese and type 2 diabetes. It is to be injected subcutaneously in the abdomen, thigh, or upper arm once daily at a time, same time, regardless of the timing of the meals. Recommended dose of liraglutide 3 mg per daily. Start the dose with 0.6 mg per day once week, per day for 1 week. In weekly intervals, increase the dose until the dose reaches to 3 mg. If pediatric patients do not tolerate an increased dose during the dose escalation because of its side effects, dose escalation for pediatric patients may take up to 8 weeks. The pediatric patients who do not tolerate 3 mg daily may be treated with reduced doses. Adult patients with type 2 diabetes should monitor blood glucose prior to starting the drug. Most common adverse effects reported in more than 5% are nausea, diarrhea, constipation, vomiting, and injection site reactions. Hypoglycemia is not that common. Dyspepsia, fatigue, and dizziness, abdominal pain may be there. The gastrointestinal side effects are common in this type of patient, and that is one of the commonest indications where we have to withdraw the drugs, because most commonly these side effects occur after initiation of the drug treatment and after increasing the dose. To minimize the impact of these adverse, it is recommended that it should be initiated at lower dose, then slowly increase the dose weekly. Warning: risk of thyroid cell tumors. Liraglutide causes thyroid cell tumors at clinically relevant exposure genders of rats and mice. The human relevance of liraglutide-induced rodent thyroid cell carcinoma has been determined. Contraindicated in patients with a personal or family history of the thyroid cell tumors or multiple endocrine neoplasia syndromes. Counsel the patient regarding the potential risk of this particular side effects. Personal or family history of multiple thyroid cell carcinoma, neoplasia, or hypersensitivity to the liraglutide or any patient, and pregnancy, it should not be used. Another important drug which has been approved recently and in India also likely to get in type 2 diabetes as oral drug is semaglutide. Semaglutide is approved, injectable semaglutide is approved for as an obesity drug, but oral semaglutide is yet to be approved as anti-obesity drug. These drugs are mainly tried in patients of type 2 diabetes mellitus. Semaglutide is also a GLP-1 receptor agonist with long elimination of half-life. Half-life of the subcutaneously administered semaglutide is almost 183 hours. So that is the reason why it is to be given once a week in the presence of normal kidney function. It's allowing subcutaneous administration per once a week. Approved once weekly subcutaneous semaglutide for the treatment of type 2 diabetes as well as in obesity. Weight loss efficacy of once weekly subcutaneous semaglutide appears to be compared with other once weekly GLP-1 receptor agonist. It's almost like same. Semaglutide treatment effects in patients with obesity, that is STEP trial. It is a four phase 3 clinical trials that tested the drug efficacy and safety. More than 4,000 adults with overweight were treated. They were randomized to receive a reduced calorie meal plan and increased activity or the lifestyle intervention plus semaglutide. For 68-week trial of subcutaneous semaglutide, 2.4 milligram per week versus placebo. Step 1 trial, Step 2, Step 3, and Step 4, February, March, and 2021. So these are recently published trials. All trials were in adults with overweight or obesity. Step 1 was in almost 1,900 patients. Step 2 was in 1,200 patients. Step 3 is almost 600 patients along with lifestyle modification. And Step 4 was in 800 patients. And after a 20-week run-in, and the trial examined further weight loss in subsequent patients. In the Step 1, 2, and 4 trials of individuals with overweight and obesity, those in the semaglutide group attained a 15 to 18% weight loss after 4 weeks. and dosage was well tolerated, and most common side effect observed was gastrointestinal side effect. They were transient and mild to moderate severity. 2000 in June 2021, US FDA approved this drug for weight loss. It is indicated as an adjunct to the diet and exercise. In chronic weight management in adult patients with initial BMI of more than 30 kg or greater and 77 kg or per square meter or greater in the presence of at least one comorbid condition like hypertension and type 2 diabetes and dyslipidemia. And it should not be used in combination with other seraglutide containing prescriptions. Safety and efficacy of co-administration with other products of weight loss has not been established and should not been studied in patients with history of pancreatitis. It also is to be administered once weekly on the same day of each week at any time, with or without meals. Inject subcutaneously in the abdomen or thigh. Initiate at 0.25 milligram once weekly for weeks. In 4 weeks interval, it should be increased up to 2.4 milligram is to be reached. The maintenance dose of 2.4 milligram once weekly is advisable in patients with type 2 diabetes. Monitor their blood sugar levels. Most common adverse reactions reported greater in patients were nausea, diarrhea, vomiting, constipation, and abdominal pain. The warning in rodents, semaglutide cause thyroid cell tumor, so it should not be used in such type of patients where there is a thyroid abnormality. Contraindicated in patients with personal or family history of multiple endocrine neoplasia syndromes, and counsel the patient regarding the potential risk of TMC. Personal or family history of medullary thyroid cell carcinoma in patients, and known hypersensitivity to the semaglutide drug. In summary, for decades, the world has been lacked in the effectiveness of pharmacotherapy of anti-obesity drugs. The few available drugs have been withdrawn due to side effects. Few options were available, that is diet, exercise, and bariatric surgery. Manipulation of the physiological satiety hormone with GLP is an effective and tolerated as anti-obesity drug with additional pleiotropic beneficial effects, and it welcomed the addition to the treatment options for obesity. Thank you. Thank you, sir.
I think some other session they have so it has gone.
Yes, sir. I'm here, sir.
So, Dr. Deepak, I think the organizers or the event managers have made some other session live before we could conclude our session. So, kindly conclude the session as.
Sir, sure, sir.
Yeah.
Thank you, Ajgaonkar sir, for this wonderful presentation. Sorry, in between I was having some internet issues, so couldn't last 5 minutes I couldn't be there. But overall, it was a nice session with the legend. We can have an opportunity to listen them and learn from them. So I thank Makar sir, I thank SR Arvind sir, I thank Ajgaonkar sir for this insightful all three sessions and giving your valuable time, sir. Thank you so much, sir.
Dr. Ajgaonkar, I think this liraglutide 3 gram is not available in our country right now. It's not approved for the use in as an anti-obesity agent in our country as of now. Seemingly.
No, basically this drug has been, US FDA just approved that drug.
As an anti-obesity agent.
Yes,
But,
yes.
But still we are using for type 2
Oral
diabetes.
oral semaglutide is not yet approved as anti-obesity drug. It has been approved like as a anti-diabetic.
But the liraglutide high dose is not still in our country is not approved as an anti-obesity agent.
Right. Yes, sir.
Yeah. So thank you. It was a wonderful session listening to all the learned speaker, Dr. Devgaonkar, Dr. Arvind, and Dr. V.M. Makkar, sir. Thank you, organizers for inviting us for this wonderful evening. Thank you all. Have a pleasant evening. Thank you.
Dr. Indukar, who is the next speaker?
After you, it is Sudhir Bhandari.
No, now next speaker is myself, right?
Yeah, you are first. Let me begin, then I will introduce you, and then you have to start.
Okay.
Event people, should we go ahead?
Yes, sir. I think we do have 5 minutes spare.
Okay.
And we can wait for 2 to 3 minutes. In between, we can introduce our speaker in detail, and we can utilize the time as well, sir.
Shailesh Trivedi joining or not?
No, sir, he is not joining, so I will be co-chairing you, sir.
Okay. Right, Deepak. Okay.
I just wanted to inform you regarding the same. So Dr. Deepak Sudasna will be chairing the session.
Fine. Wonderful.
Thank you so much.
Good evening, everybody. We are now on second day of virtual RSSDI Ahmedabad, and those who are joining this session at VS Ajgaonkar Hall. I would like to remind you that we are in the session named as Mixed Bag. We have 4 wonderful topics covered by equally learned, respected, and wonderful speakers. And we are going to begin with a very important, pertinent topic, hypertension and diabetes. We all know that these 2 coexisting diseases in India, Asia, and globally are making havoc, which is probably more severe, more serious than present pandemic. Unfortunately, Asians, having all bad things in the merit, we are thin Indians, but we are insulin resistant. We are not overweight, but we have more fat. And probably somewhere down the line, a denominator of insulin resistance goes across metabolic axis, metabolic disease. And to begin with, I have an initial topic named diabetes and hypertension. And to start this, we have none other than our senior, respected, wonderful colleague and speaker, Dr. Muruganathan from Tirupur. He is known very well with us in India, outside India, a very senior, respected emeritus professor at MGR Medical University, FRCP, FACP, FPCP, FICP, Governor, American College of Physicians, India chapter, Dean, ICP 2016-2017, President, HSI 2015-2016, past President, API, past President, Tamil Nadu IMA, past Dean, IMA CGP, Adult Immunization, Progress in Medicine, Medicine Update, Manual of Hypertension, has received a prestigious BC Roy Award from President of India in 2005. He is a Best Performing Doctor Award from Tamil Nadu Governor and received Lifetime Achievement Award from TN Dr. MGR Medical University. I think excellent speaker we have, and we are going to enjoy next 15 to 20 minutes with Dr. Muruganathan. I request him, sir, please go ahead with your topic, share your slides, and initiate the session. Over to Dr. Muruganathan.
Thank you, Dr. Indukar, for that nice introduction. And please enable me to share my slides. Yes. Is the slide visible?
Yes.
Okay. At the outset, I thank the organizers, Dr. Vasant Kumar, Dr. Bansi Sabu, the scientific committee chairman, and all our good brothers and sisters. As the chairperson has said, this is a very important topic, but unfortunately, we are not giving much attention for this deadly duo. There is no discussions based on the review of the data only, no conflict of interest. Okay, how common is this duo? Hypertension is twice as common in diabetes. Also, the new onset of diabetes is 2.5 times in hypertension. And unfortunately, both diabetes and hypertension are not under control in our country. The type 1 diabetes, the cause of hypertension in type 1 diabetes is mostly diabetic nephropathy. But now recently, metabolic causes also have been proposed. What causes hypertension? Diabetes. Metabolic syndrome, mainly insulin resistance, endothelial dysfunction, increased blood glucose, excessive ROS activity, and then sometimes diabetogenic antihypertensive drugs like diuretic and beta blocker. Drugs causing both hypertension and diabetes like oral contraceptives, corticosteroids. Hyperinsulinemia enhances renal sodium reabsorption and vascular reactivity. Angiotensinogen from fat cells. Our chairperson was saying we have more fat. Fat cells increase angiotensin 2, increase salt and water retention at the proximal tubule, increase the blood pressure. Some additional factors like increased sympathetic tone, endothelial dysfunction associated with hyperglycemia and advanced glycogen end products, increased free radicals, altered response to nitric oxide, genetic factors. I will show you all these in the slides. If you see the lifestyle factors like diet, inactivity, stress, smoking, genetic factors, malnutrition in the early life, drugs and hormones causes insulin resistance, which causes increased angiotensin, and that produces increased aldosterone, hypertrophy of the vascular smooth muscles, thereby hypertension. Same way, the insulin resistance, unopposed sympathetic activation, stimulation causes contractility of the vascular smooth muscle, and then peripheral vascular resistance leads to hypertension. The complications of hypertension, because of both together, the stroke is 75%, ESRD 50%, CAD is 35%, retinopathy is 35%, amputations is 35%. Overall, 60 to 80% of diabetics will die of CVD particularly. And then what are the American hypertension guidelines? In adults with diabetes and hypertension, antihypertensive drug treatment should be initiated at a BP of 130/80 or higher. Whereas European guidelines and our Indian guidelines say it's 140/90. And their recommended drugs is in adults with diabetes and hypertension, all first-line classes of antihypertensive drugs. Diuretics, ACE inhibitors, ARBs, and CCBs are useful and effective. Class 2B evidence, adults with diabetes and hypertension, ACE inhibitors or ARBs may be considered in the presence of albuminuria. So you should not, give an open target, generalized target. You must individualize target rather than blanket advice. Consider the age, life expectancy, previous or associated comorbidities, overall treatment burden, hypotension, drug side effects, expected cost complaints, resources, patient's attitude, and support system. In simple language, lowest blood pressure, which patient can tolerate without postural hypotension, compromise on critical vascular beds as well as quality of life. The strategy for management of hypertensive diabetic patients, proper blood sugar control, achieve target level of blood pressure control for diabetic patients, early detection of both diabetes and hypertension complications and manage them as well as delay their progression, improve patients' quality of life. One important drive-home message, if somebody has got diabetes, look for BP. Somebody has got blood pressure, screen for sugar, because both coexist. Also, those people are also having obesity. So these three things go together. So whenever somebody with obesity, metabolic syndrome, look for hypertension, look for blood glucose, and then monitor them, find out and diagnose early so that we can prevent the complications of both diabetes and hypertension. That is the key message. Now, in high normal blood pressure, more aggressive lifestyle measures. You see, forget about the target rate and the goal between various international guidelines. When somebody has got high blood pressure, like 130, 80, you ask them to go intensive lifestyle measures. Why? Even ordinary persons without hypertension, without diabetes, somebody should really do some lifestyle modification. Having said that, please also do not overdo things. Sometimes people who are enthusiastic, they do over exercise also, which is not good. But anyway, whenever you have any problem, consult the doctor and do exercise program according to their advice. While a blood pressure of more than 140/90, it should be treated with pharmacotherapy and achieve cardiovascular and microvascular protection. As the speaker, the chairperson said, Indians, especially South Asians, have a high risk. Even being born in South Asia itself, there is a risk factor for cardiovascular problems and diabetes. Okay, what are the lifestyle modification? Weight reduction. It definitely reduces 5 to 20 by reducing 10 kilo. When I said that, don't need to reduce aggressively 10 kgs. Even mild reduction also is good, and then gradually you can reduce. Then DASH diet. I had been listening to so many dietitians, diet advice, but none of us also follow. We said DASH diet eating, which means 3 to 4 servings of vegetables and fruits. But how many of us take 3 to 4 times of servings of fruits and vegetables? That is very important. That will reduce the blood pressure. You should have enough fruits, that will give fiber as well as potassium. Sodium restriction, physical activity, and especially TV watching. The modern risk factor is TV watching, be it a T20 cricket game or serials of so many programs in television. In fact, even television nowadays in the COVID times, don't watch TV because everywhere, get COVID. So you watch comedy, you watch, nice programs. But again, 2.5 hours, more than 2.5 hours each day is a risk factor. It's not advisable. Alcohol abstinence also very good, and stop smoking. Everything, all put together, lifestyle modification itself can reduce to 20 to 30 millimeters of mercury. Now, coming to the pharmacological therapy, antihypertensives. What is an ideal antihypertensive drug? It must decrease blood pressure, must reduce ROS activity and improve endothelial dysfunction, must prevent, improve or arrest proteinuria, must prevent and protect CAD, CKD, CHF, must be favorable on glycemic control, must improve the dyslipidemia, not worsen it, must not worsen peripheral arterial disease, must improve this here endothelial dysfunction, also erectile dysfunction, and not cause impotence, must not decrease eGFR and should not increase serum creatinine, must not raise uric acid and serum potassium. So ideal drug is this. They should have all these qualities, and it should be easily combined with other drugs, because nowadays for everything we have a combination therapy. So an ideal agent should not increase insulin resistance, well tolerated, most important, because the long-term treatment, cost effective, is very important. What is the general principle of treatment? It has been recommended that all patients should receive either ACE or ARB if there is no contraindication. Multiple drug therapy is generally required to achieve target blood pressure. When you use ACE or ARB, especially in young diabetic women, you should be careful because ACE and ARB in a reproductive age may be harmful for the fetus. So now, as I said, multiple drug therapy is generally required to achieve target blood pressure. Statin therapy should be given to achieve LDL cholesterol even less than 700. I, being the LAI, Lipid Association advisor, we always say less than 70 is good. Then why ACE is preferred in diabetes? Because it reduces BP with minimal side effects. They have no adverse effects on lipid metabolism. May reduce blood sugar concentration by insulin sensitivity. Decrease progression of albuminuria, renal protection is there. reverse vascular and ventricular modeling. So cardiac protection, renal protection, progression of retinopathy is also reduced. Unique CV benefit, reverse LVH, cardio protection, especially ramipril and perindopril. Coming to ARB, ACE and ARB head-to-head trial is not there, but evidence are growing for ARB also. Because telmisartan, drugs like that has got polymorphic activity and it is very useful in a diabetic hypertension. Unfortunately, several ARB outcome trials have avoided a head-to-head comparison with ACE. ARBs are an alternative in patients who develop ACE inhibitor-induced cough, but are more expensive. But of course, nowadays we get a lot of ARBs. See, now more ARBs have come into the market. Now less ACE inhibitors are coming into the market, which means ARBs are more popular now. Concerns of beta blockers used in diabetes, because beta blockers can mask hypoglycemia, prolong hypoglycemia, worsen hyperglycemia, and less protection for nephropathy and increases insulin resistance. Okay, because of these side effects, there are some concerns of beta blockers, but we cannot avoid beta blocker because withholding beta blockers in diabetes with CAD doubles mortality risk. Always use beta blockers in coronary artery disease, post myocardial infarction, LV dysfunction, tachyarrhythmias, heart failure, and increased sympathetic activity. Carvedilol and bisoprolol and nebivolol are preferable. So the newer beta blockers are preferable. Of course, atenolol after the ASCOT trial, we don't advise. Atenolol and diuretic, produces diabetes. So we nowadays don't use atenolol. But these drugs, the newer beta blockers, are very useful. Then coming to the insulin sensitivity, if you see, the carvedilol has the insulin sensitivity in the beta blocker. So if at all you have to use a beta blocker for post-MI or angina, carvedilol is good because it is also increases the insulin sensitivity. Then coming to diuretics, the practical tips, what are the diuretics we used? In elderly patient, especially isolated systolic hypertension, diuretics are useful. Low dose, combine rather than increase if targets not achieved. Best combine with ACE or ARB. Avoid combinations with beta blockers. I already told you, beta blockers and diuretics should not be combined because the chance of developing diabetes is more. Avoid in previous HNK or grossly uncontrolled diabetes. Chlorthalidone if creatinine is less than 2. Loop diuretics if creatinine is more than 2. Even today we saw one trial, the CTD is used in a person with EGFR of less than 30. They say the results are good. Indapamide may also be preferable, especially in an elderly person, especially when you have a dyslipidemia. Indapamide is the ideal drug. In resistant hypertension, in low potassium, the aldosterone antagonist should be given, spironolactone. Then coming to calcium channel blocker, it is a best add-on to ACE or ARB. In fact, worldwide, the best combination for hypertension is ARBs and CCBs. Because of the combination, the the glomerular arterial venous dilatation happens and then less edema because of the calcium channel blocker. Long acting, but unfortunately it is not useful in proteinuria. Whereas in non-DHPS cannot be used with the BBS, especially in CAD, it may be useful in proteinuria. Other classes, including alpha blockers, may be used under specific indications, such as symptoms of BPH. Now, when you use anti-hypertensive drugs in diabetes, dysglycemia, ACE and ARB reduces dysglycemia and also reduces dyslipidemia, whereas CCB is neutral. Diuretics increases dysglycemia. Beta blockers also increase dysglycemia and dyslipidemia. So whenever you give drug in diabetes, you must take care for the comorbid problems also. In fact, in diabetics with hyperuricemia, losartan may be a good drug because ARB and also reduce the uric acid. And now 2018 guidelines says, in addition, combination therapy is never recognized as the most initial treatment strategy. Even in the beginning, you should do. This is an algorithm. When the patient has got albuminuria, you give ACE or ARB. If there's no under control, add calcium channel blocker or diuretics. And then if the BP is not at goal, beta blocker can be added at the late stage. And then even if it is not under control, we can use alpha blocker and clonidine, etc. When somebody has got diabetes with CAD, The first line drug itself, you should add ACE-ARB with carvedilol, and then the rest of the things same. And I already showed you this pathogenesis of the hypertension. You can see, according to this, the ACE and ARB will reduce RAS system, and then calcium channel blocker here, and then the ACE and statin increase the nitric oxide delivery, and in sympathetic carvedilol and the diuretics and aldactone in this cycle, all these things produce optimal BP. Now, the trends in uncontrolled hypertension, only 27.3 patients had both systolic and diastolic under control. This is a study in the Indian population. Now, strategies to improve diabetic hypertension: screen for hypertension, depression, anxiety, educate the patients, control cost, genetic, formulary possible, then ask about adherence, decrease clinical inertia, team care, and please promote home blood pressure monitoring. When patients with diabetic hypertension, they are more worried about diabetes, not their control of hypertension. So now new ways of treating insulin resistance hold hope for counteracting both consequences and concomitant cardiovascular risk. The difficulties of managing hypertension is because of the ISH is more common, polypharmacy, glycemic control, renal jeopardy, depression, clinician inertia. Diabetes is a growing problem. Hypertension is a growing problem. Hypertension and diabetes are dying problem. Hypertension is preventable. So promote home blood pressure monitoring, home blood sugar monitoring, validated BP monitor. 3 different cuff sizes must be there. Just like diabetic clinics all over the world, hypertension clinics should be promoted. Hypertension specialists like hypertensionologists should be promoted, and never ever give up control over his diet, takes regular exercise, has time to relax, does the right toil in discharge of his duties, observes proper hours of sleep and awakening, balance in his actions and reactions, emotions and reasons, duties and rewards, conquers disease, says Bhagavad Gita. So learning is always a good beginning for health. Learning is beginning of wealth. Learning is beginning of spirituality. Thank you for your attention. I'll be happy to take questions. Over to the chairperson. Thank you very much.
Thank you, Dr. Muruganathan, for wonderfully enlightening us about the details of hypertension and diabetes, their coexistence, and the changing scenario in the therapy of hypertension and diabetes. One quick question from me. As we are using SGLT2 inhibitors since last 6 to 7 years, are they changing the therapeutics of management of hypertension in diabetics, or it is not affected, sir?
Actually, nowadays, any diabetic hypertension topic is not complete until we answer this question. SGLT is a very good drug, but whenever you use SGLT, there are so many other precautions you must take. And once the SGLT is suitable for the controlling diabetic patients, you should be very, very careful also in titrating the dose. SGLT itself can reduce the blood pressure to 3 to 5 millimeters. So whenever you add an antihypertensive drug along with SGLT, you monitor so that the patient may not go for hypotension. Of course, SGLT, you have already discussed in various forums. There are precautions and cautions which you should take whenever you give SGLT, for example, to prevent pelvic infection, when there is a bone density problem, when there is any other contraindication for SGLT. But SGLT is ideal drug, especially in diabetic hypertension. If a patient is not controlled with metformin, SGLT is the best combination in diabetic hypertension. When you give SGLT, please make sure you monitor the blood pressure. And when everything is okay, when the SGLT is indicated, please go ahead, because it also prevents heart failure. And SGLT is a good drug, provided the other conditions are suitable for SGLT. So there are a lot of trials now going on. Whether SGLT itself can be given, especially preserved ejection for cardiac failure. They are trying SGLT. So SGLT is going to be a cardiac drug than a diabetic drug sooner.
Thank you. Thank you very much. I thank Dr. Muruganathan again for excellent presentation. And now we go for the next session. We have wonderful topic coming up: beta cell dysfunction to de-differentiation. And the speaker is none other than Sudhir Bhandari, who is coming from Pink City, Jaipur. And he is one of the renowned speaker, colleague of ours, who is senior professor of medicine, consultant, internist, diabetologist, metabolic physician, and principal and controller at SMS Medical College and attached hospital, Jaipur. academically very strong, have multiple articles in multiple journals, chapters in books, and he has been awarded Dr. P.J. Mehta Young Scientist Award, Dr. Channa Reddy Gold Medal, State Merit Award by Home Honorary CM, Rajgaura Award by His Highness the Governor, Times of India, Health Awards. So I request Dr. Sudhir Bhandari to take up for his topic and request the organizers to give sharing of screens to Dr. Sudhir, and it is over to Dr. Sudhir Bhandari.
Before Sudhir comes, I'm very happy to share the podium with Sudhir, and very happy to see him after a long time. Apart from all his qualities, he's a very good human being, a very good, lovable person. Over to Sudhir. Thank you. Nice meeting you, Sudhir.
Thank you very much, Dr. Muruganathan. You have been very modest, very kind, and probably one need to learn humility from you, sir. So you are the role model of humility, and I extend my profuse thanks for being always so kind. Thank you very much. At the onset, I extend my profound thanks to Dr. Bansi Sabu, RSSDI, and whole team for having given me this opportunity. And I'm sure it is wonderful. Next few minutes, we should be able to, is very important. And I'll just start. I'll share the screen, sir. Yeah, it is a very interesting topic, the beta cell dysfunction and the de-differentiation. I think probably the story of diabetes begins with beta cell and ends with the beta cell. If you look at this, what causes the beta cell failure? There are different ways it can happen. Compensation by beta cell works only if the cells are robust. In susceptible beta cell, compensation fails. The defect creates weak link in the compensation process that promotes beta cell dysfunction, and hyperglycemia, once established, lead to glucotoxicity, promoted severe beta cell failure, and ultimately it lands up into the uncontrolled diabetes or hyperglycemia. The contribution of beta cell mass and function to the pathogenesis of type 1 and type 2 has been well depicted here, and the insulin resistance is both hand in hand with the type 2 diabetes. The insulin resistance and beta cell dysfunction are the core defect in type 2 diabetes, which has been very well established. The possible beta cell fates in type 2 diabetes and ways for recovery of the functional beta cell. Once the functional beta cell, there could be genetic predisposition and the cellular stress, which can lead either to beta cell death, which could be dysfunctional beta cell, or it can ultimately lead to de-differentiated beta cell, which finally goes into this kind of selection. The pathogenesis of type 1 diabetes, all of us know the development of type 1 diabetes is thought to be initiated by the presentation of beta cell peptides by antigen presenting cells, APCs. And these APCs bear these autoantigens migrate to the pancreatic lymph nodes where they interact with the autoreactive CD4 T lymphocytes, which in turn mediate activation of autoreactive CD8 T cells. These activated CD8 T cells return to the islets and lyse beta cell expressing immunogenic self-antigen on major histocompatibility complex class 1 surface molecules. It's a very intricate, pathological cascade. The beta cell destruction is further exacerbated by release of pro-inflammatory cytokines and reactive oxygen species from innate immune cells, and these macrophages, natural killer cells and neutrophils brings about the beta cell apoptosis. These autoantibodies can be measured in circulation and are considered a defining biomarker for type 1 diabetes. At diagnosis, people with type 1 diabetes have reduced beta cell function compared with the healthy controls. With amelioration of hyperglycemia, these beta cell can have a partial recovery of insulin secretory function, leading to so-called honeymoon period after diagnosis with minimal or no exogenous insulin needed. The beta cell abnormalities might also contribute to type 1 diabetes pathogenesis, leading to what is called a beta cell suicide, beta cell hypoglycemia, Beta cell HLA class 1 overexpression is common in pancreatic sections from cadaveric donor with type 1 diabetes. Overexpression serves as a homing signal for cytokine T lymphocyte. Additionally, evidence also exists for increased beta cell endoplasmic reticulum stress linked with accelerated beta cell death. Endoplasmic reticulum stress in beta cell has also been associated with alteration in messenger RNA splicing and error in protein translation and folding. Resultant protein products have been proposed as a potential immunogenic neoantigens. Type 1 diabetes is characterized by a variety of abnormalities that involve both islet and the exocrine pancreas. Hallmark of type 1 diabetes is the loss of insulin-producing beta cells and immune infiltrates of islets. Type 1 diabetes mellitus is a chronic autoimmune disease with a strong inflammatory component. Inflammation might contribute to early induction and amplification of immune assault against pancreatic beta cells. At later stages, no stabilization and maintenance of insulitis. There may also inhibit or stimulate beta cell regeneration and might cause peripheral insulin resistance. So the important key points are innate immunity and inflammatory mediators, the activation of both endogenous and exogenous ligands of pattern recognition, amplification of insulinitis might depend on dialogue between immune cells and beta cells. After transition to adaptive immune response, inflammatory mediators such as cytokines might contribute to prolonged functional suppression, and some inflammatory mediators might promote, and that's all leads to a severe autoimmune phenomenon. Inflammatory process that might contribute to type 1 diabetes has already been talked about. Interaction of beta cells and immune cells lead to induction and amplification of insulinitis and transition from innate to adaptive immune response. During progression of type 1 diabetes, beta cell most likely die from a combination of necrosis and apoptosis. Very important statement. Methods to visualize beta cell inflammation and beta cell mass are being developed. Molecular techniques have been applied to identify beta cell killing in vivo. And basis for long-term loss of beta cell remains unclear. It is possible that ongoing beta cell destruction is intrinsic. This is proven beyond doubt that these abnormalities are well depicted and histologically in vivo analysis. For example, C-peptide, insulin and proinsulin studies have provided evidence for the persistence of insulin-producing beta cell in long-duration type 1 diabetes. There are persistent mechanisms by which beta cell apoptosis has been taking place, and viral infections in type 1 diabetes also hits the beta cell. When the pancreatic beta cells are subjected to autoimmune attack, killing the majority of beta cell population while the neighboring alpha cells and delta cells are spared. Destruction of beta cell manifests as a failure to produce insulin. Consequently, patient with type 1 remains insulin dependent for their lifetime. And that is very important. There are certain viruses like enteroviruses, Coxsackie viruses, which trigger these autoimmune process. Many candidate genes for type 1 such as MDAS5, PTPN2 and TYK2 regulate antiviral responses in both beta cell and immune system. There has been decrease from clinical onset of type 1, deterioration of glycemic control associated with different degree of insulin resistance. There has been a beta cell dysfunction and mass which gets totally to the root cause of autoimmune type 1 etiology of the diabetes. Pancreatic beta cells are extremely sensitive to the blood glucose concentration. Changes in its homeostasis influence beta cell function and population, which is proved beyond doubt. Factors which are associated with progressive reduction of beta cell function and mass are: one is a lipotoxicity, which is well established. prolonged exposure to increased free fatty acid may have negative effect on beta cell function and lead to accumulation of toxic fatty acid metabolites in the islet cell. The autoimmunity and inflammation, markers of autoimmunity in phenotype 2, beta cell function, a possible role of immune system in the pathogenesis of type 2 diabetes. About 10% of individuals with type 2 diabetes, specific autoantibodies have been found out. Adipokines, hormone-like peptide on proteins released from adipose tissue. Leptin, pro-inflammatory cytokine, contributes to beta cell failure, may induce inflammatory reactions and apoptosis upon chronic exposure. Islet amyloid. Islet amyloid deposits in pancreatic islets have been considered a pathological character of type 2 diabetes, and its role in beta cell death has long been researched. Incretins, through binding on specific receptors on beta cells and increases of intracellular cyclic AMP and calcium, incretin stimulate the glucose-stimulated insulin secretion, improving both first and second phase response and restoring the biphasic profile. Because the stimulation of insulin synthesis occurs by upgradation of insulin transcription and translation and stabilization of insulin mRNA, beta cell secretory capacity and insulin stores are preserved. So there are multiple mechanisms which have been proposed for the beta cell dysfunction as depicted in picture. It is speculated that after a prolonged period of insulin hypersecretion, depletion of readily available insulin granules may occur, thereby reducing the insulin secretory response, may play a role in wider multifactorial setting of diabetes pathogenesis. Beta cell exhaustion. The strongest support for exhaustion concept comes from studies examining the benefit of beta cell rest strategies. That supports the beta cell exhaustion theory. When inhibitors of insulin secretion such as digoxide or somatostatin are given to animals or humans with diabetes, paradoxical increase in beta cell function are observed following a period of rest. This is a very strong documentation of this beta cell exhaustion theory. Furthermore, human subjects with poorly controlled diabetes demonstrated dramatic improvement in beta cell function following a brief period of intensive glycemic control. Assessment of beta cell function and main pathogenic mechanism can be done, and changes in insulin sensitivity. In fact, the proven that between the insulin secretion and insulin sensitivity, there is a non-linear hyperbolic relationship, and product of two variables is constant, disposition index. Therefore, a correct evaluation of beta cell function requires quantification of the insulin secretion in relation to insulin sensitivity, evaluation of disposition index, which is very important. There are surrogate methods of evaluation of beta cell function: fasting insulin, fasting C-peptide, HOMA-B, HOMA-2B, fasting proinsulins, intravenous stimulation test, intravenous glucose tolerance test, hyperglycemic glucose clamp, graded glucose infusion, and arginine stimulation test. There are various methods: oral stimulation test, oral glucose tolerance test, and mixed meal tolerance test, insulogenic index. That is a way we can assess. Understanding of beta cellular in type 2 diabetes, renewed focus on beta cell differentiation. How this may be prevented or reversed, extent to which other islet cells can be induced to differentiate into beta cell. Recent therapeutic developments, possibility of restoring endogenous beta cell function, although long-term stability, safety, and efficacy of these approaches is not yet known. Beta cell dedifferentiation in the diabetes is important, but what is this? When we talk of beta cell dedifferentiation, what after all it is? Dedifferentiation state of a fully matured beta cell can change with natural reversible events and during the progression to death. Hyperglycemia of diabetes is thought to be major determinant causing beta cell to lose their differentiation, also termed dedifferentiation, which leads to the dysfunctional insulin secretion. This process is also called as glucose toxicity, which can be at least partially reversed by treatment of hyperglycemia. Mechanism of beta cell dedifferentiation in diabetes Recent findings indicate that process involves coordinated and tightly controlled activation, repression of a specific transcription factor that drive transition from a stem cell to a mature beta cell during embryonic development and postnatal period until weaning. And this is proven beyond doubt the methods of beta cell dedifferentiation. Beta cell dedifferentiation characteristics were observed in mouse pancreatic insulinoma, beta cell exposed to high glucose for a long period, but massive cell that did not occur. A recent study showed that beta cells in type 2 diabetes patients lose their identity and cell mass, possibly even gaining features of other islet cell type, indicating that islet cell remodeling with dedifferentiation is the underlying cause of beta cell dysfunction during development of type 2 diabetes in human. Despite significant alteration in beta cell differentiation, phenotype, and decrease in the beta cell mass in human type 2 diabetes, apoptotic rate of beta cell remains relatively low. Growing evidence suggests that beta cell dedifferentiation may be a potential mechanism for loss of beta cell function and mass during development of type 2 diabetes. MicroRNAs potentially associated with beta cell dedifferentiation have been found, and these microRNAs are microRNA 7, 24, 30, 124, 184, and these multiple types of RNAs are there. So when we talk about beta cell dedifferentiation, there's a strong take-home message. Pivotal role of beta cell dysfunction in progression of diabetes, many factors that influence beta cell function altering natural course of disease. A correct assessment of beta cell function require concomitant evaluation of insulin sensitivity because two variables need to be judged in relation to each other. The clinical considerations are made regarding the therapeutic option which impact on various factors or mechanisms that contribute to progressive loss of beta cell function and mass. Pancreatic beta cell dysfunction plays a vital and complex role in pathogenesis of type 2 diabetes. Ultimately, it is a feature of beta cells to respond to the insulin requirements posed by the prevailing level of insulin resistance that leads to the development of type 2 diabetes. Various genetic and environmental factors conspire together in this state of beta cell susceptibility and decompensation. Thank you very much. And I think that's a brief presentation all about the beta cell dedifferentiation. Thank you very much.
Thank you, Dr. Sudhir Bhandari, for discussing a very complicated topic and making it simple. I think beta cell dysfunction we had been discussing since many years, but this dedifferentiation is something new coming up. And I think this is definitely going to make some clinical impact in future. But I think in clinical practice, evaluation of beta cell is still not reaching every corner of our country. Do you suggest simple 1 or 2 tests which can be done at every district place to assess beta cell?
Probably the C-peptide levels are the very simple tests which can be done at every smallest place, and probably C-peptide really guides you about the insulin therapy. And the bottom line is that we have to prevent the glucotoxicity. And as you recollect, Dr. Murgunathan spoke so well in his treatment modality of hypertension that there has to be a multi-pronged approach. And probably the bottom line of beta cell dedifferentiation is that we need to prevent the glucotoxicity by having a multi-pronged approach, and C-peptide could be the simplest test to find out the beta cell functionality at the smallest place. Rest all, there were a number of tests, but this is the simplest of the lot.
So I think we have to come out with this C-peptide assessment in most of the patients,
Yes.
so that a clinical guideline would be comfortable.
Yeah.
And as both my speakers have pinpointed importance of beta cell, their rest, glucotoxicity, we have to answer this. Thank you, Dr. Sudhir Bhandari, for wonderful presentation. And I thank you again on behalf of RSSDI, all of us. And if there are any questions from audience, we'll wait for a minute. Otherwise, I thank you and take up the second session. Thank you, Sudhir. Our next session would be coming up within few minutes, and the topic is very important to present era. It is immunity and acute respiratory infections. in diabetes. I think present pandemic and present epidemic of diabetes both are very pertinent and very important. I would request the event people to share me the intro of Dr. Agam. Yeah, that's great. And our speaker is Dr. Agam Vora, who is going to discuss this wonderful topic and pertinent to present era. Dr. Agam is Assistant Honorary and in charge Department of Chest and TB at Aryan Cooper Hospital in Mumbai. He is ex-associate professor in the Department of Chest and TB, KJ Somaiya Medical College, Mumbai. Assistant editor of Journal of Association of Physicians of India. He is on editorial board of Chest India, General Secretary of Academy of Advanced Medical Education, and President of Geriatric Society of India, Trustee of Malad Medical College, a medical association. To deliver this important, pertinent topic in present situation of COVID, I would request Agam Vora to take up, share his slides, and begin his presentation. Over to Dr. Vora.
Good evening, everybody. Thank you very much for having me here. At the outset, I must express my sincere thanks. Good evening, everybody. Thank you very much for having me here. At the outset, I must express my sincere thanks to my teacher, late Professor Director Dr. K.C. Mohanty, the organizers of today's program, my close friend Dr. Bansi Sabu and his entire team, Dr. Mangesh Tivaskar, again my very close friend and my diabetologist. All my respiratory cases, all my complicated cases, all diabetes management is done by Dr. Tivaskar, and whatever little bit of experience I have in managing respiratory infection and diabetes, the credit goes to him. All my patients, all of you who chose to be here on this working day evening, your presence encourages us to do more and more program and educational partners for today's program. The agenda for next 15 or 20 minutes I have is to give you some data, association of diabetes and normal lung, association of diabetes, lung infections and immunity, and some take-home message. While preparing for this talk, I was looking at my data and I just roughly scanned last 100 patients that I saw in my OPD. And I had this mix of cases with tuberculosis, upper respiratory, lower respiratory tract infection, stable asthma, COPD, interstitial lung disease, mainly IPF, and sleep apneas. And when I look at what was the comorbidity diabetes in them, and I found significant, all my 7 patients of OSAS had 100% diabetes. 2% of my asthmatics were diabetic, 8% of my tuberculosis were diabetic, 16% of my drug-resistant tuberculosis were diabetics. And you can see that elderly patients, diabetes was one of the major comorbidity in my respiratory cases. When I look at my admitted patients today, this is today's data, and the associated diabetes as comorbidity. Out of 7 AECBs, 3 are diabetic. Out of 3 sepsis, 3 are diabetic. 1 tuberculosis, 1 diabetic. 1 hemoptysis, same patient is diabetic. 1 community acquired pneumonia admitted today is luckily non-diabetic, and out of 5 ILDs admitted today, 2 are diabetics. And when I look at the association, it makes me think that immunity plays a major role. Every infection does not develop into disease, and we have understood this better during this COVID times. There may be a patient who may get completely asymptomatic COVID positive, and there may be some patient who develops a florid disease and you may even lose them, and there comes the role of immunity. And then what are the factors which reduce your immunity? And when I kind of think about it, these are the things that come to my mind is prolonged use of cytotoxic and immunosuppressant drugs, including steroids, high stress level, certain acquired immunocompromised status, certain food, chemicals, fertilizers, insecticide, but yes, diabetes and associated comorbidities like your liver failure, your kidney failure, patients on dialysis are responsible for lowering your immunity. And you all know this better than me, that why are we concerned about diabetes? Huge morbidity, huge mortality. So many people would die because of this diabetes and diabetes related complications by the time we finish our talk. Pulmonary infections in diabetes is characterized by altered host defense. in the entire body and more locally in lung, especially by altering the respiratory epithelial and ciliary function. Characterized by serious clinical features, longer duration, more frequent complications, and needless to say, more mortality. In diabetic patients with end-stage renal disease, there could be pulmonary infection-related mortality tenfold than general population, and hyperglycemia can alter host defense and makes him at a higher risk of acquiring infection. It impairs wide range of functions in neutrophils and in macrophages. They are particularly important in limiting invasion by pyogenic and other bacteria. So your neutrophil and macrophage are responsible for limiting infection, but hyperglycemia impairs their function, and movement of phagocytic cells to the site of infection is impaired. Respiratory infection is a leading cause of mortality and morbidity, and of course, the cost worldwide, not only in your area and my area. On the population level, patients with diabetes are more susceptible to respiratory tract infection due to a number of mechanisms. There may be age, unhealthy lifestyle, decreased immune function, increased risk of aspiration due to gastroparesis you may have because of diabetes, pulmonary microangiopathies you may get, and frequent comorbidities you may have with diabetes like renal failure and stroke. Not only infections, there are acute infections like community-acquired pneumonias, viral, sepsis, fungal infection, but also lungs are vulnerable with vascular complications like pulmonary vascular event, cardiac vascular event, airway disease, and there may be autonomic neuropathies leading to lung function changes. Approved uncontrolled diabetic will have PFT impairment, the FEV1, FVC, and FEV1 by FVC, all may be impaired. Interestingly, also patients with impaired glucose, intolerance of glucose, IGT, they may also have changes in lung functions, including lung compliance. Going into each, respiratory infections, mainly the acute infections, staph is a major bug responsible for both community-acquired and nosocomial pneumonia, and there is a high nasal carrier state. Diabetics are thought to be at an increased risk of this staphylococcal pneumonia. 30% of diabetics are nasal carrier for staph aureus compared to 11% in healthy individual, more than double. And the rate of nasal carriage of staph is directly related to glycosylated hemoglobin. So, better control and less likely of carrier state. Worse control, higher chances of them having a carrier state, and more so developing complications of staph pneumonia. There is a higher incidence of gram-negative bug also with uncontrolled diabetics, especially their susceptibility to laryngeal trauma. Patients admitted, you're doing intubations, etc., putting them on high risk of getting gram-negative infections. They stick to upper respiratory epithelium and also increase that kind of colonization in diabetic patient. Subsequent risk of aspiration due to gastric gastroparesis in diabetic patient is also known. Be it anaerobic infection, be it atypical infection, including Legionella and Mycoplasma, diabetics are at higher risk. The most common complications in diabetics because of acute respiratory tract infection, lower mainly, is effusion, the parapneumonic effusion, empyema, and sepsis or bacteremia. Fungal infections are also not uncommon, and during COVID times also we saw a lot of COVID-related complications, especially in diabetics who had uncontrolled diabetics and who went into complications like ketosis. And this is one patient of diabetic ketoacidosis where we diagnosed mucor. You can see that there was a big consolidation on left side, and on biopsy it was confirmed mucor. Viral infection, in fact, there are theories which used to talk about viral infection as a cause for type 1 diabetes. Viral infection may be dangerous in people with diabetes. There is increased risk of complications from disease like influenza. There are HBV, HCV again are more common in diabetes than all those who do not have diabetes. Influenza also is a cause of morbidity and mortality in diabetic patients, and during episodes of influenza pneumonia, the rate of ketoacidosis rises, and the mortality chances because of this ketoacidosis also increases. You can see that X-ray showing bilateral fluffy shadow. This was a confirmed case of influenza, and just 48 hours after, you could see that there was huge consolidation bilaterally, mainly peripherally. This was also a confirmed case of influenza. Not only that, there are challenges in using antibiotics. Say, for example, aminoglycoside you're using. It is not that you can't use aminoglycoside, but you have to be extra cautious because they share the common end organ damage, and which is nephrotoxicity. There may be issues in using fluoroquinolones. Of course, no chest physician, no physician, learned like you would use quinolones routinely in practice. But then if you have to use quinolones for whatever reasons, you know that there may be issues of hypoglycemia. Tuberculosis does not spare anybody, and these are a few famous, people who had co-infection. That means who were diabetic and had tuberculosis. It is worth noting that TB is a shadow of diabetes, though it is long recognized, but it is highly underappreciated. And I feel sorry. A lot of chest physicians also forget to check sugar levels, forget to ask for simple sugar testing when they are managing diabetes. And this, I showed this slide earlier, but look at this. The lungs are more vulnerable in diabetes, but yes, tuberculosis for sure. There is higher incidence of tuberculosis in diabetics, and managing tuberculosis and diabetes is hard. You need to manage both disease simultaneously. There's a remarkable historical fact which says that autopsy of diabetics in 1883, there was presence of granuloma in 50% of those autopsy cases. And before insulin, it was said the diagnosis of diabetes was death sentence, and leading cause of death was tuberculosis. During 20th century, it was said that a diabetic who does not die of coma dies of tuberculosis, especially if patient is poor, especially if diabetes control is poor. 14% of my TB patients have diabetes. 5 to 30% of diabetics get TB with rifampicin resistance, and hence drug resistance also is a problem. With diabetes, spread of MDR, XDR, XSDR remains threat, and it becomes very expensive to manage diabetes and tuberculosis together. There are various mechanisms by which diabetics are at higher risk of getting tuberculosis, or tuberculosis predisposes to diabetes, including IgT in diabetes. There is higher conversion to over diabetics. TB causes acute severe stress, fever, inactivity, malnutrition, stimulates various stress hormones. Plasma levels of IL-1 and TNF alpha are increased, stimulating stress hormones, and there are various disengagements in lipid metabolisms as well. There are a lot of physiological changes that also happen in pulmonary physiology due to diabetes, that is diminished bronchial reactivity, reduced diffusion capacity, mucus plugging and mucomodulation is altered, and reduced ventilatory response to hypoxia. With all that, let's look at how do we prevent these respiratory infections in diabetes, and we need to manage strict control of sugars. Vaccinate against flu and pneumonia. We must vaccinate every diabetic. We must vaccinate, for that matter, everybody, but diabetics for sure with influenza and pneumococcal vaccine. Raise patient awareness about it. Practice good hand hygiene and cough etiquette. Social distancing holds true not only in COVID, but tuberculosis, especially if tuberculosis with diabetes, and smoking cessation goes a long way. I would urge all you diabetologists to ask for at least twice a year X-ray chest and regular medical examination for sure you will do. And any diabetic who has sudden cough, weight loss, or any probably a new shadow coming up on X-ray must be investigated for tuberculosis. And building immunity in diabetic patients is of paramount importance. Though immunity is very complex subject, immunity would require presence of it would need genetic factors, it would need environmental factors, and it would need individual lifestyle changes, including regular exercises, good diet, and nutrition. But out of all this, I believe environment we may not be easily able to change it. Genetics is probably beyond us, at least at this date, and hence what is modifiable is a lifestyle changes. Smoking cessation, a good diet with good fruits, vegetables, regular exercises, maintaining good weight, good sleep, minimum stress, and all recommended vaccine is one quick formula or a short formula to build immunity. And there is evidence to show that various micronutrient deficiency occur in diabetics, which would alter your immunity, and that is vitamin A, B6, C, vitamin E, selenium, iron, copper, folic acid is a few of the known micronutrients which can alter immune response, and there are enough studies for this. The micronutrients would enhance insulin action through activation of insulin receptor sites, which serves as a component for enzyme systems. Chronic hyperglycemia causes significant alteration in micronutrient status. And one important component of improving immunity is to prevent and treat this deficiency. And many times, only diet may not be enough, and you need to supplement this, their diet with this combination of all these micronutrient. People with diabetes have 30% lower vitamin C concentrations. Uncontrolled diabetics and zinc may lead to decrease in, there is reduced reabsorption of zinc from kidney, and yes, there is more loss of zinc. 14 to 48% of patients may have hypomagnesemia. Vitamin B12, B1 deficiencies are known in normal individual also, and more so in diabetics, more so if they have acute infections. And hence, if you can probably have a formula which is a lot of micronutrients, especially focusing on vitamin C, zinc, magnesium, B1, B12, and folate, this would help prevent the micronutrient deficiency and would help build immunity. I would summarize by saying that diabetic patients are immunocompromised owing to dysfunction of immune system due to elevated sugar. They are more prone to infections, mainly the respiratory one. The common bugs responsible are strep, influenza, mainly the H1N1, tuberculosis, and not to miss COVID-19. They have a lot of micronutrient deficiencies, mainly vitamin C, zinc, magnesium, thiamine, B12, and folate. And a diet rich in this micronutrient must be supplemented along with smoking cessation, regular exercises, good sleep, and management of stress to improve their immunity. Thank you very much. And this way, we could help our diabetic patients. Thank you very much for your patient hearing.
Thank you, Doctor, for covering a very vast topic. I can understand the way you have to run through, but you have nicely passed on the all important points. And most important, immunity is probably at the crux. And we all have in last 18 months seen what immunity means and what is the importance of immunity. So every diabetic, as he has discussed well, I think we have to answer, we have to look at, and we have to see that immunity, diabetic status, prevention of smoking, cessation of smoking has to be followed, and screen every diabetic at regular interval for tuberculosis. This is what my speaker, Dr. Vora, has passed on. I thank him again and thank for joining us. Bye.
Thank you, sir.
Thank you very much. Thank you.
Thank you very much.
Thank you. Now we go to the last topic of this wonderful session. And as I initially told before Dr. Muruganathan's lecture, that metabolic syndrome is probably the basis of entire gamut of diseases like hypertension, diabetes, obesity, leading to all unwanted complications. And to deal with this, an interesting study, ICMR INDAB, with respect to diabetes and metabolic disorders, the lesson what we have learned from the present ICMR INDAB study. To discuss this, we have Dr. Pradeepa, and she is going to present this wonderful topic, discuss this topic. She is from Madras Diabetic Research Foundation, Chennai, which we all know that it is a premier institute where research in India, everything comes out from their center, is a sentence from Gita. So she is going to discuss this wonderful topic with us. Over to Dr. Pradeepa to discuss this wonderful topic.
Thank you. Let me share my screen. Is someone sharing?
Event people, kindly help, ma'am.
Because it says I'm not able to share. Let me see.
Just wait. Yeah.
Can you see my slides?
Yeah, definitely.
Yeah.
We can see. Please go ahead.
So thank you one and all for being here for this my talk, and good evening. And I'm really I would like to give my thanks to the Dr. Banshi Sabu and the organizing committee of RxSDI for allowing me to talk on diabetes and metabolic disorders, lessons learned from ICMR in DIAB study. ICMR India Diabetes Study, for short ICMR in DIAB, is funded by Indian Council of Medical Research, New Delhi, and Department of Health Research, Ministry of Health, Government of India. The main primary objective of this study is to determine the national prevalence of diabetes and pre-diabetes, and by estimating the state-wise prevalence of the same, and to determine the prevalence of hypertension and dyslipidemia in urban and rural India, to determine the prevalence of CAD among subjects with and without diabetes, and to assess the levels of diabetes control among self-reported diabetes. 1 minute. Yes. So the study design is cross-sectional door-to-door survey. And we have studied individuals aged 20 years and above from all the states of India and the Union Territories. So the ICMR in-depth study, we have covered 27 states, 2 Union Territories, Chandigarh and Puducherry, and National Capital Territory of Delhi. And we have recruited 4,000 representative samples from each state or Union Territories, and which included 1,200 urban and 2,800 rural. This is the largest epidemiological study on diabetes in India, which has sampled over 1,13,043 individuals. So moving on to the prevalence of diabetes. We have seen that we have given the weighted prevalence here, and we can see that there is so much of variation in prevalence of diabetes, ranging from 4.3 in Bihar to 13.6 in Chandigarh. You can see that Tamil Nadu, actually these states were done in a phased manner. So there are several phases included due to logistic problems. So the weighted prevalence here, we have shown the rural and urban. Similar to, as I said, it is increasing. It is different in various states, but you can see the in Jharkhand, it ranges from 3% in the rural area. And for urban, it is Arunachal Pradesh, starting from 5.8 to 14.2 in Chandigarh, and Tripura is the highest with pre-diabetes. With the diabetes, it is 15.5 in the urban areas. But one thing you can see that the prevalence of diabetes is high in urban compared to rural in all the states. Based on the prevalence of diabetes, we calculated the burden of diabetes in adults in a population of India, which is working out to 77.8 million. We also stratified the prevalence of diabetes based on GDP, and you can see that all the states which have higher GDP have higher prevalence of diabetes. Here you can see Bihar has the least, and you can see that prevalence is 4.3. Like for Chandigarh, it is 13.6, which has the highest GDP per capita. Moving on to the prevalence based on socioeconomic status. Here you can see in the urban areas where I have circled, the prevalence of diabetes is higher among low socioeconomic status in the states of Chandigarh, Punjab, Tamil Nadu, Andhra Pradesh, Maharashtra, and in the northeastern states of Tripura and Manipur. So when you go to rural, you can see that all the states, you can see the diabetes prevalence are higher among high socioeconomic status. Glycemic control was also assessed among the individuals with self-reported diabetes. This we found that around 30 to 35% of them had good control of diabetes, that is HbA1c less than 7. However, you can see that 45%, nearly 45% in urban rural as well, had an HbA1c more than or equal to 8%. Management was also assessed among all these self-reported individuals, self-reported diabetes in India. And we found that around 80% of them were using OHA for management, while only 3.1% were using insulin, whether be urban or rural area. The rest 10% is for OHA plus insulin in the urban, 7.8 in rural. And we can see that diet also was advised in a small proportion. When self-monitoring was assessed, we found that men were doing monitoring better compared to women. You can see in both urban and as well as rural that men were doing SMBG monitoring better compared to the women. That is 22.1% in urban compared to 16.9. It's similar, actually, there was not much difference in the rural area where it was 12.5 and 12 in the counterparts. Pre-diabetes was assessed and we found that Mizoram had the least, that is 6%, and it ranged to around 14.6% in both Tripura and Chandigarh. Seeing this huge burden in the coming years, we can say that we can expect more diabetes, conversion of pre-diabetes to diabetes coming up. Moving on to other metabolic NCD studied in the ICMR INDIAB study. Going to obesity, we assessed both generalized and abdominal obesity, and we found that the women had higher generalized obesity in urban as well as rural areas. The overall prevalence in women was 23.7 compared to 19.7 in the men. Similarly, abdominal obesity, you can see in urban, more than 50% of the adults, women studied in the urban areas have abdominal obesity. 38.8% overall had women had abdominal obesity compared to 20.3. Even in rural, it is catching up. See, you can see 33% of women have abdominal obesity. Now going to hypertension, we found that 26% overall had hypertension, but we have detected 23.4% in urban and 19.6% in rural areas. They are newly diagnosed hypertensive individuals. See, you can see the total hypertension is higher in urban areas, 31.4 compared to 23.9 in the rural areas. So we can see all metabolic disorders being higher in urban areas. Prevalence of dyslipidemia, the components were studied, where we found low HDL to be around 70%, more than 70% in urban as well as rural. You can see hypercholesterolemia, hypertriglyceridemia, as well as high HDL were significantly higher in urban compared to the rural areas. We have many studies coming up, and many of them, many data showing that migration, urbanization, globalization are all being risk factors for NCDs, which include diabetes. So we assess the effect of internal migration on diabetes and metabolic abnormalities in India using the participants from ICMR INDIAB study. So this pie chart shows the distribution of non-migrants and migrants in the study population, where you can see around nearly 66% were non-migrant rural dwellers and 19.4% were non-migrant urban dwellers. 8.4% were rural to urban migrants, and 3.8 were multiple migrants. They either migrated in between to rural, they went back to urban, so they came back that way. And only 2% were urban to rural migrants. So here, this slide shows you the prevalence of various metabolic disorders, diabetes and disorders in migrants and non-migrant urban and rural dwellers. So you can see diabetes, 14.7% in the rural to urban migrants, 34.8 hypertension, 36.2 and 50.5 abdominal obesity among rural urban migrants. Everywhere this abdominal obesity is standing out. You can see that. And you can see that urban to rural migrants, also there was significantly high prevalence. Like 47% had abdominal obesity. See, we also found that as the years of migration increased, that is to rural to urban, there was an increasing trend in prevalence of diabetes, abdominal obesity, hypertension, and as well as generalized obesity. You can see that as the years, the migration is more than 10 years, abdominal obesity is seen as 55%, 55% there. And both generalized and hypertension around 40%, and diabetes around 18.1% when the year of migration is over 10 years. We found that there's a risk that is 1.2 times risk for hypertension, 1.6 times risk for generalized obesity, 1.8 and 1.9 for abdominal obesity and diabetes among rural to urban migrants compared to rural dwellers. We wanted to see what are the risk factors which are contributing to the explaining the diabetes prevalence, high prevalence in these states. So we did this partial population attributable risk, and we found that risk factors, five risk factors, that is abdominal and generalized obesity, hypertension, physical inactivity, and low fruit and vegetable intake, that is less than 2 servings per day, could explain nearly 70% of diabetes in the population in the rural to urban migrants, while 66% could be explained for non-migrant urban dwellers, those who lived in urban areas throughout their lifetime. So what are the lessons you learned for the nation from the ICMR INDIAP study? The prevalence of diabetes is high in both urban and rural areas. Explosion in diabetes is inevitable with increasing prevalence of diabetes. As I said, in the coming years, it would increase. Only a third of those with diabetes have an HbA1c less than 7%. Only 16% of known diabetic individuals reported doing SMBG, where monitoring is the key for management of diabetes. Only 16% follow that. Insulin use is extremely low. Prevalence of hypertension, obesity, and dyslipidemia are high in all regions studied. Overall, 10.8% were migrants, that is either they migrated from rural to urban or vice versa. Rural urban migrants had higher prevalence rates of diabetes, hypertension, and abdominal obesity compared to their non-migrant rural counterparts. The risk for diabetes were 2 times higher in rural urban migrants compared to non-migrant rural dwellers. As I said, the 5 risk factors together explain nearly 70% of diabetes among rural urban migrants. So to conclude, the results from the ICMR study have important implications for cities and health systems, especially in a developing country like India. Thank you. Thank you for giving me this opportunity.
Thank you, Pradeepa, for wonderfully putting up this 1 lakh patients Indian data. And we have learned very interesting points from this presentation. And I think this is an eye-opener for all of us to manage patients clinically. And I again thank you for being with us. And if there are any questions from audience or colleagues, we'll be there for a couple of minutes.
Thank you, sir. Thank you for the question.
Any questions to Madam? I don't think, Pradeepa, there are any questions. So with this, we conclude this session, Mixed Bags. I thank all my speakers for being in time, delivering excellent home messages to everybody. I thank RSSDI Ahmedabad, our dynamic president, Dr. Bansi Sabu and his team, and hand it over back this presentation to events people with a word of thanks. Thank you very much.
Sir, you can start now.
Am I audible?
Yes, sir.
Thank you. Good evening, everyone. Thanks for the opportunity by RSTA. Today, I'm going to start with the oral paper on case report of fat pancreas in a lean person, a case of pancreatic lipomatosis. So here comes the case report. A 49 years old male who is a known case of type 2 diabetes mellitus for the past 15 years comes with complaints of loose stools for 6 months. Loose stools for 6 months, which was on and off for the first 4 months, more after taking meal diet, and last 2 months, which was daily and after each meal per drink, and 4 to 5 episodes per day. The stools on examination is yellowish in color. We are eliciting history covered with greasy, slimy layer, which is large in amount and not blood stained. No bad odor and no worms in stools. Other relevant histories like history of loss of weight about more than 15 kilogram in last 6 months, and history of loss of appetite, history of ulcer over both foot, and history of less ambulant for the past 2 months. Regarding the past history, he was diabetic for 15 long years. Earlier, he was on oral antidiabetic, later switched to insulin for 2.5 years. And during admission, he was on human premixed insulin. 12-0-10, no other comorbidities, no past history of any surgeries. And personal history, he takes mixed diet. And the important thing to rule out, to consider here is not an alcoholic and smoker and other substance abuse. And examination, conch is oriented and is thin built and malnourished. Pallor is present, leukocythemia present, and bilateral pitting pedal edema, and the vitals were stable. And the patient weight before 1 year is 63 kilogram. Now the current weight while on admission was 45 kilogram. The BMI found to be only 14.07. So on system examination, CVS, RS and per abdomen were normal. On CNS examination, there is a bilateral symmetrical sensory motor polyneuropathy present with the pressure source over the both foot and above heel. And first, we have made a diagnosis provisionally diabetic with the diabetic peripheral neuropathy with the chronic diarrhea for evaluation. On routine investigation, total count on CBC hemoglobin is 9.3 and RFT is normal, and urine routine doesn't show any albuminuria. And LFT is normal with the elevation of ALP alone, and hypoproteinemia with hypoalbuminemia. TFT is normal, and serum electrolytes found to have a hypokalemia due to chronic diarrhea. And USG abdomen, distended gallbladder and bladder, and minimal free fluid in the abdomen and pelvis. Otherwise, other organs appears to be normal, and pancreas couldn't be visualized. Fasting lipid profile is normal, and serum amyl is not elevated. During the admission, his blood sugar level is fluctuated. So second day morning, he developed hypoglycemic symptoms and seizures. And we can see that graph here, where there is a fluctuation of the blood sugar, fasting as well as postprandial blood sugar level from the baseline. And so because of this labile blood sugar level, couldn't measure the C-peptide. And for the evaluation of the chronic diarrhea, so according to history, I clearly have a stigma of malnourishment and the weight loss, like fatty stools of large volume covered with greasy, slimy layer, and each of may more after taking food and all these things. And stool examination, greenish yellow color, semi-solid, and blood and mucus were blood absent, mucus were present, and microscopic shows no RBCs, ovocyst nil, and culture were negative, and VCTC viral marker were negative. So we on further evaluation, drug-induced diarrhea, fecal incontinence, and due to diabetic autonomic neuropathy, all are evaluated and ruled out. And we come to a provisional diagnosis of malabsorption diarrhea with the history and examination and the investigation. So malabsorption diarrhea. So among the quantitative and qualitative tests to confirm the steatorrhea, so we have done a qualitative test of Sudan blood stain of steatorrhea, which comes as positive. So we confirmed it as a steatorrhea and proceeded. So on further workup to rule out the etiology of the steatorrhea, we have done CT abdomen and planned for ogiroscopy and duodenal biopsy and the fecal elastase test and pancreatic function test for pancreatic insufficiency, as we are suspecting in this case. And so first we took CT abdomen, and one remarkable thing came out in which the pancreas is entirely replaced with the, around the fatty replacement and around a Hounsfield unit of 80. So no calculi, no other parenchymal visualization is there. Entirely is clearly they depict it as a dark pancreas. So we can see here is the dark pancreas. The pancreatic parenchyma is replaced with fat. So this is the normal pancreas for the comparison, CCD abdomen, and this one is the dark pancreas, which came out in contrast enhanced CT abdomen. So on CT report, they have given it as appears bulky and parenchyma replaced by fat and minimal free fluid in the abdomen, and which impression given as a pancreatic lipomatosis. So this is the thing we have got in the journal where the few cases are published in total pancreatic lipomatosis. In here, it is in our patient that total pancreatic lipomatosis is a dark pancreas. And we have made a final diagnosis of diabetes mellitus, malabsorption diarrhea, which is due to pancreatic exocrine insufficiency, which in turn is due to total pancreatic lipomatosis. So we have given the treatment of meal plan diet with low fat diet and pancreatic enzyme replacement around 25 to 40,000 lipase units, and vitamin and iron supplementation, IV albumin, and supportive care. So regarding the total pancreatic lipomatosis, it is a rare entity, but it is usually insidious, so that it will be mostly asymptomatic with varying clinical signs and symptoms. So we couldn't easily identify that, and it should be considered in the differential diagnosis of patient with malabsorption and patient with the diabetes and malabsorption. So CT or MRI with MRCP may be the effective imaging methods used to establish the diagnosis. So usually the causes will be obesity associated with metabolic syndrome, or congenitally associated with cystic fibrosis, or Schwarzman-Diamond syndrome, or it may be associated with chronic pancreatitis also. So the thing about diabetes is the total pancreatic lipomatosis may lead to diabetes because of the exocrine as well as the endocrine deficiency. Sometimes the chronic diabetes patients may end up with total pancreatic lipomatosis. So the other way around. So the both are the possible thing. So it can be treated with dietary modification and pancreatic enzyme replacement along with diabetic control. So it is a rare case, which few cases were present in Indian journals also. So this is my case report, and thank you very much for RSSTA for giving me this opportunity to present this case in the world renowned forum. And thanks my HOD, Dr. Natarajan sir, Dr. Sandamari sir, and Dr. Sangamani sir from Madurai Medical College. Thanks a lot. Hello, sir.
Yes, sir.
So, sir, is there any question answer session, or the session will be move on, sir?
Sir, question answer session is in the last, sir.
Okay, sir. Okay. I'll wait, sir. I'll wait for the next presentation. Thank you,
Okay,
sir.
sir. Thank you. Thank you.
Thank you.
Good evening. Shall I start my presentation?
Yes, sir. Yes, sir. You can start.
Okay, thank you. Yeah. Are you able to my scene screen? Shall I start?
Yes, sir. You can start.
Yes. Yeah, good evening. Myself, Dr. Naresh Sen. I would like to thanks to the organizing committee and secretary and the abstract jury to giving me the good opportunity to present here. My topic is importance of the LV, left ventricular global longitudinal strain in COVID-19 patient with type 2 diabetes and heart failure. I'm a Polo Hospital group. See, the background is the novel coronavirus disease, COVID-19 or SARS-CoV-2 virus is responsible to the myocardial ischemia or myocarditis which precipitate the heart failure. Pro-BNP, the brain natriuretic peptide is a marker for the cardiovascular heart failure, but is limitation for the normal ejection fraction. Several studies show the importance of LVGLS is reliable, a prognostic good factor for the heart failure. Objective of the study to assess the left ventricular global strain in diabetes, cardiomyopathy with heart failure, preserved ejection fraction or low ejection fraction to assess further the cardiovascular morbidity and mortality associated with different global longitudinal strain of the LV. Method of the study we performed observational studies between the 2020-21. We enrolled 74 cases of diabetic cardiomyopathy patient with the heart failure as compared to the other COVID-19 patient without diabetes. Include the adult 49 mean of the age, the NYHA class 1 to 4, and male versus female ratio is 3 or 2. Especially the LV, global longitudinal strain was assessed the velocity vector, the 2T echocardiogram, 2 chambers, 3 chambers, and 4 chambers with the Simpson method priorly to check the LV ejection fraction, divided 2 groups, heart failure, reduced ejection fraction less than 50%, or heart failure, preserved ejection fraction is more than 50%. We check the ejection fraction with the L-diastolic volume and systolic volume formula by the Simpson method as per the 2D echocardiogram, 2 chamber, 3 chamber, 4 chamber. The advanced technology is strain imaging. Look the picture of the strain imaging, the straining of the LV myocardium with the bull-eye phenomena to check the graph, the shortening and lengthening of the LV myocardium and check the systolic function of the LV. BLS is very important to the special tracking, but it has limitations, some age vary and machine vary and sexual verification, but the studies show that less than 60% of the GLS is significant to detect the heart failure by the LV. The inclusion criteria and exclusion criteria over there is more than 80 years of the age, left ventricular ejection fraction more than 25%, HbA1c more than 7, or RT-PCR positive for SARS-CoV-2 virus positive. Exclusion criteria, We exclude in studies hypertension, coronary artery disease, CKD, hypothyroidism, congenital heart disease, pregnancy, valvular heart disease, systemic inflammatory disease, previous history of viral myocarditis like influenza and HIV and pneumonitis. Results saw the found significant result, the LV globular longitudinal strain, the LVGLS in diabetic cardiomyopathy group minus 10.6 mean as compared to the minus 18.7, the control group. LV ejection fraction was assessed of 46 mean and the 59 as compared to the control group. But in the finally result found that less than 10% of the LVGLS is significant 30 days mortality as compared to the heart failure patient. It shows that this almost 74 versus the control 70 cases. And central, we can see the mean ejection fraction 46 versus 59, and LVGLS is low down with the red minus 10 versus minus 18.7 with compared to the N-Pro BNP labels. Another table we can show, we can divide heart failure reduced ejection fraction versus the heart failure preserved ejection fraction patient in diabetic patient with heart failure or COVID-19 patient case. 20 cases with reduced ejection fraction and 54 cases with preserved ejection fraction. Look at the ejection fraction is around 40 mean, 40% ejection fraction in reduced ejection fraction of heart and 56% in preserved ejection fraction. And coming to the down of the LVGLS is around 10 plus minus 2.7 standard deviations as compared to the 12 and minus 3.6% deviations. Mortality comparison with the reduced ejection fraction and preserved ejection fraction. The chart is showing minus 10% GLS in reduced ejection fraction and minus 12.5% is preserved ejection fraction as control to 17%. This very important data show the 30 days mortality comparison between a diabetic patient, COVID-19 positive, reduced ejection fraction group versus preserved ejection fraction groups, 11% mortality in preserved ejection fraction, also as compared to the 15% mortality, 30 days mortality in reduced ejection fraction level. 30 days mortality is compared to based on another group. We divided those patients having ejection fraction less than 50% or LVGLS less than 10 or LVGLS is between 11 to 15. Is higher, mortality is 14% is less than 10. LVGLS is very significant marker. Limitation are studies, the two centers, number of samples is less, hospitalization is limited, variation about the statistical models, and the limitation apart from the echocardiogram machine in very of the models and system of the electronic part. Is another part is some AC inhibitors and ARBs, heterogeneous part of the studies are very important limitation of our study to detect the LVGLS comparisons. Discussion the SARS-CoV-2 virus infection affect the myocardium, endocardium, the heart initially, leads to the myocarditis and myocardial injury and ischemia precipitate the heart failure. In diabetic patient, especially in immunocompromised patient, diabetic cardiomyopathy describe the diabetic association with heart failure without confounding factor like CAD and hypertension developing the left ventricular hypertrophy and diastolic dysfunction initially, but we can pick the LV systolic function with preserved ejection fraction in the base of LVGLS. GLS is very important and several studies have gone for LVGLS, global longitudinal strain pattern, and preserved ejection heart failure in diabetic patient also we can pick the, and the data shows and the guidelines shows that less than 16% of GLS is very significant to detect the heart failure and pick the heart failure early detection, and less than 10% GLS is high mortality, 30 days mortality with heart failure patient in the hospitalized diabetic cardiomyopathy, not only in reduced ejection fraction, but also we found the preserved ejection fraction is very important. We conclude the study, the left ventricular global longitudinal strain has more significant value to assess heart failure. LVGLS is helpful to assess cardiac systolic function. Is diabetic patient where mostly physicians found only diastolic dysfunction with preserved LV ejection fraction more than 50%. Reference they are there. We would like to give the take home message. Early detection prompt treatment and reduced mortality in case of diabetes, heart failure, even preserve ejection heart failure, not gone for the diastolic dysfunction. Apart from that, we can pick the GLS, pick the LV systolic function in case of diabetic heart failure patient with normal ejection fraction. Thank you so much. Any questions? Respected sirs, any question?
RX events?
Dr. Aniket, you can start now.
Yeah, thank you. Shall I share my screen?
Yes, sir.
Just a minute. Hello?
Yes, sir.
I'm not able to share my screen.
Give me 1 minute. Hello, sir. We can show your screen.
Hello?
I can see your screen, sir.
But I'm not able to see my slides.
Sir, you can open PPT.
Just a minute.
Any problem, sir?
Yeah, actually not able to get that PPT on that share screen option. Actually, PPT is open in the background.
Okay, sir.
Sir, hello. Hello.
Hello. Yes, ma'am.
Yes, sir. First of all, please open your PowerPoint.
Yeah, PowerPoint is open in the background, ma'am. It's there.
Okay, come back to Zoom screen, sir. Zoom screen पे आ जाओ सर अभी आप.
Yeah, I am there on the Zoom screen, ma'am.
Okay, आपको नीचे सर green icon share button का
No, now it's there, ma'am. Now
Okay.
it was not appearing before, but now it's there. I'm sharing my screen. Can you see my
coming,
slides?
sir. It's coming.
Yeah.
Yes, perfect,
Thank
sir.
you. Thank
Just
you.
put it slides for more.
Yeah. Yeah. I thank RSSDI for giving me this opportunity to present my case in the annual event of Research Society of Study of Diabetes in India. I am Dr. Aniket Inamdar from Samarpan Clinic, Umarga. Along with my co-authors, I am presenting my study on association of fasting heart rate with fasting and postprandial blood glucose levels in Indians. I have no conflict of interest and directly starting with my background and aim. Diabetes mellitus is associated with an abnormal autonomic function. In diabetes mellitus, being it is as a metabolic disease, it usually has increased sympathetic and decreased parasympathetic activation. As we all know, diabetes and impaired fasting glucose are associated with the increased mortality, particularly with the cardiovascular causes. Several factors, including fast heart rate, have been identified to be associated with increased likelihood of having diabetes. Heart rate, as such, is a crude index of autonomic nervous system tone, reflecting the balance between the sympathetic and parasympathetic inputs. Especially in diabetics, there is increased sympathetic input, whereas there is decreased parasympathetic input. And it very well correlates with the muscle sympathetic nerve activity as well as serum noradrenaline levels. With the aim of this, our study was to establish the correlation between the fasting heart rate and fasting and postprandial blood glucose levels. For this study, 509 patients between the age group of 25 to 75 years were studied at different centers in India. The resting heart rate was recorded on finger pulse oximeter before taking the fasting blood sample. The morning blood samples were obtained by venipuncture after overnight fast of at least 8 hours, and the postprandial sugars were obtained after 2 hours after the breakfast, and the blood glucose estimation was done by the hexokinase method. The diabetes mellitus was defined in accordance with the American Diabetes Association as the fasting plasma glucose more than 126 milligram per deciliter or more, or 2-hour postprandial blood glucose levels 200 or more. The Pearson's correlation test was used for the statistical analysis. So what did we find? We found that the resting heart rate was significantly higher in patients with a higher fasting blood glucose levels compared with the patients with a normal blood glucose levels. And the difference was statistically significant with a p-value of 0.002. And not only that, it was also noted that the fasting heart rate was also significantly higher in patients with a higher postprandial blood glucose levels. Again, a significant p-value of a 0.002. In this, we can clearly see the correlation between the fasting blood glucose values along with the fasting heart rates. As we see clearly, as the fasting glucose level increases, there is increase in the heart rate. And that too happens in both cases, the fasting as well as postprandial levels. So as fasting blood glucose increases, the fasting heart rate increases. As the postprandial blood glucose increases, the fasting heart rate also increases. So coming to the conclusion, our study supports the hypothesis of a fasting resting heart rate as an independent risk factor for diabetes mellitus and as well as for impaired fasting glucose, because our study has clearly shown that there is increased fasting resting heart rate in case of both increased fasting blood glucose levels and increased postprandial blood levels. And not only this, the patients who are non-diabetics also, even the fasting is in impaired fasting range. In those patients also, we have clearly seen increased fasting heart rate. The recent study by the Framingham Heart Study has clearly demonstrated the reduction in heart rate variability along with the sympathetic and parasympathetic imbalance, not only in patients with diabetes, but also in individuals with the impaired fasting glucose. The meta-analysis of 7 published studies confirmed the positive association between the resting heart rate and the diabetic risks. A resting heart rate is generally considered as a surrogate marker for autonomic activity. And increased sympathetic nervous system activity is usually associated with acute and chronic resistance, insulin resistance. And when there is acute and chronic insulin resistance with the background of sympathetic nerve activity, it again increases the heart rate, which could be an indicator of a surrogate marker of abnormal autonomic function. And one of the most important mechanisms that has been postulated for the sympathetic activation, because sympathetic activation, when there is a sympathetic activation, it leads to the vasoconstriction, and when there is a vasoconstriction, it decreases the blood flow to the muscle, and when there is a decreased blood flow to the muscle, there will be impairment of the glucose uptake by the skeletal muscles, leading to again increased blood glucose levels. So the sympathetic activation has also been associated with the diabetes related risk factors such as reduced insulin sensitivity, high blood pressure, obesity, and with a background of subclinical inflammation and metabolic syndrome. Ultimately, the exact mechanism by which the increased heart rate is induced remains to be elucidated. But however, our findings suggest that this area of investigation may be relevant for future studies. One of the remarkable result which has clearly shown by the Framingham Heart Study that whenever there is small increase in blood glucose levels, there is a corresponding increase in sympathetic activity and decrease in parasympathetic activity. And not only this, the Framingham Heart Study has clearly shown that increased blood levels decreases the vagal tone and ultimately again increases the heart rate. So this area of investigations needs further studies, and this is very interesting area to study the autonomic dysfunction in the area of diabetes and impaired fasting blood glucose levels. These are my references, and I thank all my co-authors and the RSSDI for giving me the opportunity to present my paper in the national conference. Thank you. Sir, any questions?
Shall I start my video?
Yes, sir.
Okay. Are you my video is visible?
Yes, sir.
Okay, I'm start now. Thank you, myself, Dr. Naresh. I would like to give the thanks to the organizing committee, secretary, and abstract jury for giving me a good opportunity to present here. My topic is current approach of integrated management with allopathy and lifestyle intervention in Indian diversity group. Diabetes is a major risk factor for the cardiovascular disease and obesity, an additional risk factor for the same. The diabetes is defined as significant hyperglycemia with high limit of body mass index called obesity. And along with the obesity, diabetes could more risk of the diabetes, heart failure, heart disease, and stroke. Lifestyle intervention is primary health care consisting of the health, exercise, and education for the yoga, meditation, and diet counsel. Stress management, primary and secondary prevention for integrated approach of allopathy with alternative tools. Objective are studies performed for the good glycemic control and prevention of cardiovascular complications in diabetes type 2 with obesity to assess the importance of integration of allopathy with lifestyle intervention. to compare cardiovascular morbidity and mortality between integrated approach of allopathy with lifestyle modification and allopathy alone. Methodological of the study, the observational study, the cohort study was performed duration of the 2-year follow-up integrated program with focus on pharmacotherapy with lifestyle intervention in patients with IBCP. Total number of patients 2014, middle age of the men and women, the ratio was the man and female is a 3.2. Diabetes type 2 and obesity were enrolled. Usually care in group A divided was 1080 patients and another group divided as an integrated approach, allopathy with lifestyle intervention with 960 patients. Group B, beside a group B, the allopathy medicines, behavior counseling, education with balanced healthy diet.
Sorry, sir. Sir, I can't see your PDF slides.
Pardon? Hello.
Yes, sir.
My slide is my slide is visible.
No, sir. We have seen your screens. Just open your PPT. Hello. Sir, just open your PPT. Can you hear me?
Yeah.
Sir, we see your screens. Just open your PPT, sir. Because
okay.
So we only the some
Are you able to see?
Yes, sir. Just put it in full screen mode.
Are you able to see?
Yes, sir.
Can I start?
Yes, sir. You can start.
The group B is the integration of the allopathy with lifestyle intervention. Group B, allopathy medicines, behavior counseling education, balanced healthy diet, exercise, superimpose the endurance, the yoga and meditation and exercise training with aerobics. 3 times a week for 3 months with integrated program for 2 years follow-up program. Inclusion criteria is 18 to 75 years of age, diabetic patient. Of course, the HbA1c level is more than 7, body mass index is more than 25. Exclude the criteria, we exclude the hypertension, coronary artery disease, CKD, congenital heart disease, pregnancy, valvular heart disease, systemic inflammatory disease, and previous history of viral myocarditis. Results. Proposed lifestyle improved after 2 years program. The group and group B difference, the 95% confidence plus BMI is significantly lower than group A, and bed circumference, base stiff ratio, decrease in the heart rate, systolic pressure and diastolic pressure, HbA1c control, and significant value is p value is 0.002. The slide is showing the diagram is a body mass index improvement of 5.3 reduction as compared to the 1.5 in integrated group, and fasting blood glucose are approximately 35 versus 20 reduction, and ppvs are 56 milligram per dl in integrated group as versus compressed to the 30 milligram per dl down to the baseline, and HbA1c control is a 2.7 down as compared to the 1.9 of the baseline HbA1c in integrated group. After 2 years follow-up, the ECG and TMT changes in 2D echocardiogram is left ventricular hypertrophy, LV diastolic dysfunctions shows the chart. See the ECG ST changes now 11% versus the 16.6% in the usual groups, means the pink line as versus to the blue line, and pink group is a integrated group with the allopathy and lifestyle modification as compared to the 11.4 versus 16. ECG changes and TMT positive as 7.1% between the 15.9%, and LVH left ventricular hypertrophy in echocardiogram is 12% versus 21%, and diastolic dysfunction is 18% versus 32% in the usual group. See the importance of the 1.5 to 2 time fold improvement of the diastolic dysfunction and TMT positive and left ventricular hypertrophy, the help of the integration part. Another is unstable angina. We found 3.4% versus 12.9% as usual group, and in integrated group myocardial infarction, congestive heart failure and a stroke. The significant, you can see the pink bar is around 5.9% angina cases versus 13.9 cases in the usual group, and MI, myocardial infarction, is a 2.2% versus 8.6 in the usual group, and 2.4% congestive heart failure as compared to the 6.2%. And stroke, another stroke is 2.8% the integrated part of the group with the allopathy, and alone allopathy is a 5.4% incidence of a stroke. Is a very, very important data, is showing again part of the variable comparison, the percentage wise, the atrial fibrillation, ventricular tachycardia, and cardiac death. Atrial fibrillation in the integrated part is a red part, and the blue part, group A, with only allopathy. See, the integrated part with the allopathy is a 2.9% atrial fibrillation we found as compared to the 7.2%, and ventricular tachycardia is a 1.2% as versus the 3.4%, and finally death found the 1.8% versus 3.6% in usual group. Limitation of our study, the two centers, sample data is insufficient, statistical model is the variable, the limitation about the lifestyle modifications such as the yoga, meditation, and diet vary towards the trainer and performers. The very important. And another part is the improper or a heterogeneous implementation as compared to the standard guidelines. These are the limitation of the studies. The conclusion, conclude the studies, the regular 2-year follow-up, improvements in cardiac autonomic function, quality of life, decrease stress, improve personality and exercise score in integrated part with allopathy, better reduction of the heart rate, blood pressure, weight, BMI, weight circumference, waist hip ratio, decreased cholesterol level, and sugar and HbA1c level. Also, decreased incidence of cardiovascular events in the integrated group, 2 to 3 times decreased incidence of cardiovascular disease, 33% reduction of cardiac arrhythmias, and 50% reduction of the cardiovascular mortality, and 35% reduction congestive heart failure in integrated group as compared to the usually group. None of the have conflict of interest our side. The take-home message, we would like to the tight control of the glycemia, tight glycemic control, and control of other core-risk factor of cardiovascular disease like obesity, dyslipidemia, hypertension could decrease cardiovascular morbidity and mortality. Allopathy is the best modern medical science to control the diabetes, but it has some limitations and adverse effect of longer duration therapy. Lifestyle modification is a supportive weapon to prevent diabetes and reduce the cardiovascular complication along with allopathy medication. Lifestyle modification is an integrated that should be keep in the mind of all physicians who are treating diabetes. Thank you so much. Thank you for giving me the opportunity, and my co-authors and RSSDI chapters and abstract juries and president. Thank you so much.
Good day, friends. It's a very pleasant experience being with you, but it's even more special talking about something that is often ignored in our country. Let's talk today about an expert consensus that has been built up around the role and importance of high fiber in diabetes management, not only in India, but across the world. These are our conflicts of interest. Now, there is a growing trend in pre-diabetes, diabetes, and obesity across the nation. And this trend is accompanied by, or is perhaps due to, unhealthy dietary practices. One of the things that we tend to ignore in dietary management, in MNT, in medical nutrition management, is the importance of dietary fiber. There is a lot of scattered information available. People do pay lip service to the importance of dietary fiber, but we need to have a user-friendly guidance, and we need to have all this evidence and information in one person-friendly, reader-friendly format. So that's why 14 experts from India got together to discuss this concept, to analyze current recommendations and data, to prepare a draft document, and then to improve and edit it. Multiple rounds of discussion took place before the final draft was created. Now, what is fiber? Fiber is not homogeneous. There are different types of fiber based upon their characteristics, biochemical characteristics. You can have soluble as well as insoluble fiber. Soluble fibers are viscous and gel forming. Insoluble fibers are non-viscous. Soluble fibers are highly fermentable, while the insoluble ones cannot be digested. The soluble fibers have beneficial effect on gut microbiota, while the insoluble ones do not have too much of an effect on that. Do remember that when we think of the gut microbiota, these are trillions of cells in our gut, and we call them the second endocrine system because they actually influence endocrinology of the body. They speak with the brain, they speak with metabolism, with the pancreas, they speak with the bone, they speak with our mood, and they also listen to our brain, our metabolism, our pancreas, our bone. So that's why the gut microbiome is known as the second endocrine system of the body. It is also known as the second gene pool because actually there are more cells in the microbiome than there are in the human body. Soluble fiber also increases the production of short chain fatty acids like butyric acid, which have a beneficial effect upon metabolism. Soluble fiber comes from vegetables, berries, and fruits, also from nuts, lentils, beans, and legumes, as well as from grains. Insoluble fiber comes from whole grain, bran products, fruit skins, and legumes as well. Both have different physiologic effects. Soluble fiber delays gastric emptying, improves glucose control, improves cholesterol levels, promotes weight loss, while insoluble fiber increases fecal weight and promotes bowel motility and therefore prevents and treats constipation. It also helps in promoting weight loss. Now that we've understood the classification, the sources, and the effects of dietary fiber, we can understand the overall physiologic effects in three simple words. Number one, there are intrinsic effects, intrinsic beneficial effects of fiber. That is the pro-satiety and the pro-intestinal motility effects. Secondly, there are colonic effects. If you remember, we spoke of the gut microbiome and of butyric acid. So fiber increases fermentation. It increases the production of short chain fatty acids. And number three, we have endocrine effects through which or in which dietary fiber actually leads to increased insulin sensitivity, decreased insulin secretion, and reduction in glycemic variability. So these are the physiologic effects of fiber. But if there are effects, then is it possible that there is a chance of overdosing or underdosing ourselves with fiber? Actually, there are various guidelines. All of them are in overall concordance with each other. But from our ICMR and National Institute of Nutrition 2020, we get a guideline that our intake should be 40 grams of dietary fiber per every 2000 calories consumed. So 40 grams per 2000 calories consumed is what we should aim for in India. But different foods have different fiber contents. Some of the foods with the highest fiber content include bitter gourd at 16.6 grams per 100 gram of edible portion, soya bean at 15 grams, whole grain wheat at 12.6 grams, and oats at 10.3 grams. Amongst the nuts, almonds have the highest fiber at 11.2 grams. But this information becomes very confusing for us and we are not able to translate it into culinary medicine or culinary advice. Therefore, we promote the concept of FDN or fiber-rich diabetes nutrition. We all talk of the three macronutrients, carbohydrates, fats, and protein. And rightfully so. But to these three, we should add a fourth angle, and that angle is fiber. If we speak of fiber-rich diabetes nutrition, we will automatically be able to get a balanced diet, which will be adequate in protein and carbs and fats, but will also give us the fibers and will allow us to benefit from the physiological effects of both soluble and insoluble fibers. These benefits are well known to all of us. In diabetes, we will have better metabolic health, better glucose control, lesser insulin resistance, less triglycerides, less cholesterol, and overall, we might even be able to achieve diabetes remission, or if not that, certainly we'll be able to achieve a reduction in dose of anti-glycemic or anti-diabetic drugs. If we use too much of fiber, again we can get in trouble. Bloating, flatulence, and diarrhea, these may occur. Some people with celiac disease, for example, may have to avoid wheat. So therefore, we need to be careful when we advise a high fiber diet to our patients. If someone is not used to taking fiber at all, we should start low and go slow. Begin taking a high fiber breakfast, add salads, but go up slowly. Drink large amounts of fluid or water or other clear fluids like lemonade, and this will help avoid constipation. The way food is prepared and cooked can also change our fiber content. Unfortunately, there is no single take-home message for this. We have to understand that if you are soaking mung beans, then fiber will go down. If you boil rice, fiber content goes up. But upon boiling, the fiber content of barley, wheat, and nuts will go down. Roasting will increase the fiber content of wheat, rice, moong dal, and soybean, but will decrease fiber in groundnuts. There is one simple message, however, amongst all these complicated things that we have to remember, and that is that when you use a pressure cooker to cook food, fiber content does go down as compared to if you're cooking with microwave or in an ordinary manner. We should be aware of all these things. So now we've realized that fiber is important. We need a minimum of 40 grams of fiber per 2000 calories. We shouldn't take too much of fiber. And if we focus on home cooked medical nutrition therapy, the nutritional benefits, the health benefits are there. But we have to be aware of how this food is cooked at home. It's therefore important to work with a trained professional to create or to craft an individualized diet meal pattern for each person living with diabetes. Such a dietary advice should offer healthful food advices, direction on portion control, and also on eating patterns. And such a program will actually help ensure that fiber-rich diabetic nutrition is provided to manage type 2 diabetes. At times, formula grade or medical grade MNT, formula grade or medical grade fiber-rich diabetes nutrition can be used as a partial meal replacement or as a full meal replacement to help ensure good fiber intake and to help ensure good portion control, glucose control, and weight management. Using medical grade FDN or fiber-rich diabetic nutrition also helps maintain dietary sufficiency because you ensure that all micro and macronutrients are given in the required quantity. So this is what the decode or the expert consensus on FDN has to say. We must increase the intake of fiber. This will be done by taking more high fiber foods or fiber supplements. While both soluble and insoluble fibers are important, soluble fibers are more important from a metabolic point of view because they actually impact metabolism and they work through the gut microbiota, which is our second endocrine system. If we use fiber-rich diabetes nutrition, we will be able to improve glucose control, lipid levels, and help in weight management. So that's what we request all of us to do. Make fiber-rich diabetes nutrition an active part of MNT an active part of type 2 diabetes management. Add fiber as the fourth angle to our three macronutrients. Thank you. Good day, friends. It's a very pleasant experience being with you, but it's even
Dr. Unnikrishan, you can start now.
Okay, thank you. Am I audible and are my slides visible? I hope I'm audible and slides are visible.
Yes.
Yeah. So thank you, and glad to be here again at the RSSDI. So I'm going to talk about glycemic trends in metropolitan versus non-metropolitan cities. 1 year result of the landmarks trial. And this study, many papers of the study have been presented in this conference. And this is just one study where we see the glycemic trend and compare it with metropolitan versus non-metropolitan cities. An encore presentation following. So to introduce the topic, 77 million people in India have diabetes, and India is the second largest affected country in the world. Surveys suggest that around 10 to 16% of urban and 5 to 8% of rural population have diabetes. However, in urban India, no real information on trends in the diabetes management comparing metropolitan and non-metropolitan cities are available. Hence, this subsidiary analysis from the landmark study evaluated the impact of glycemic control, treatment adaptation on vascular complications, and of course, I'll be presenting only the glycemic management trends. So let's look at the objective, which is to identify the trends in glycemic control by looking at the change in HbA1c, fasting plasma glucose, and postprandial plasma glucose at the end of 1 year in patients with type 2 diabetes in metro and non-metro cities. So the study design, this was a 3-year nationwide multi-center prospective observational study. And this mirrors the real-life diabetes management from India, registered in, of course, a CTRI. Inclusion criteria is age 25 to 60 years, type 2 diabetes for more than 2 years, on 2 anti-hyperglycemic medications. Patients visited every 6 months, and I'm presenting the 1 year data, but it's up to 3 years. And the endpoints are both the microvascular and macrovascular. And these were the metro cities: Bengaluru, Chennai, Delhi, Hyderabad, Kolkata, and Mumbai. So 382 sites from India. And we had 5,654 people at the end of the 1 year to evaluate. So the metro cities were 2378 and non-metro cities were 3858. The age was similar, 52. Duration of diabetes was similar, 8.6, and A1C was similar. If you see the A1C change in metropolitan cities on your left versus the non-metropolitan cities on your right, the blue color being the baseline and the green color being the final value, you will see that in both metropolitan and non-metropolitan cities, during the follow-up, there was a reduction in A1C, 8.1 to 7.6, 8 to 7.6. And this difference was not statistically significant. The change from fasting plasma glucose also in the metro cities came down from 143 to 130, and in the non-metros from 142 to 129. This also was not statistically significant. If you look at the change in postprandial glucose control, the values came down from 205 to 183 in the metro cities versus 206 to 189 in the non-metro cities. And this difference, the p-value was a borderline 0.0508, but this wasn't statistically significant. So this is probably the first of its kind evidence from India, which reports glycemic trends between metropolitan and non-metropolitan cities. And this will aid in understanding disease management and treatment pattern across India. In this first year, patients from both metropolitan and non-metropolitan cities showed improvement in glycemic status and similar trends for change in glycemic parameters. These results will help us compare the longitudinal glycemic pattern across India, and data indicate that the area of residence has no major impact on glycemic parameters. Study was sponsored by Sanofi and there was writing assistance provided. Once again, friends, thank you for listening to me. It has been a pleasure participating in this meeting. I understand there are no questions from the audience, so that's fine. So I think the session is over. Thank you. So RX Events team, may we leave the session?
Yes, sir. Yes, sir, you can leave.
Thank you and all the best.
Thank you, sir. Thank you.
RX Events.
Yes, sir.
Shall I leave the meeting?
Yes, sir. Yes, sir.
Okay, fine. Thank you.
Thank you, sir.
Thank you.
Yes, Brijesh sir, shall I move the session?
Yes, sir. You can leave.
Okay, there is no question.
No, sir.
Okay, thank you.